friends, senior colleagues, and teachers. So I welcome all of you on this day 2 conference, virtual conference of oncology progress. After the successful of first day of head and neck and discussing of breast cancer, now we have 4 dedicated sessions in this conference. One is of hematology, second one is lung cancer, and third one is our gynec-oncology and GI sessions. So our program director worked very hard to design and reconstruct this meeting, and they choose the selective one of the best topics for our conference and meeting. And really, we have a very great galaxy of stars with us for today joining. And I would like to invite our program directors for this morning meeting, Dr. Chirag Desai, who is the consultant oncologist and director Hematology Clinic, Vedanta, Ahmedabad. He's also a very good friend of mine and senior, and always he guides me. And whenever I need any kind of help from him, or whenever I am in any odd hours, he just pull me and pick my hands and get me out from all these difficulties. And our session coordinator for this today program is Dr. Jitendra Pehlajani, and he is also a very good friend and near and dear to me. Dr. Chirag Desai, sir, over to you.
Thank you very much, Sandeep, for those kind words. Good day, everyone. Oncology is the fastest fastest growing field in medicine. And what we see nowadays is we see about 3 or 4 changes in the NCCN guidelines every year. And this change is reflected in change in our practice as well. And gradually over the time, we have seen that the outcome of the treatment also is year on year and decade on decade. We have seen dramatic change in the outcome with our treatment. So I congratulate Dr. Sandeep, Jasuja and the team for working so hard on the certificate program to keep all of us abreast on every sphere of oncology. And as he already said, today we are going to have 4 sessions on hematology, lung cancer, GI, and gynec oncology. We have selected some very good topics for discussion and debates, and we have very eminent faculties. So without wasting much time, I request Dr. Jitendra Pehlajani, who is the program coordinator for this session, to invite the chairpersons and begin the sessions. Thank you very much.
Thank you so much, everyone. First of all, good morning to all. So, beginning our hematological conference, I would like to invite the chairperson, Dr. Hemant Malhotra, sir, who is Director Oncological Services at Sri Ram Cancer Center, and who is also a professor and head and Department of Medical Oncology at Mahatma Gandhi Medical College and University. And I would also like to invite General Dr. Velu Nair, sir, who is Group Head Medical Services and Chief Consultant Hemato-Oncology and Bone Marrow Transplant at Apollo CBC Hospital, Ahmedabad. Welcome to you, sir. Over to you, sir.
Thank you very much, Jitendra. Thank you, Sandeep, for this excellent program. Yesterday's program was very good, and we hope that this today's program will be even better. On behalf of my very good friend, General Velu Nair, I'll take the liberty of starting the session. And good morning to everybody, all the delegates. Early morning on Sunday, I would have preferred to start the session at 11 o'clock, but we have a lot of topics to cover. So it's my pleasure and privilege to introduce the first speaker to you, Dr. Naresh Somani. And Dr. Naresh is a very dear friend of mine of more than 20-25 years. And he has recently shifted from the Bhagwan Mahavir Cancer Hospital to the Jaipur HCG Cancer Center. And Bhagwan Mahavir's loss is HCG's gain. Naresh is now Director of Oncology and HOD of Medical Oncology at HCG. He's an all-rounder oncologist, does lots of solid tumors and does lots of liquid tumors also. And today he's going to be speaking to us on updates in the management of CLL. So Naresh, the screen is yours. All the best to you.
Good morning to all of you. Thanks to Dr. Jasuja to give this wonderful opportunity. And I don't know how to have my slides from my screen. So can someone help me to get my slides? Thanks to chairpersons for this wonderful introduction. And organizers, please, can I have my slides? Yeah. So can I share it from my side? Yeah. Anyway, so can it make it on the? Is it on the full screen now? So I have been given the task of covering the few of the aspects of the treatment in the CLL, and basically to define the role of the obinutuzumab in CLL. It is being a sponsored session. Next slide, please. So when we discuss the CLL, next slide, please, we define the treatment. We should not forget that all patients do not need the treatment. And most of these patients are middle-aged or elderly. They are the frail. They have some comorbidities. And we should not forget that disease is still not under the category of the curative. Treatment still is, most of the treatment are not definitive, defined treatment. They are the prolonged treatment, continuous treatment, and patient need the long-term follow-up for the disease as well as for the toxicity management. Next slide, please. So when we understand the CLL, like most of other malignancies, as on today, extracellular, transmembrane, intracellular pathways has been defined, has been understood, has been discovered, and various abnormalities has been identified. And based on these various abnormalities, beautifully, the different molecules has been designed, had been understood. Apart from the alkylating agent, we have now moved to the monoclonal antibody like CD20 monoclonal antibody type 1, type 2. Then we have the big three inhibitor pathway drugs like idelalisib and dualisib. We have the most commonly used drug like the BTK inhibitor drugs and so on. So identifying the various abnormalities has helped us to design the various drugs as well as the various protocols or the combinations. Next slide, please. So when we treat these patients like any other patient, we need to define that what is the CR, what is the PR, what is the progressive disease, and so on. And as on today, the minimal residual disease in CLL is also being talked much and much, at least in the clinical trials. And when you are using the newer treatment like the venetoclax based protocol or Gazyva based protocol, or say, let's say like the ibrutinib or the acalabrutinib based protocols, then we always try to assess our patient that what is the MRD or what level of the MRD we have achieved for our patient. And like CML, can we go in that direction where we can stop the treatment for some time and watch and wait that is there any relapse or not. Next slide, please. So key patient profile in CLL is that we try to define that when the patient needs the treatment, and if the patient needs the treatment, is the patient younger and fit to accept the very aggressive treatment, little bit toxic treatment? Is the patient elderly, frail with the comorbidity and not so suitable for the treatment? And is the patient relapse refractory after 1 or 2 lines of the treatment? And especially the patients having the poor prognostic features, notably 17p deletion or IGHV unmutation status. So we try to define our patient in the beginning when we start the treatment, and then we see that how to make the utility or how to fit in the clinical practice these various parameters to choose the right treatment for the right patient. Next slide, please. So the prognostic information which everyone has to keep in the mind before starting the treatment, or I will say the essential part as on today to do the workup for a CLL patient, that is the identifying the prognostic abnormality like gene abnormality and the IGHV mutational abnormality, karyotypic abnormality, try to define the complex karyotyping abnormality. And this is how the FISH-based cytogenetic analysis try to define the patient in the unfavorable, neutral, or favorable type of the thing. So one has to easily remember it, the DEL 11 and DEL 17. These are the poor prognostic factors in CLL. Next slide, please. So CLL IPI has also been designed based on the various simple clinical as well as the cytogenetic based abnormality, that is the age, stage of the disease, serum beta-2 microglobulin level, and based on the IGHV mutational status and the TP53 abnormality. So these are the 6 parameters which we always try to have for our patient to do the risk stratification so that we can choose the right treatment for the right stage of the patient and at the right time for the CLL patient. Next slide, please. Next slide, please. So as we can understand it from this slide, that when we have the mutational abnormality like IGHV and P53 abnormality, the PFS, overall survival, and the probability of the survival, there is a vast difference between the various subgroups of the patient. So it is very essential that when you start the treatment or you jump for the treatment, please do these workup. But very important to understand and to remember, none of these abnormalities as on today, except the outside the clinical trial context, probably are not required for asymptomatic patient where you feel that the patient doesn't deserve the toxic treatment or treatment which has a lot of financial toxicity. Next slide, please. So evolution of the treatment, yes, we all have moved from the conventional cytotoxic drug like chlorambucil, cyclophosphamide, at least in the monotherapy form. The real advances came with the availability of the purine analogs like the fludarabine, and then came the CD20 monoclonal antibody in this field, and combining them with the either FC, making it the FCR, or with the bendamustine, making it the bendamustine rituximab based protocol. The further advances came with the availability of the proton tyrosine kinase inhibitor group of the drug. The ibrutinib was really the game changer. Then subsequently came the acyl ibrutinib, and then we have the genu ibrutinib also. And then the various B cell receptor based molecules also being developed, like the PIK3 molecules, like the BCL2 molecule, like the venetoclax. And then simultaneously type 2 engineered monoclonal antibody like the Gazyva also being developed, and they also find their suitable role in the management of the CLL. Next slide, please. So presently, we talk more about the MRD and the definite or the finite treatment for the CLL rather than giving them indefinitely. So this was the trial, just to make you aware again, that is the FC versus FCR. Next slide, please. And this trial could demonstrate that yes, both PFS and overall, there is a difference when you combine the FC with the rituximab, but yes, the toxicity is increased to certain extent. Still, it is being manageable. Next slide, please. Next slide, please. So safety profile, yes, when we assess carefully that yes, there are a little bit more toxicity with the FCR, but they are being manageable and more or less they are comparable. Next slide, please. But we should not forget that these kind of the protocols, they also have the possibility of the second malignancies also. Now, FCR has also been assessed and compared in comparison to the BR also, and basically to assess whether it's the non-inferior protocol. Next slide, please. And this trial also could show that, yes, the BR also is well accepted, very high, various clinical parameters, response criteria like CR, PR, or the overall response rate also. And this trial could also demonstrate that when we talk about the MRD negativity also, yes, a remarkable achievement is possible in the trials or protocols like FCR or BR. Next slide, please. And we all are aware about these protocols. The PFS difference was there with the 3 drugs combination, that is the FCR, but the overall survival at the certain defined point, that is the 36 months, remained the same with this protocol. Next slide, please. Adverse events, yes, there is a possibility of the second malignancy whenever you combine the drugs like fludarabine or bendamustine also to a certain extent, though it was not so in this particular trial. Next slide, please. So the rituximab in combination with the bendamustine or FC established its role, and we all have been using it till recently in the various setting of the patient, depending on the age of the patient, comorbidities, and the frailty of the patient. Next slide, please. Now, CLL 11 trial was basically further advancement with the availability of the newer molecule and being studied as the single agent chlorambucil, obinutuzumab plus chlorambucil, or chlorambucil plus rituximab. That was the stage 1, and subsequently this trial as the stage 2 part of this trial was basically to compare the GC chlorambucil versus rituximab chlorambucil. Next slide, please. And this CLL 11 trial could show us that the various clinical parameters like the response rate were much, much higher in the Gazyva based protocol. Next slide, please. And median PFS was again in favor of the Gazyva plus chlorambucil compared to the rituximab plus chlorambucil arm. Next slide, please. So PFS, if you look at the various subgroup analysis, except the 17p deletion subgroup of the patient, where it is very, very difficult to improve the result, at least with the available standard of care that time when the trial was being assessed, all other subgroup of the patient, they were being benefited by the Gazyva based protocol uniformly and significantly. Next slide, please. So the overall survival was also again in the favor of the CLL chlorambucil plus Gazyva based protocol compared to the rituximab chlorambucil. Next slide, please. So the time to next anti-leukemic treatment was again in favor of the Gazyva based arm. Next slide, please. So that is very, very important. And because nowadays everyone talks about the MRD in the CLL also. So this was also being assessed in this particular trial. And that was again in favor of the Gazyva plus chlorambucil arm compared to the rituximab plus chlorambucil. So all the clinical parameters in CLL 11 were in favor of the Gazyva based protocol. Next slide, please. So this is how we can now say that in the elderly, frail patients or patients with the comorbidities, if by any reason you want to treat the patient with the chlorambucil based protocol, then probably the chlorambucil plus obinutuzumab is the right combination for your patient. Next slide, please. So next, with the availability of the ibrutinib, and after Resonant 1, the Resonant 2 was being studied, and this could make it clear-cut that the ibrutinib is superior to single-agent chlorambucil, and that was well understood because this drug was basically the rationally being designed as the proton tyrosine kinase, which the pathway which was well understood in the mechanism of the CLL development. Next slide, please. And another trial was the Illuminate trial. Now, Illuminate trial basically studied the combination of the ibrutinib again with the type 2 engineered anti-CD20 monoclonal antibody, that is the obinutuzumab. And if we look at the various high-risk parameters like the high-risk cytogenetic, bulky disease, then we can say that compared to the chlorambucil and obinutuzumab combination, Ibru plus obinutuzumab combination is much, much superior as far as the PFS is concerned. Next slide, please. So next slide, trial is the Elevate TN, and I think my subsequent speaker will be covering this particular in the detail. So I will not be going much in the detail, but just to assess, because this is a landmark trial, acalabrutinib plus Gazyva has again been considered as one of the standard of the cares in this particular subset of the patient, especially in the frontline setting. Next slide, please. So CLL14 trial, this is one of the recent trials being published, and with the availability of the BCL2 inhibitor drugs like venetoclax, which is basically oral drug. So this has also been studied in combination with the obinutuzumab compared to the chlorambucil plus obinutuzumab. We all understand it that the dose of the venetoclax is 400, but this is gradually from the starting from the 20 milligram. We need to scale it up to avoid the toxicity, especially like the tumor lysis syndrome. Obinutuzumab is classically given as the 1 gram day 1, 815 in the first cycle. Though on the first cycle, on the day 1, you can give it as like 100 milligram, then day 2, 900 milligram also. And then subsequently, it is given as once only in every cycle. Now, important thing which I want to draw your attention is that it's a 28-day cycle. The defined treatment, it is not like your BTK inhibitor drug that you go on giving it. It's a definite treatment like venetoclax are the 12 cycles, chlorambucil again 12 cycles, and obinutuzumab are given only for the 6 cycles. So that is the beauty of these kind of the protocol. Now we are talking that compared to the ibrutinib or acalabrutinib, are these combinations better because they are limiting the financial toxicity. Next slide, please. So if we look at this trial, the efficacy parameters like the median PFS among the various subgroups, overall trial population, PFS for the IGHV mutational versus unmutated population, and P53 based assessment. All these subgroup of the patient, they were uniformly being benefited by this combination of the venetoclax plus obinutuzumab. Next slide, please. So talking about the MRD based on the ASO PCR based method analysis, if we look at the important parameter, that is the undetected MRD, that is the venetoclax plus OB combination, showed as a 47% compared to the just 7% in this. So 3-year survival looks like that they are almost matching, because that is again the beauty of the combination of the chlorambucil plus obinutuzumab. But I'm sure the subsequently the overall survival, because that is being now correlated with the MRD, various parameters are being correlated. So because MRD is much higher, undetected MRD parameters are much higher. So basically these patients are in larger perspective are being benefited by the combination of the venetoclax plus Gazyva. Next slide, please. Next slide, please. So this is how the newer combination in form of the ibrutinib, acalabrutinib, or the protocols like the venetoclax plus Gazyva are now being studied in larger population. They are now available to most of our patients, those who can afford these kind of the protocols. Next slide, please. So looking at the very recent update of the CLL guideline, the first line treatment, those patients with the DEL17 mutation positive patient, the preferred regimes are basically more and less BTK plus obinutuzumab based protocol, or venetoclax plus obinutuzumab based protocol. Other recommended regimes are obviously those, if these drugs are not available, logistically not possible, then you can give even the single agent obinutuzumab also, or genibrutinib for certain group of the patient where there is an intolerance to the ibru or acalabrutinib. And second and subsequent line treatment depends on that what your patient has been given in the first line. Next slide, please. So those patients which are the last group of the patient, that is the patient without DEL17 mutation, depending on if the patient needs the treatment indicated is there, then depending on whether the patient is elderly or the frail patient, or depending on the patients are younger fit patient, we try to choose the patient. But the rule of the thumb, the things which I easily remember in my clinical practice, that there are the 2-3 drugs which are most important as on today, that is the BTK inhibitor drug, Gazyva, or the combination like the acalabrutinib plus obinutuzumab. Venetoclax, I'm not talking much right now because this drug is officially not available in India. Next slide, please. So what is the situation in the current scenario? So are we still using the same combination, first line, second line? Looking at the various scenario, the use of the rituximab or similar drugs like the obinutuzumab, we talk a lot. There are certain relative contraindication in the COVID situation and so on, and various other modifications. So these are the parameters I think needs a long list and needs a lot of time to discuss, but one has to keep in the mind when the patient is being prescribed for our protocol in this pandemic situation. Next slide, please. So I would like to conclude that novel target agents, including the Gazyva, they are eclipsing the chemoimmunotherapy protocols in newly diagnosed as well as the relapsed CLL. Ongoing investigations are exploring novel agents and multi-targeted combination regime with the goal of MRD or eradication. Obinutuzumab remains one of the preferred regime option in the frail patient or with the comorbidity patient. B-cell receptor inhibitor drugs like BTK or other small molecule inhibitors, including BCL2 inhibitors, they are having the better safety profile, will help CLL patients in remaining progression-free throughout the disease. Next slide, please. And as Dr. Malhotra in the very beginning said that at 9 o'clock or even before that, maybe a little bit torture. So I would like to point my gun to our Dr. Sandeep Jasuja that please, after the winter, spring or summer collections, it is your duty to send us the Zoom meeting collections also, so that in the very early morning on the Sunday, we can start our meeting. Thank you once again to the organizer, the chairpersons, and all of you for careful and the patience listening. Thank you. Is there any question in the chat box? Can I see it?
Is Dr. Hemant there? Dr.
Yes,
Hemant
sir.
Malhotra? Okay, Dr. Naresh, I think a quick question from my side. How do you, use MRD in your treatment practice to strategize, your treatment-free remission periods and also follow-up maintenance, if any? How do you incorporate your MRD into your practice?
So, if you ask me the routine clinical practice for most of the patient, I'm not able to use it, or rather, I will say frankly that I don't want to use. But the kind of the protocols which we apply for a patient, like bendamustine rituximab, maybe chlorambucil based protocol. But yes, even for the single agent ibrutinib, I am not much interested for the routine clinical practice. Moving beyond that, like venetoclax plus Gazyva based protocol, or venetoclax in some other combination, or acalabrutinib plus this sort of Gazyva, then probably this picture comes, this MRD picture comes in the mind to define the treatment, to make the finite treatment, like 12 cycles of the venetoclax plus Gazyva, and then you stop it. So that is the standard parameter.
So in venetoclax, you have said it in the CL14 trial, you've said you go up to 400. We are all using venetoclax in different places, including in some cases of CLL. And you have said you go up to 400. You combine, like all of us use voriconazole to actually, step up the levels so that you don't have to, spend so much money on 400. So do you use it with the voriconazole, or you use it alone? And do you use it right through the cycle? Or what are the breaks? Is it 2 weeks, 3 weeks, and 1 week, 2 week off?
So I don't have the much experience of using the venetoclax because it's not officially available. It is available through the gray market, but I have seen the few of the prescriptions of the legendary people like you and Dr. M.B. Agarwal and Dr. Advani, that most of the patients, they are not going on the 400 milligram dose. That is the routine clinical prescriptions and the practice I see.
Thank you very much, Dr. Naresh. In the interest of time, I would like to thank you on behalf of the organizers for a very lucid and comprehensive overview on CLL. Thank you. So we move on to the next talk, which is on acute myeloid leukemia, treatment updates in AML. And we have Dr. Hari Menon, who really doesn't need any introduction, who's a senior consultant, director of HEMONC and director of BMT in the Site Care Hospital, Bangalore. And as a matter of fact, we see him on all forum nearly every week, 2 weeks. So I don't think he really needs any introduction. And with that, I would hand over the platform to Dr. Hari Menon to give his talk on AML. Dr. Hari.
Thank you, sir. Thank you, and good morning to all. It is a pleasure to be on this forum and also to be amongst friends and colleagues and mentors. So I'll start my sharing of my screen. Can I share my screen?
Yes, sir.
Okay. Is it visible?
Not yet, sir.
Is it visible now? No?
No, sir.
I have sent my presentation to you. If it
Yes,
is
sir. Can we share that, sir?
Yeah, sure. Because there's always.
While you are setting up Dr. Hari's presentation, can I make a request that we have, very lengthy topics. Each topic requires 3 or 4 days of discussion. So if you could just remind the speaker at 18 minutes that you have 2 minutes left, then we'll be, able to keep up to time. Okay, Pankti, you do that.
Sure.
Thank you.
So can I?
Yeah. Good morning, Hari. Please go ahead.
Yeah. Thank you, sir. And yes, as you said, the topic is a very large topic, and to put it within 20 minutes is going to be a challenge. Can I have the next slide, please? I mean, I cannot. Yes. So the survival of acute myeloid leukemia, as from the perspective of intensive chemotherapy, has shown a very modest improvement with the recognition of different entities in terms of being de novo AML, or for the matter, a secondary AML, or with myelodysplastic features or non-dysplastic features, and the therapy-related AMLs. And what has been a challenge has always been the elderly AML, where you will appreciate from the graph that the improvements have been, we will not even say modest in terms of what can be delivered following chemotherapy. Can I have the next slide, please? Yes. Yeah. So understanding the cytogenetics was the first step in terms of understanding who is the patient who's going to do well with therapy. And we do have, and this paper from Grimwade, which is still relevant today after 20 years, demonstrates to us the relevance of cytogenetics and the importance of the impact of chemotherapy in terms of producing outcomes in these patients. Next. So can I have the next slide, please? Yeah. So today, when we are talking about treatment of AML, it's basically boils down to the understanding of the biology of the disease, and following which one could probably look at treating AML where we may refer to predictive markers, and to treat AML where there are no predictive markers with a more broad-based kind of a treatment versus, which includes, of course, chemotherapy too, and versus treating an AML with an eye on predictive markers. Okay, and the next slide, please. Yes. Then, when you're approaching AML conventionally, you look at the morphology, you do the flow cytometry, which might give us some clue as to what the underlying cytogenetic or molecular profile might be, especially certain profiles involving NPM1 mutation, or for that matter, even the A21 translocation, etc. And then you do the FISH analysis to identify certain specific abnormalities, including deletions, 5q and 7q deletions. You look at the karyotype, you look at the diploid status, whether hyperdiploid, aneuploidy is a very common feature in patients with AML. And today, many of us look into the molecular makeup by reading the molecular profile using next generation sequencing. Next. So understanding the biology is key to the to delivery of treatment to AML. So I'll just dwell about 2 to 3 minutes on this. Next. So when you talk about molecular mechanism, we know that there is a role for altered proteins in the leukemic stem cell, and what has happened at the nuclear level. Can you just go ahead? Yeah, quickly. So epigenetic changes and transcriptional deregulation is key, and they alter gene expression. And we know that there are several epigenetic mechanisms, especially involving the DNMT3A, IDH, TET2 mutate, 1011 translocation, and also the induced DNA methylation changes, which alter the histone code in the cell. Next. And transcriptional repression, especially in the promoter islands, especially the CPG islands, and activation, it leads to activation of incorrect transcriptional start sites known as TSS is observed. Next. So this results in either hypermethylation or hypermethylation, which is associated in hypermethylation states. It's associated with promoter regions, which results in silencing of the TSS, or hypermethylation, which actually results in activation of proto-oncogenes, which increases the genomic instability. Next. So we do have some key mutations, especially the IDH1 and 2 and the TET2 mutations, which are mutually exclusive. And the IDH1, 2 mutant types inhibit mainly only the wild type TET2. And then comes the larger picture of the aberrant fusion genes like the MLL, RUNX1, RUNX1T1, and the PMLR alpha, which is associated with the APML, and which disrupt transcription of hematopoietic and myeloid differentiation. And these events lead to activation of survival signaling pathways, and independently, mutations in the p53 affect tumor suppressor pathways, enhancing abnormal proliferation. Next. So can I go next slide, please? Yes. So FLT3 tyrosine kinase domain mutants induce activation of mitogenic signaling pathways involving proliferation factors such as RAS and increased self-renewal. Next. And can I go to the next slide, please? Yeah. Yeah. So when we talk about so many mutations, there is a close interaction, and each one independently does not translate into the aggressiveness of the disease or translate into sensitivity or resistance to the treatment. It is always a combination and the interaction between various genetic abnormalities which results in the type of AML that we have to treat, inducing its sensitivity and resistance to treatment. Next. And or at the molecular level, so it's a very heterogeneous combination and numerous single gene mutations and co-occurring mutations occur. This complicates the complexity of the diagnosis and treatment outcome. Next. So can I go to the next slide, please? Yeah, I'll just go through. And when we talk about the functional overlap of AML driver mutation, there are few mutations which overlap very significantly. There are few that are independent, but you will understand that key to many of these is the involvement of epigenetic mechanisms, which combined with several other mutation status, which helps us to target perhaps the epigenetic mechanism for better outcome. Next. And as we go, as we know, as the age advances, the acquisitions of gene mutations are exponentially higher, and we will appreciate that most of the mutations involving the epigenetic mechanisms tend to increase as the age goes up, including the IDH1, IDH2, the TET2 mutation, the DNMT3A, and also for a certain extent the NPM1 mutation. Next. So in conclusion, we do understand that genetic events have variance in their strength of leukemic drive and disease constitution. It is a reflection of either a few strong drivers, particularly NPM1, or serial acquisitions of mutations of additive lower tumorigenic potential. And co-mutational interactions have a major influence that is challenging, which is very challenging to decode at the time of diagnosis. And many of these disease alleles are also found in what is known as clonal hematopoiesis, which is an independent mechanism altogether. And the presence of clonal hematopoiesis also translates into the increased incidence of relapse and refractory disease that we encounter when we treat AML patients. Next. So after this understanding, we look at treating AMLs where you don't actually have any of these predictive markers. And that is something that we encounter in our routine practice. And this includes epigenetic targeting, the BCL2 inhibition, exploiting the hedgehog pathway, and newer delivery systems. And I'll just dwell on some of the studies which have looked into these mechanisms. Next. So we do understand that way back in 1990, the difficulty in treating elderly AMLs looked at much less intensive therapies, and that's where the role of hypomethylating agents came into play, which was already in existence for a long period of time, but implementing it into the treatment of AML came into the picture. And subsequently, decitabine and azacitidine were used, and this were compared with the use of with low-dose RRC, which was one of the standard of care for treating elderly AMLs. And we'll appreciate that there was an improvement in terms of event-free survival in these patients when treated with decitabine with decreased mortality. Next. And the phase 3 study, which looked at using azacitidine with conventional chemotherapy, again reflected what was seen in the phase 1 studies in terms of improvement in the progression-free survival in these patients and time to next treatment in these patients. Next. And we do understand currently that can I have the next slide, please? Yeah, I understand that hypomethylating agents are key to the treatment, and currently the exploration of maintenance therapy with oral hypomethylating agents, which was described in the Quasar AML 001 study, demonstrated that there was an improvement in terms of progression-free or disease-free survival in these patients, in those patients who were treated on a maintenance therapy with oral azacitidine, which became a convenient way of treating these patients. Next. So this is just the graph which demonstrates an improvement in overall survival with a difference of about 9.9 months as compared to those who did not receive a maintenance therapy following achievement of remission to any form of treatment, including chemotherapy. Next. So the next aspect is, the next big thing that happened in AML was the exploitation of the BCL2 inhibition, basically looking at activating intrinsic or mitochondrial pathways of apoptosis, which is completely regulated by the BCL2 family. And the anti-apoptotic protein actually holds back the pro-apoptotic proteins, which of which BCL2 family is an important aspect. And targeting this through a mimetic in the form of venetoclax tends to send the tumor cells along the apoptotic pathway, thereby having control over the disease. Next. So this was the phase 1 study. Following the phase 1 study, where there was a 19%, almost a 19% response rates, there came the next combination wherein there was a synergism demonstrated with venetoclax with hypomethylating agents. And this was a strong signal which looked at combining these two. And there was an improvement in terms of additiveness of responses when venetoclax was combined with hypomethylating agent. Next, the next graph will was the exploiting this key concept, which was the vial A study, which was a follow-up to a combination of venetoclax with low-dose cytarabine, which was a vial C study. And the vial A study looked at the combination of hypomethylating agents with venetoclax in patients who were untreated in first-line therapy. Next. So clearly, there was something we don't see too much in AML, was the demonstration of an overall survival benefit when combining patients, combining treatment with venetoclax and azacitidine in elderly patients. And mind you, these were patients above the age of 75 and above, and also those patients who had comorbidities above the age of 60. So, clearly there was an improvement of almost 6 months in the combination arm as compared to the placebo group. Next. And more importantly, as I had alluded to, the presence of high-risk features are there in elderly AML. And there was a benefit for patients who harbored high-risk features, especially T53 mutation and FLT3 mutation, though the number of patients were low and it was not powered enough to demonstrate a statistical significance. But if you look at this forest plot, we will appreciate that there was a benefit for even the adverse cytogenetic risk group and mutational groups. So definitely a game changer in terms of treating elderly AMLs with a non-chemotherapy strategy. Yes. So the next one is, which we have known for the past 5 years or so, is the CPX351, which is a new drug delivery system. Next. So basically, it's in equimolar proportion, combining liposomal cytarabine and donomycin in equimolar proportion. And next slide, please. And this was basically a drug which was used for older patients where 3+7 regimen was always a challenge to treat these patients. What was understood is that there was an improvement in response rates, an improvement in time to progression, and also it translated into an improvement in overall survival in these patients being treated. And particularly so, the combination, the use of this agent particularly helped patients who had therapy-related AML or secondary AML. Next. And this is clearly a demonstration of its activity in elderly AMLs, where the toxicity profile, although the duration of neutropenia was prolonged in these patients, the response rates were definitely better, which resulted in a better overall survival by time since better overall survival in these patients. Next. So it's definitely indicated currently for patients treated in adult patients with newly diagnosed AML and therapy-related AML, particularly, and also AML, the MRC study demonstrated patients who had a history of MDS or MDS MPN-like picture, there was a benefit for using this new preparation in the form of CPX351. Next. The next one is to look at this, looking at the sonic hedgehog pathway. And the sonic hedgehog pathway, basically, the patch receptor is the one that actually goes through the smoothen molecule, which actually activates the genes through the glioma-1 pathway. But when you are having a drug such as glasdegib, which is a smoothen inhibitor and which interferes through the sonic hedgehog pathway, there is a suppression of the proliferation of these tumor clones, especially in patients with high-risk AMLs. So this was a concept that was used for treating patients with this specific inhibitor of the sonic hedgehog pathway. Next. So this was a phase 2 study which looked at comparing it to the standard low-dose RSC arm. Next. So clearly there was again an improvement, more so for the time to progression and the disease-free survival in these patients when using a combination of glasdegib with the low-dose RRC in these patients, thereby showing another way to treat these patients. Next. And clearly there was a benefit for those patients, unlike what it was being used for targeting the poor risk patients. There was more benefit for those patients who had a good risk and intermediate risk disease. Next. So treating AML differently with an eye on predictive markers is the next thing. Next.
Sorry for the interruption, sir. 2 minutes.
Yeah, I know. I got that information. Thank you. So you have targeting the FLT3, and this is something new. It was way back in 2017, which was presented at the New England Journal publication. We have the RATIFY study. Can you move ahead, please? This is a difficulty for me. The RATIFY study, which showed clearly demonstrated an overall survival benefit for use of midostaurin in induction therapy for patients with FLT3 mutated patients. Next. And similarly, in relapsed refractory patient, gilteritinib, which is a much stronger FLT3 inhibitor and a more selective FLT3 inhibitor, demonstrated a survival benefit. Can I go to the next slide? And this is next slide, please. Yeah. So clearly, there was a benefit for them. And the next study was using the quizartinib, which is another FLT3 inhibitor, in patients with relapsed refractory disease, and using it as a maintenance therapy in these patients. Next. And there was a trend towards a better median overall survival in these patients. Next. So I would just rush through this in the interest of time, which is the Quasar study, which looked at an improvement in survival for these patients by almost 6 months when we looked at treating them with a FLT3 inhibitor in the maintenance setting. Next. So the IDH1 and IDH2 inhibitors are the next. I will just rush through. We already know that the IDH2 inhibitor, which is an asciminib, in combination has got a profound impact in terms of improving the responses and also achieving remission state, and in some patients, even getting an MRD negative status. Next. So I just need another 2 minutes to finish my presentation. Yes. Yeah. So coming next to next slide, please. That was I've already discussed. And this was the study which looked at combining an asciminib with an hypomethylating agent. And we know that when patients have IDH1 and IDH2 mutations, they are responsive to hypomethylating agent. And there was a rationale for combining it with an IDH2 mutation. Clearly, there was a significant improvement in event-free survival when combining it with an IDH2 inhibitor. Next. And the IDH1 inhibitor, similar to IDH2 inhibitor, which is ivosidenib, also demonstrated the same pattern. Next. So Mylotarg, which was a drug which went into oblivion in 2010 and brought back based on the combined analysis of studies which demonstrated a key role for gemcitabine when, especially in patients with high and good risk cytogenetics and a favorable profile risk cytogenetics, including those patients who with the A21 translocation who may harbor the c-KIT mutation. Currently, has clearly demonstrated that the use of gemcitabine in combination with standard chemotherapy overcomes the impact of c-KIT, negative impact of c-KIT mutations, and currently should be the standard of treatment and be incorporated in all standard risk patients for treating AML, because it has increased the long-term response rates and remission rates from 50% to almost 75% in the subgroup of patients. Next. And this is clearly the graph which shows the clear demonstration of its impact in the favorable risk and also to a large extent in the intermediate risk group. Next. So in conclusion, GEO-based meta-analysis is a valuable addition to the treatment of co-binding factor leukemias and should be incorporated in the treatment of these conditions. Next. So in conclusion, the understanding of the molecular makeup and the interactions have helped understand AML better in order to prognosticate and exploit targets for improving outcomes. And the benefits have been more so for patients unfit for intensive chemotherapy and in the elderly AML. Targeted therapy is rendering a durable response, improving survival with less morbidity, and future trials will provide us answers to the use of targeted therapy in combining with chemotherapy and hypomethylating agents. And I will conclude with that. Thank you.
Thank you very much, Hari. Wonderful, wonderful talk. All of us know that AML is a subject which takes 3 days of a separate conference, and you brought out all the important points. Any burning questions, Janal Sahab? Would you have any burning question, or should we move on?
I think in the interest of time, you've done a great job for a difficult topic, telescoped everything into 20 minutes. So I want to thank you for a wonderful talk.
I just wanted to say I didn't dwell on another upcoming thing, which is the CAR T cell therapy and also the bispecific T cell engagers in AMLs. Yeah, thank you.
So that's fine, Hari. You were excused. You had a tough job to do. Thank you very much.
Thank you.
So if you could move on, the next topic in the hematology series is newer approaches and combinations in chronic myeloid leukemia. Chronic myeloid leukemia, everybody is aware, is the commonest adult leukemia in India. And to deliver this talk, we have Dr. Biswajit Dubashish. Dr. Biswajit is a wonderful person, and me and my institution are personally very, very impressed with him. And one of these days, I'll tell you the reason. He's presently professor of medical oncology at the very prestigious Jipmer institution in Puducherry. Dr. Biswas, the proceedings are over to you now. Please share your screen and carry on. And may I request my co-chair, General Nair, to do the next two and then conclude the session. I have another parallel session to do, so I may log off in a little while. Dr. Biswas.
Thank you, sir. Thank you, Dr. Hemant Malhotra, for this introduction. And again, thank the organizers for giving this opportunity. Is my screen visible?
Yes, sir.
So good morning. So now we move from CLL and AML to a different disease, which is CML, where we have tasted a lot of success in the last two decades. And my scheme of presentation would be, I would look at some prognostic markers. We'd look at some new ways of looking at the old drugs, some new drugs in the pipeline, and something related to molecular research, and I would then conclude. So if we go by the era of the CML survival, we can clearly see that somewhere at 8% many decades back to now, the survival is almost like 92%. And in fact, this almost reaches to the normal life expectancy of the general population. So if you look at our country, this is a data collected data which was published, and we could see that the 5-year EFS and 5-year overall survival seems to be slightly lower when compared to the Western, and that seems to be because of the late presentation, because of poor compliance to the drugs. Prior to this was the access to second generation TKI, with now dasatinib more generics available. I think that's becoming less of a problem. And again, a lack of PCR monitoring, which is actually, so hence we are not able to do a TFR in many of our patients. So just one word on the comorbidities. It has been clearly shown in the subgroup analysis of the CML4 that managing the comorbidity is very, very critical. And if you have a comorbidity index, Charlson comorbidity index high, then clearly the survival seems to be very, very poor. The second would be about the risk stratification. The most commonly used risk stratification was SOCAL index, which was probably prior to the TKI. And if you can see that there was a lot of emphasis on the age because chemotherapy was being used. But with the advent of the TKIs, where even elderly people are able to tolerate, a newer score like the ELTS is able to predict survival better than survival and recurrences better than the old SOCAL score. So currently, if anyone has to use in their routine practice the score, I think the ELTS would be the one which we should be using. Now coming to the drugs, there have been a lot of drugs which have been approved, with imatinib being the first drug which got approval, and subsequently the second generation TKIs like the dasatinib, nilotinib, and then the third generation with bosutinib and the ponatinib. Now, apart from that, there are a lot of other inhibitors which have come up, and one kid in the new in the block is the asciminib, which is a non-ATP competitive inhibitor, which we will be looking in detail in the next few slides. And there are some of the newer drugs which are in the trial. So coming to the older drugs, which is the second generation TKI, what has changed over the last 2 years have been the advent of this phase 2 study, which was published in JCO from the MD Anderson. And they showed that a lower dose of dasatinib, 50 mg, as frontline therapy could be as effective as using 100 mg a day. So what did they show? These patients were all in chronic phase, and they used a 50 mg of the dose of dasatinib. The rate of BCR-ABL transcript levels were at 3 months were less than 10% in 96% and less than 1% in 77%. And the cumulative rates of CCYR at 6 months and 12 months were 77 and 95% respectively, which was as good as the dasatinib at 100 mg. In fact, it was slightly better than the 100 mg dasatinib. Now, what happened to the incidence of side effects? The side effects were definitely much lower with the 50 mg drug, and the effusions were seen only in 6% with the dose with very few patients requiring the dose reduction. The responses were quite equivalent to dasatinib 100 mg, and the survival was also similar, though the OS data is very immature. So I think more and more we are looking at using 50 mg, which will definitely make use of dasatinib as second generation TKI much cheaper as well as easy to use in our patients. Next is the ponatinib. We know that ponatinib, the dosing has been 45 mg, and there has been problems with use of ponatinib, especially the cardiac effects, where you get around 4 to 5% of severe cardiac failure with the drug, and 10 to 12% of these patients can develop a grade 2 to grade 3 cardiac toxicity. So people looked at whether we could optimize the dosing of the ponatinib, and they looked at a different dosing strategy. One method of this dosing strategy was to use 45 mg of ponatinib or 30 mg of ponatinib, wait for a complete cytogenetic response. Once you have a complete cytogenetic response, reduce the dose to 15 mg of ponatinib. So in this study, they had 3 cohorts. The cohort A, where they used 40 mg. After CCYR, they reduced it to 15 mg. Cohort B 30 mg and then reduced it to 15 mg, and the cohort C they started with 15 mg only. So if you see in the non-T315I, the BCR ABL, I mean the complete cytogenetic response, it was very evident that when you use a higher dose, the CCYR rates were higher when compared to using at a lower dose. The major molecular response were almost similar between the three groups. Now, when it came to T315I, it was very, very clear that you had to use a higher dose and the lower doses did not work well. The PFS and OS in all the three groups were similar. So from this strategy, it looks like we could use somewhere at 30 mg, 45 to 30 mg for patients with T3 without a T315I mutation, and probably after a complete cytogenetic response, you could reduce it to 15 mg. If you have a T315I, then you start off with 45 mg, and once you achieve a complete cytogenetic response, you could reduce the dose to 15 mg. This seems to be, this has definitely reduced the cardiotoxic side effects of the drug. So this is a newer drug which has got an approval, and this drug is called asciminib. This is different from the normal TKIs which we use. How is it different is that on the ABL we have two pockets. One is the catalytic pocket or the place where the ATP binds, and this is the place where all the second generation TKI or the first generation, all the TKIs compete at this particular site. Now, if you develop mutation to this particular site, then the effectiveness of this drugs come down. So there is another pocket which is the myristoyl pocket, which is an independent of this ATP binding site. And if you are able to block this or bind this, you can develop a auto inhibition of the BCR-ABL. So if you look at this cartoon over here, we know that the ABL domain, if it is in a closed conformation, it is inactive, and in an open conformation, it is active. So this is the N terminal of the ABL, and when this N terminal binds to the myristoyl pocket, it forms into an inactive compound. Now, once you have a BCR-ABL translocation and there is an ABL1 auto inhibition, then this myristoyl pocket is not able to bind, and hence it is in open state. Now, what does the asciminib do? The asciminib actually goes and binds to this myristoyl pocket and then forms into a closed conformation, which makes the BCR-ABL inactive. Now, what is the data with respect to asciminib? The asciminib phase 1 study was there, and the phase 1 study showed a dose-limiting toxicity, especially asymptomatic elevations in lipase levels and clinical pancreatitis. The most common adverse effects included fatigue, headache, arthralgia, hypertension, and thrombocytopenia. And most of these side effects were manageable. And then they went on to look at the hematological and cytogenetic response. So there are two subsets of patients which we need to look at. One is the T315I mutation patients, and another is the non-T315I mutation. So in the non-T315 mutation, the complete cytogenetic response was 54%. And when compared to the PACE study, we could see that it was almost similar, the complete cytogenetic response. Now again, the major molecular response without T315 mutation was 48%, which was near similar to a molecular response, major molecular response in these patients. Now, if you go with the T315I, the complete cytogenetic response with asciminib is much lower when compared to ponatinib. So probably in a T315I, asciminib may not be a good drug if you are using it single agent. Similar was with the major molecular response in the T315I population, where the response rates were much lower when compared to ponatinib. So this drug got its approval in the phase 3 study with bosutinib and has been FDA approved currently. So there has been a lot of data coming up in the cell line, whether we could combine these drugs. And if you can actually see in this figure that in a T315I, The asciminib actually does not have much of a response, but when you add ponatinib with T315, the sensitivity to the of the cells increase, and there is more destruction of the cells. Similarly, if you actually see the dasatinib, you actually do not, they are all quite resistant. But when you add asciminib with dasatinib, they become quite sensitive, which is again seen from this cartoon. So it is clearly seen that if you combine asciminib, it resensitizes the BCR-ABL to the second generation or third generation TKIs. Now, this is a newer concept which is called a PROTAC, which is a proteolysis targeting chimera. Let's say this is your protein of interest, which is the BCR-ABL, and then you have this ubiquitin molecule, and the drug is basically a conjugate. One end you have a ligand of the protein of interest, and other is the ligand which binds to the ubiquitin molecule. Now, once this drug attaches to the protein of interest and the ubiquitin molecule becomes activated and it degrades the protein. So this is an interesting method of degrading the BCR-ABL protein. So the data, it's all in the cell culture, cell and rat models, where they have tried this new drug which is called GMB475, and it's very clear that that the protein gets degraded, and you have inhibition of all the respective pathways, which is very clear on the cell line models. Now, what are we doing about TFR? The treatment-free remission, we have plenty of studies, and we are all stuck at somewhere between 40 to 60%. Now, if you see how many of proportions of patients will achieve a TFR, if you take 100 newly diagnosed patients, at the end, I think 40% will be able to achieve TFR and 60% will fail achieving a TFR. So is there any way of improving this TFR? So there was a phase 2 study which was called the Destiny study, where there was a de-escalation of these TKIs before complete treatment discontinuation in these patients. So what they did was they looked at patients with MMR or better for 1 year. Then instead of immediately stopping the drug, they reduced all the drugs by 50% and continued it for 12 months. And after that, they discontinued TKI if these patients were continued to be in MMR. So what did they find? They found that the overall TFR was 70%. So this seems to be an interesting strategy, and probably might improve our way we are looking at the TFRs. Is there any way by which we could look at which patients would get the TFR? This was again a study done from the Hammersmith group, where they looked at developing a TFR prognostic index, and age, previous TKI resistant, duration of MR4, and transcript type was used, and they developed a kind of prognostic index. And the index clearly showed which patients could achieve a TFR and which patients could not achieve a TFR. Now, we know that once we do a TFR, most of the recurrences occur in the first few months, especially during the first 6 months. But it's also, they are also now looking at late relapses with the TFR1. So a study done in France, where they looked at for 14 patients over a period of 15 years, and they defined the late relapses as more than 2 years. And they found that around 13% of these patients can have a late TFR relapse. So what did they conclude was that they said there are two methods by which TFR loss can occur. The most common one is in the first figure, where you can see the moment you stop the TKI, there is a rapid increase in the the loss of MMR, and within 3 to 4 months, you have a complete loss of MR 4.5. Whereas the second strategy, where these patients develop a late recurrence, here actually there is a gradual loss of the MMR 4.5 over a period of time, and then it loses its MMR after 19 months. So one has to be aware that that late TFR recurrences still can occur, and it's almost around 10% of this patients which can develop this.
Dr. Vishwajit, last 2 minutes, please.
Yeah, sir. I'm just completing, sir. The toxicity of stopping this TKI, they have looked at TKI withdrawal syndrome, which was seen in the Euro Sky trial, and they found that almost 30% of these patients develop musculoskeletal symptoms once they stop the drug. Now, is there any way of targeting the CML stem cells? Yes, people are looking at that. This is an in silico study where they looked at 24 targets and they have identified some 2 targets which they could target. And one of them is the venetoclax, and this is some promising study where they found that venetoclax with the TKI showed some promising results in CML in blast crisis. Now, there are also BCR-ABL independent pathways which are in place, which are like the epigenetic pathways and other mutations which can be targeted at. Now, if you look at again the genetic makeup, it is very clear that the BCR-ABL independent pathways have a completely different genetic makeup, and probably targeting this is what is important in future. Single cell analysis is again a way way going forward, where they have looked at specifically this BCR-ABL independent group of cells which can be targeted, which can be separated, and they could be targeted. The last couple of slides on COVID-19, because we are in that situation, and this was an interesting study where they found that the intensive care and mechanical ventilation were much lower in the CML when compared to the control group. More further study needs to be done. My last slide on the take-home message is that it's very essential that comorbidity management needs to be done. ELTS score is preferred. Dasatinib at 50 mg low dose seems to be the way go forward. Exciting data. Ponatinib 40 mg, 45 mg till CCYR followed by 15 mg seems to be the better way of dosing. Asciminib is the newer drug which specifically targets the myristoyl pocket. The other targeting in the coming up are the PROTAC, and this seems to be very promising. TKI de-escalation prior to TFR, targeting the stem cell are some of those which we need to see. Thank you. Thank you, sir.
Thank you, Dr. Vishwajit, for that very comprehensive overview on the CML landscape and the new molecules. In the interest of time, there are no questions on the question box. I would just say, out of the new molecules you've said, which are the ones which are available in India now?
I think asciminib is not there, sir, still. So, so we don't have any, I think, except with ponatinib, which was the last drug. Bosutinib, ponatinib are the 2 drugs which are there.
Okay, thank you very much. There are no questions on the question box, and I think in the interest of time, we will move forward. I once again want to thank you on behalf of the organizers for this lovely talk.
Thank you, sir.
We go on to the next talk, which is by Dr. M.B. Agarwal, who actually needs no introduction. I think there's nobody who doesn't know him. He's going to talk on nilotinib, a journey of 10 years. He's the professor and head of hematology in the Bombay Hospital of Institute of Medical Sciences. And as a matter of fact, he's a teacher of teachers. He's a doyen in hematology. And I must applaud his academic, work which he's done, especially in the COVID era, even before that, for the Mumbai Hematology Group, with his lovely webinars going right round, and his perseverance and consistency has been absolutely applaud-worthy. So Dr. M.B. Agarwal is going to talk to us on nilotinib, a journey of 10 years. Dr. Agarwal, please.
Thank you, Lieutenant General Velu Nair. Thanks to Dr. Sandeep Jasuja for having me. And thanks to Dr. Vishwajit for starting the ball rolling on the front of CML. I'll just share my slide. Okay, so we're talking about nilotinib, a journey of 10 years. When you have a patient of CML, you've got 4 goals in front of you. Deep molecular response. And I think what is most important to me, for every patient achieving TFR. safety of the treatment, and to have a near normal life expectancy. I'm going to show you some cases. My first case is this young girl, Priya, 18-year-old, an asymptomatic patient with low-risk uterus, no comorbidities, strong family support, desires to go abroad for further education. How will you treat this patient? Obviously, our first goal was to achieve the TFR as she desires to go away in a couple of years. And for that, you needed a quick, deep molecular response. She had all the 4 options: imatinib, nilotinib, dasatinib, and bosutinib. She picked up nilotinib, 300 milligram twice a day, and after 3 months, the BCR level was down to 1.1, and after 6 months, non-detectable. No adverse effects. 2 years of DMR, she went off the treatment, monthly follow-up for 6 months and 2 monthly follow-ups for 1 year. Just before the lockdown last year, she moved to New Zealand for higher education, and she is now well placed in a reputed institution. What did we learn? In a young, fit person with chronic phase CML, you'll prefer a more powerful TKI, which can give you quick and deep molecular response, so that very early in the course, you can have a successful TFR. Nilotinib fulfills these criteria for a very young person who has got no underlying cardiac and thromboembolic disease. In India, the mean age of CML is 42. In fact, in our center, it is 39. What it means is that 50% of your patients are in the first 4 decades of life. And that means they do not have cardiac comorbidities. My second patient is on the opposite side of the life, this lady on the left side. 63-year-old retired army officer, seen about 5-6 years ago. There's history of smoking, alcohol, interstitial lung disease, for which she was on steroid and azathioprine. She had some kidney problem with stones and recurrent infections. She had a massive spleen, and UTA score was very high. Her kidney was not healthy, and even liver was not healthy. And how will you treat her? So at that time, we had 3 options: imatinib, dasatinib, nilotinib. She was explained about all this. She was also told about that she can achieve TFR, 40%, 60% chance. Dasatinib was considered unsuitable because she had unhealthy lung. Imatinib was considered poor choice because she had a high-risk Sokal score and impaired renal function. Bosutinib, of course, was not available at that time, and also because of her liver, we would not have used it. We gave her hydroxyurea and allowed her to think what she wanted, and she opted for nilotinib, and I think rightly so. After 3 months, BCR able 0.9, after 1 year, 0.02. There were some biochemical abnormalities, but nothing to warrant stoppage or reduction in the dose of nilotinib. After 15 months, BCR able non-detectable, and that has remained so till 2019. She decided to go off the treatment. That was 3 years after diagnosis, 2 years after DMR. Nilotinib stopped about 2 years ago, BCR able, usual monitoring, etc., and it has remained undetectable. She did get the withdrawal syndrome in the form of skeletal-muscular pain, but even that has settled. Now she's just on her treatment of ILD. She also given up smoking and alcohol. Did we learn something different from this patient? So treatment of CML-CP is always oriented towards achieving early TFR, irrespective of the age of the patient. Is the first lesson. Imatinib should be avoided if your kidney is bad. Dasatinib should be avoided if your lung is bad. And bosutinib should be avoided if your liver is bad. Move on to my third patient. And that's a prince from Jodhpur. 36-year-old, CML-CP, uterus low score, no comorbidities. Local hematologist, as usual, started imatinib 400, but he had significant GI toxicity. Drug was stopped, restarted in a lower dose, same problem recurred. He refused to take further imatinib. Came out to Mumbai for an opinion. We put him on our favorite drug, nilotinib 300 milligram BD. In this setting, you don't have to increase the dose of nilotinib. He tolerated it very well. And did we learn something different? So intolerance to imatinib is quite common. And intolerance leads to non-compliance. And that leads to inadequate therapy. And this can lead to increased risk of KD mutation, progression of the disease to AP, BC, and does not give you a chance of TFR. In fact, you will look at the last studies on imatinib, only 18% of patients achieve TFR. In our patient, of course, KD mutation study was not warranted. He was quickly moved on to 2G TKI without wasting any time. We move to our last patient. And this one is a simple guy, 32-year-old, doing a job. Low focal risk, no comorbidities. He was put on imatinib 400 mg. Unfortunately, his response was pretty bad. At 6 months, 31%. No BCR-KD mutations. He was switched over to nilotinib 400, and in this setting, this has to be 400. Excellent response, DMR by 18 months, and of course, his plan is to go TFR and get on with his life, forgetting that he ever had CML. And what did we learn from this patient? We learned that imatinib is ultimately a weak drug, and inadequate responses are quite common. In these kind of cases, you should appreciate the warning signals and move on to the next generation as quickly as possible so that you can achieve successful TFR. So friends, traditionally we had 3 options of treating, and 2 years ago we got the 4th option, bosutinib. Why do I not use imatinib as first line of therapy in my practice? It's the first generation time-tested 20 years old drug, but it's the weakest of the TKI. Molecular responses are less deep, time taken to achieve DMR is longest. Risk of progression to APBC is higher, KD mutations are more common, and above all, this niggling low-grade chronic toxicity of fatigue, pain, waterlogging, and depigmentation of the skin. This is MD Anderson data showing you comparison between nilotinib and imatinib. Complete cytogenetic response 99% versus 85%, MR 4.5 80% versus 56. At MD Anderson, no one gets imatinib as the first line of therapy. These side effects are problem. You saw in our patient GI problem. You can get this kind of skin problem. You can get this kind of puffiness. You can get edema of the legs, and you can get skeletal-muscular pain. Overall, these account for significant amount of problem with which the quality of life is affected. Interestingly, imatinib side effects don't overlap with nilotinib. Side effects profile of nilotinib is very different. So those who get intolerance to imatinib can be easily shifted to nilotinib without any botherations. And that's the paper, minimal cross intolerance between these 2 drugs. If you have intolerance, it leads to compliance problem. One forgotten toxicity of imatinib is when it is used for long term is the kidney. Be careful about it. The conclusion of this paper was imatinib is significantly correlated with chronic renal disease, both due to glomerular and tubular injury, unlike nilotinib, which does not do this. Bosutinib is the new kid on the block in India. The problem with this drug is GI disturbances. And another one is hepatotoxicity. And because of significant diarrhea and hepatic dysfunction, it leads to recurrent reduction or repeated interruptions. And that was commonly observed in the B4 trial. Dasatinib, a popular drug around because generic is available and what was discussed by Dr. Vishwanath, the low-dose dasatinib. Now, I like to caution you. Dasatinib is a potent drug, no doubt about it, as potent as nilotinib. However, it is more myelosuppressive. It produces pleural effusion to the tune of every 4th patient. It causes irreversible pulmonary hypertension in 6%, mortality of which is 80%. It also causes GI hemorrhage without thrombocytopenia and increased risk of infection, and you have to be careful in COVID area. And less discussed but often reported, 315 KD mutation is highest when dasatinib is used upfront. So the buzz around the town is what Dr. Vishwajit presented, the low-dose dasatinib. And I like to caution you because your goal is TFR. and you cannot easily achieve that with dasatinib 50 mg. The reason is this study has various flaws. A single center study, a single arm study, a very small study, having majority of patients in low and intermediate SOCAL group, very short follow-up. 25% had dose interruption. 5 were treatment failure. And the study was compared with historical control of 100 mg, not the best thing to do. So I don't think we have reached a state where with TFR goal, we should do this kind of practice in our day-to-day patient care. Now I come to nilotinib, and I call it the queen of the TKIs. Nilotinib produces quick and deeper responses with low risk of transformation to AP and blast crisis, with low risk of BCR-able KD mutation. We now have this 10-year follow-up data of ND study, and our personal experience of using this drug for 243 patients till today, and I think this is the largest single center experience from India. Approximately 2 patients we put on nilotinib every month. ND is the phase 3 3-arm study where 2 arms were nilotinib, different doses compared to imatinib. And that's the design of the study, imatinib versus nilotinib versus standard dose nilotinib. And the 10-year data was presented 1.5 years ago in 61st ASH 2019. And that's the presentation and publication. I'd like to bring your attention to this 10-year data of MR 4.5 in 60+% of patients as against 45 in imatinib. If you look at the patients who progressed to accelerated phase or blast crisis, 24 on imatinib and 11 on nilotinib. And even if you look at the second half of the study, from 5th to 10th year, 5 on imatinib and 1 on nilotinib. And if you look at the mortality, 16 died on imatinib, 6 on nilotinib. And this is the publication, nilotinib superior to imatinib as first-line therapy, conclusion of ND 10-year data. Treatment-free remission, and that's publication on nilotinib 2019. And as was shown to you just now by Dr. Viswajit, all these drugs lead to at least about 50% of treatment-free remission. And this is a study going right up to 200+ weeks. Once you get stabilized, probably after 2 or 3 years, the relapses are almost unheard of. Coming to nilotinib as a second-line therapy. For most of the patients, if it is due to failure of the first line, you will do the KD mutation study, and that will tell you when nilotinib can be used freely, when it can be used carefully, and when it should not be used. And once again, in a stop studies TFR, after second-line nilotinib, and you have the same percentage, 50% study going on beyond 200 weeks. Pediatric CML, and that's the data on pediatric CML by the master, none other than Nobuka Hizaya. And that's the MMR data, which is to the tune of 60 to 72% depending upon newly diagnosed versus relapsed patients. If you look at the event-free survival of newly diagnosed, 36, and relapse refractory, 36, it's almost to the tune of 90 to 95%. And the pediatric dose of nilotinib is 230 milligram per meter square twice a day. And once again, it is our preferred drug because we will like to put as many pediatric CML into TFR as possible. Miscellaneous part, this is nilotinib in accelerated phase, and this is nilotinib in blast phase. So these are the nilotinib studies for CML, first line, second line, and pediatric. ND, study 2101, CMR, and dialogue, which is for pediatrics. And these are TFR following nilotinib, freedom, stop, path, and goal. Current indications for nilotinib, US FDA approved, include adult and children, frontline and second line. What did we see today? We saw the ND trial, nilotinib first line. We saw nilotinib in second line. We saw discontinuation study, freedom, stop, and we saw nilotinib in the pediatric subject. I conclude my talk by saying, in cancer, whether it is CML or any other. You need to hit hard, hit early, have the best option, and have the best choice. Nilotinib is the game changer. We now have a Nilotinib TFR club with 48 members in it. And this morning, the secretary of this club comes and gives me this little piece of Happy Father's Day, saying that you have taken us off a drug and we feel now we are normal off treatment. Well, thank you so much to all of you to give this opportunity to speak to you.
Thank you very much, Dr. Agarwal. As usual, in his inimitable style, he has delivered his talk so crisply and bang on time, bang on time. So I will label him as the father of the queen of the CML drugs, that is nilotinib. And I have, since we have little time, I have 1 or 2 questions for you, sir. You have a large cohort which you have treated with nilotinib over 10 years. What is your TFR in your experience, in your group? What is the frequency of TFR, number 1? Number 2, how many of this were naive cases where you started them upfront, and how many of them were changeovers?
So these 243 cases are our naive patients. I have not included in these 243 patients the patients who were put on nilotinib as a second-line therapy. Our TFR rate cannot be sort of calculated very easily, because there are a good number of patients who I think are eligible for a going off the treatment, but are hesitant in going off the treatment because their quality of life is so good that they just don't want to do it. They're also uncomfortable coming every month for 6 months, every 2 months after that, for the rest of their life. So there are various reasons where I feel uncomfortable in calculating any figures from my study.
Thank you. And one last question from my side. Have you had to take off any of your patients from nilotinib because of side effects or intolerance?
The commonest reason for taking off nilotinib in the early part was the cost of the treatment. And the cost of the treatment now, as you know, with the PAP has come down to almost about 7,000 to 8,000 rupees. So no more that is the indication for taking patient off the treatment. Few patients we had to take off because of biochemical changes which were very significant, or they had ECG changes. But because of the younger age of the patient and very careful selection, the total percentage of patients where we have stopped nilotinib is just about 12 to 13%.
Thank you very much, Dr. Agarwal. Once again, there are no more questions. We'll move on in the interest of time. On behalf of the organizers, thank you for a wonderful talk. We come to the last talk of this session, and that is we have the Elevate study and update of acalabrutinib in the management of CLL by Dr. Sharad Damodar. He is a good friend of mine. He's the vice chairman of the Oncology Services and senior consultant and head clinical director of Hematology and BMT in the Mazumdar Shaw Medical Center in Bangalore. I won't stand between him and you. I would now invite Dr. Sharad to start his talk. The platform is yours, Chirag.
Thank you, sir. Thank you, Sandeep, for this opportunity to make this presentation. I won't waste too much time. We'll straight away get on to the talk. So what I'm going to do is just present data from the Elevate study of CLL, acalabrutinib in CLL. This is basically the ASCO update, which was presented about 2 weeks ago. So we have the data in treatment-naive CLL and in the relapsed refractory setting. So now BTK inhibitors are clearly the drug of choice in most of CLL treatments. Clearly with the cost of ibrutinib coming down, I think a lot of us have started using ibrutinib, and clearly we've been building our experience on that. Initially, we only had the original molecule accessible. You've got the generics also now available. And clearly people are beginning to have experience of its efficacy and also its side effects. So on that background, I will just look at some of these landmark studies which have given us data on the 24-month PFS in CLL when drugs have been used as first line. Now, clearly, you can't compare between trials because of differences in design, demographics, and other criteria. But this just gives you a gist of what we're looking at from a response rate. So the first one is the Resonate 2, where you've got ibrutinib versus chlorambucil. So you've got the 2-year PFS of 89 versus 34%. In the alliance where you had ibrutinib versus bendamustine Ritux. Now, Benda Ritux is something which all of us have used, and that could kind of seem as your baseline reference for us in our country. So this is a comparison of 87% versus 74%. In the Illuminate study, which was ibrutinib plus obinutuzumab versus obinutuzumab plus chlorambucil, you can see a difference of 85% versus 38%. And in the Elevate study, where they actually looked at ACAL plus obinutuzumab, ACAL alone, and then this was compared with obinutuzumab plus chlorambucil. So 93% in the AG group versus 87%. And if you just looked at it across the board, this 87% single agent ACAL kind of compares with the ibrutinib single agent in the Alliance study. And the chlorambucil obinutuzumab data seems a little better from the in comparison to the Illuminate data. Now, CLL is a chronic disorder. We are still not talking about cures in it, even though we are talking about MRD, more in a research setting, not yet as a practical thing in our country. So clearly, if you look at the Western distribution, median age is 72, it may be a little lower in our country. That's what you gather when you talk to people. And because of the older age, clearly there are comorbidities which are invariably present, and there's data to say it could be as high as 90%. So we're looking at a chronic disease, currently not curable. You need long-term therapy. There are debates on finite versus infinite. Whatever you're using, you certainly would want to look at safety and toxicity profiles along with efficacy data. So when you look at the real-world data on ibrutinib, when it has been used, if you just look at the clinical practice outcome data, you see that in about 2 out of 10, close to about 20% patients, treatment was discontinued because of AEs. And in another 20% of patients, it was you had to dose adjust or dose reduce. And whenever you cut down dose, you have issues of efficacy. So there's a little bit of a balance there. And this is the real world data. So which means in about 4 out of 10, you're either having to discontinue or having to dose reduce. And this is one of the issues when you're using this generation of drugs or the subclass of drugs, which have toxicities which are known to be in the form of cardiac toxicity, bleeding issues, and vice versa, which I will come to a little later. Now, when we compare head-to-head acalabrutinib versus ibrutinib, the advantage of ACAL is that it's more targeted specific, and because of its higher selectivity, you have less off-target hit on the other kinases, and thereby you have lesser side effect and lesser toxicity profile, and that's the advantage of ACAL versus ibrutinib, and that's what we're kind of looking at when you look at efficacy and side effect reduction. So that's what is the difference between the two molecules. And on this background, we have data from the ASCO update where they presented the 4-year follow-up data on ACAL obinutuzumab versus obinutuzumab chlorambucil. The 4-year follow-up data. Initially, we had the 28-month follow-up data, which actually got updated this time. So this was to look at the long-term efficacy and safety of ACAL plus obinutuzumab compared with obinutuzumab plus chlorambucil. It had 3 arms which were randomized. You had the single arm, which was the monotherapy, you had in combination, and then you had the comparator as obinutuzumab plus chlorambucil. That was the fixed DUG arm, the O plus G of about 6 cycles, whereas ACAL and was continued for this time period. And the data cutoff was on September 11, 2020, when the analysis was done. So basically, you had 2 endpoints. The primary endpoint was looking at progression-free survival with an independent reviewer committee which assessed it in the 3 subsets. Secondary endpoints were also looked at, where you looked at PFS, overall response rates, overall survival, and the ability to achieve MRD negativity and safety profiles. Now, there were 500 odd patients. This was basically from about 18 countries, enrolling about 140 centers. And this was the split up there of about 179, 179, 177 into the 3 arms. Median age 70. About 15% were either 17p or mutated TP53. The unmutated subset, which is higher risk, was about 60 odd % in this group. So clearly you had a higher unmutated subset here. The median study follow-up was 46.9 months. Ongoing treatment in the A plus O arm is 74% and about 70% in the A arm. Clearly, the O plus G was a specific 6-cycle and thereby it was discontinued, whereas ACAL just continued in the other two arms. The discontinuation rates, if you look at it, is about 25% in the A plus O arm versus 30% in the single agent arm versus 22% even in the obinutuzumab plus chlorambucil, which is only about 6 cycles. So there also you had about 22% discontinuation rate. If you look at the commonest adverse events, 12% to about 14% was the AEs. And if you looked at the reason being progressive disease, 4%, 7%, and 1.7%. Obviously, because there is longer follow-up when you're on the drug for this, you had a higher incidence of progressive disease coming up as you were on that treatment. Median treatment exposure was 46.6 months in the A plus O arm, 45 months in the A arm, and about 5.6 months in the obinutuzumab plus chlorambucil arm. There was also a crossover allowed for this subgroup to move to the single agent ACAL arm. When we look at the results, we were basically looking at the PFS, which is there in the subsequent graph. The overall response rate was significantly higher in the A plus O versus the O plus chlorambucil, 96 versus 82% with a significant p-value. Even in the single agent acalabrutinib arm, there was a higher overall response rate of 89.9 versus 82.5 with a p of 0.035. The CR and the CRI, which is incomplete marrow recovery, were again higher in the A plus O versus the chlorambucil obinutuzumab arm of 30% versus 13%. And this actually increased when you compared it to your initial analysis at 28 months and subsequent follow-up at the current 48 months. The response rates improved from 24 to 30% in the A plus O arm and 7 to 11% in the single agent acalabrutinib arm. If you looked at the MRD rates, they were again higher in the A plus O compared to the O plus the chlorambucil, 38% versus 9%. The median overall survival was not reached in the above subgroups, and clearly the overall survival rates are highest in the A plus O arm. So this is the graph to just show you the overall progression-free survival. 87% in the ACAL plus obinutuzumab versus 78% in the single agent ACAL and 25% when you compared it with the obinutuzumab and the chlorambucil arm. So you can see clearly the difference in the progression-free survival. What about when you analyze the subsets of people who are high risk, which is the deletion 17p and the TP53? Again, 75%, 76% in the ACAL arms versus 18% in the obinutuzumab chlorambucil arm. So clearly, even in this high risk subset, you're getting about 75% response rates. When we looked at overall response rates, when you subdivided this group into the ones who achieved CR, PR, stable disease, and progressive disease, about 30% achieved the CR in the A plus O arm, whereas it was 11% and 13% in the other two. You had a higher subset who achieved a PR in the A arm, that is the single agent ACAL arm of about 80%, which then translated to an overall response rate of 89.9% in that arm versus 82% in the chlorambucil arm. Overall response rate of 96% in the A plus O arm. So this is the graphical representation of the same data. If you just look at overall response rates, they're all kind of similar there at 93, 88, and 88. The the point to bring home is the progression-free survival rates. Now, events of clinical interest, clearly you want to look at side effects when you're using a BTK inhibitor. And clearly you had more side effects in the ACAL arms, both arms, compared to the obinutuzumab arm. You had more cardiac events, bleeding, hypertension, infections, which clearly, because you're using the drug for a longer period of time, you would also have more side effects. So this is what was the outcome from this data, where you clearly had all of these being much higher when you compared it versus the obinutuzumab plus chlorambucil. But then when you looked at it between the two, between the ACAL and the A plus O, the difference wasn't too much. It was almost similar, except for a little bit of higher incidence of infections. So end of the day, when you looked at safety data, this was generally unchanged. So the point to drive home here is that the safety data did not change significantly when we looked at the follow-up from the 28-month to the 48-month study. Most of the AEs seem to come on within the first 1 year, and subsequently they tend to plateau. When you looked at the incidence of neutropenia, that was higher in the chlorambucil obinutuzumab, whereas the AEs of headache, diarrhea, fatigue, arthralgia, and cough were higher in the acalabrutinib arm. So to conclude, at the end of 46 months with the follow-up of about 46.9 months, clearly you had a significant difference between the two arms comparing ACAL, obinutuzumab versus obinutuzumab and chlorambucil. You had better progression-free survival rates. There weren't a significant difference in the high-risk subset of patients. You looked at safety issues. You clearly had more of them in the ACAL arm, but clearly the trade-off was that you had better progression-free survival. Now I'll quickly run through the relapse refractory setting data. So this is what we really wanted to see, that now that we've got ACAL data in the upfront subset, you want to compare that in the relapse refractory setting when you're comparing it with ibrutinib, which most of us have used and have some experience. So this is again another 500 odd patients, again from about 18 countries, 100 odd centers. They looked at previously adults previously treated CLL requiring therapy, the presence of 17p or deletion 11q, and an ECOG performance status of less than or equal to 2. So this was the high-risk subset who had a relapse, who did not have a previous exposure to a BTK inhibitor, a PI3 kinase inhibitor, BCR inhibitor, or a BCL2 inhibitor. And they were randomized to either ACAL 100 BD or ibrutinib at 420 once a day. So the primary endpoint here was to look at non-inferiority between these two. The secondary endpoints being the side effect profile, which was atrial fibrillation, grade 3 infections, transformation, Richter's transformation, and overall survival. So if you look at the demographics here, they are very, very comparable. If you look at the age, the distribution, the ECOG performance score, about 50% of them had bulky disease in both groups, RISE stage 3 or 4, about 50% in both groups. If you looked at the 17p, 11q, similar distribution in both groups. If you look at the IGVH, unmutated status, 82% in both subsets. So 80% odd, unmutated in both groups. So they were comparable. If you look at the duration of follow-up, similar duration of follow-ups. The important point here is how many of them discontinued treatment, and you could see that about 50% of them discontinued treatment in both arms. 52% in the ACAL arm, 58% in the ibrutinib arm. The reason for discontinuation, primarily disease progression in 30% in the ACAL, 25% in the ibrutinib, whereas adverse event was more in the ibrutinib arm of 22% versus 15% in the ACAL. So more people discontinued the BTK inhibitor in the ibrutinib arm as a result of an adverse event, whereas there was a little higher disease progression in the ACAL arm. If you look at the endpoint of being the progression-free survival response rates, you can see that they are very, very comparable. The curves all literally run on top of each other. So equal efficacy there. If you look at the hazard ratios, looks all of them are kind of sitting on that middle line, except for maybe the ones who had an ECOG of 2 and the mutated people who did a little better in the ACAL ibrutinib arm, but this is very small numbers here. If you look at the secondary endpoint, which is a side effect, if you look at the incidence of atrial fibrillation flutter, which is one of the worries when somebody is on a BTK inhibitor, 9% versus 16%. So clearly a significant difference between the two with a P value of 0.02. If you look at the transformation, Richter's transformation or grade 3 infections, comparable in both arms, and the overall survival, again, absolutely comparable between the two. So safety issues, when you looked at it, when you split and looked at the AEs, the grade 3 AEs were about 68% and 75% in the ACAL versus ibrutinib arm, and AEs leading to treatment discontinuation, 14% versus 21% when you compared ACAL versus ibrutinib. Now, the most common AEs, what we know from our experience with ibrutinib is that diarrhea is the commonest in about 46%, whereas headache and cough is the commonest thing described with ACAL ibrutinib. And this usually happens within the first 1 year and tends to settle after that. Hypertension, higher incidence in the ibrutinib arm, arthralgia, higher incidence, bleeding risk, again, higher in the ibrutinib arm. When you looked at specifically bleeding events, it was about 50% compared to 38% in the ibrutinib arm. And again, atrial fibrillation, higher incidence of 16% versus 9% when you compared it between ibrutinib and the ACAL arm. Another thing which we've seen is, again, the incidence of infections, hypertension, and pneumonitis, which is described with ibrutinib. I've actually had a patient who's developed that. That, again, is much, much lower in the ACAL arm. So when you look at these graphs to show you those side effects, you can clearly start seeing that in the ACAL, most things tend to plateau between the 12 to 18 months. So the incidence of atrial fibrillation, hypertension, again, between 12 to 18 months, bleeding events, again, plateauing around the 24-month period. The incidence of diarrhea and arthralgia, again, tending to plateau off within that 24-month period. So this is the take-home point, that most of these things happen within the first 1 year and tend to plateau within the second year. So the key conclusions from this was that ACAL was non-inferior to ibrutinib at the primary endpoint of PFS. It demonstrated lesser AEs, lesser cardiovascular side effects clearly there, lesser incidence of hypertension, and again, lesser incidence of diarrhea, arthralgia, and bruising, and clearly with equal efficacy. Last few slides to quickly run through all the pooled data on the cardiovascular events described in patients who had monotherapy with ACAL. Yes, I just have 1 minute left. I'll just finish on that last slide. So there were 4 studies which were collated. and looked at about 700 odd patients and finally found that the incidence of cardiovascular side effects was about 17%. That's about 129. And if you looked at them, when you split them up, the incidence of atrial fibrillation, palpitation, tachycardia, and sinus tachycardia was in the 2 to 4% range, and most of the others were less than 1%. So when you put all this in totality together, clearly the incidence of cardiovascular side effects are much less. So to conclude, the efficacy seems equal. Clearly, the side effects are much lesser in ACAL versus ibrutinib, which has been demonstrated in both these. And clearly, we think that this is something which is of use to our subset of patients. I'll end on this. Thank you for your time. Thank you, sir.
Thank you very much, Dr. Sharad, for that extensive data presentation. So in the interest of time, I'll just say I have just one comment. So in CLL, you did make a mention about the curative intent. We are moving towards a functional cure, and Elevate is one such bridge. So right. That's one thing we are seeing. And the other thing was, A plus O versus A, yes, in terms of PFS, MRD, yes, and adverse effects.
Yes, sir.
It's very iffy, the plus minus situation, because there isn't a
right.
very significant difference. But
right.
there would be a difference in cost. There would yes. be a difference in compliance. So your right. quick comment on A plus O versus A when it comes to practice, if at all.
Yeah, this point actually we discussed with one of the presenting authors during his talk, and he really couldn't tell us much that the addition of O would actually make a difference even in the high-risk subset. I, in fact, asked him about the high-risk subset also, and he said, really, no. I think the take-home is that A would be good enough, sir.
Thank you. Thank you very much. We've had a good Sunday morning session, and we finished all the 5 talks. All the speakers have been great, wonderful talks. And with that, I would end this session by thanking all the speakers, all the delegates, and the organizers, especially Dr. Sandeep and his team, for having given me this opportunity to chair this session, and my co-chair who left just 2 talks ago. Thank you very much. Have a good day. Have a great conference. Jai Hind. Thank you.
Thank you so much, sir, for your words and your guidance. I would like to thank all of you, chairperson and the speakers, and I will hand over the mics to the organizers.
So thank you very much, the speakers and the chairpersons and the directors of the previous program. We had the wonderful hematology sessions on Sunday morning. Now we have equally exciting session about lung cancer over next 2 hours. And the director for this program, Dr. Satya, Dattatreya, who needs no introduction, he is the eminent oncologist from Hyderabad, and he is a voracious speaker. He is sought after in every academic sessions across the country, across the globe. So I will hand over the session to Dr. Palanki. He will invite the chairpersons and begin the proceedings.
Chirag bhai, thank you so much. And thanks a ton to the organizers for making me a part of this esteemed conference. So chemotherapy combinations or chemotherapy agents in non-small cell lung cancer have reached a plateau, but we now know what's made inroads. What's new in oncology progress is incorporating immunotherapies. So immuno-oncology molecules with chemotherapy or IO combinations is the new progress in oncology in non-small cell lung cancer. To take that forward and to focus on immuno-oncology molecules in non-small cell lung cancer, I have 2 very esteemed chairpersons to take over the proceedings. Dr. DC Doval sir is a very, very respected senior colleague of mine who is the chief of the medical oncology and the breast and thoracic services at the Rajiv Gandhi Cancer Institute. Doval sir, a warm welcome to you. Dr. Bhavin Shah sir is a very, very close senior to me from my GCRI days. He's from Ahmedabad, who also has keen interest in solid tumors, non-small cell lung cancers, and transplantation as well. He would be also chairing the session along with Dr. DC Dole. Sir Bhavin bhai, a warm welcome to you.
Thank you, Satya.
Thank you, Satya. And I think without wasting much time, we would like to start the session on lung cancer. And I would first invite Dr. Amit Verma from Delhi. He'll be speaking on non-small cell lung cancer biomarker testing recommendation. Dr. Amit Verma is from Max Hospitals, Delhi.
Hi, everybody. Good morning. And I thank the chairperson and the organizers
for this wonderful opportunity. And I just want to make sure that I'm audible to everybody. Is it all okay? All set?
Yes, you are.
Yeah.
Okay.
Yes, yes. Please go ahead.
So yeah, so I will be talking about the biomarker testing recommendations, and we all understand the histologic as well as the molecular heterogeneity in lung cancer. And you can see there's a plethora of targets what we are looking at, and you can see that these are of important utility where we can apply them in the clinical practice. So matching the molecular target therapy in lung cancer is the key beyond chemotherapy. And we are adding newer drugs to each target every year with better potency and better efficacy. So you can see that we have newer drugs on the market for the NTRK, which is also a you can say, tissue agnostic biomarker for various cancers. And we have drugs which are now eligible in lung cancer as well. So we have understood that in the past, the combination chemotherapy, platinum doublets, platinum with the bevacizumab, and followed by the TKIs and the specific targets or specific TKIs for the specific targets have changed the overall survival. And this is the landmark thing what we have seen over the decade, and this is going to continue for next decade. I can assure you that. And this survival based on the molecular actionable approach or molecular target therapy have given us a significant jump in the overall survival. So regarding the oncogenic drivers in lung cancer, what we currently use in clinical practice is the EGFR, ALK, ROS, and PD-L1. And we have all adapted to all these particular biomarkers. But there are certain other biomarkers which are also recommended by the NCCN guidelines, but not are as a part of our routine clinical practice like BRAF. And there are new biomarkers which are also coming up to pick up the rare alterations, and we have drugs for them. Mutation testing in the lung cancer has evolved over the years. If I see the NCCN guidelines in 2018, they used to recommend the EGFR, ALK, ROS, BRAF testing and PD-L1 testing for the non-small cell adenocarcinoma. And also for the squamous cell carcinoma, they were considering EGFR, ALK, ROS, and BRAF and PD-L1. So PD-L1 was recommended, but EGFR, ALK, and ROS and BRAF were to be considered. So in the span of 2 years, what we have seen that they are starting recommending border molecular profiling panel to pick up more alterations beyond these 4 alterations, EGFR, ALK, ROS, and BRAF. And now, in the recent past, they have included the MET exon 14 skipping testing as well as RET testing. So this is the change what we are seeing. And I think this list will add on in the next couple of years more. So if you talk about the summation of the recommendations by the NCCN guidelines, they categorically recommend EGFR, ALK, ROS, BRAF 600E, MET exon skipping mutation, and RET testing for all non-squamous cell lung carcinoma, and PD-L1 testing for all non-small cell lung cancer. And for squamous cell cancer, the testing is recommended for patients who are young, never or light smoker, or if the biopsy specimen is small enough or mixed histology to pick up all these alterations. So what they recommend is a multiplex platform, a border platform. Primarily it is the NGS, but there are various other multiplex platforms which can pick up alterations beyond the ones which we have just mentioned, including the ERBB2, that is HER2, as well as NTRK. And the advantage of doing the molecular multiplexing that you may get recommendations for all the genes within 10 to 14 working days if the biopsy is small, and it will save time as well as money for the patient. If you talk about the guidelines beyond NCCN, that is the CAP, ISLC, or AMP, they also recommend EGFR, ALK, and ROS. But the consensus opinion also recommend for the broad molecular testing, which will include the BRAF, MET, HER2, and BRAF. And they also recommend, if in the cost constraint setting, If EGFR, ALK, and ROS are negative, then they can go for the reflex BRAF method to do red testing on a larger testing panel. So tissue sampling is a key to maximize the chances of detecting underlying molecular aberrations. And we all face all these problems. And the recommendations coming from the various experts is to recommend a pre-procedural discussion at multidisciplinary tumor board. So practically speaking, we do not do that thing in a routine practice, but yes, we do interact with our radiologists or surgeons, but not in a systematic fashion. And this is something which we can incorporate in our practice, where we document all the possibilities, the site of biopsy, where the yield can be maximum. And again, we have to involve the pathologist upfront so that the pathologist can use that specimen to store in a fashion that the yield of the genetic test comes handy. And also, pathologist is the one who is going to see the quantity of the tumor and can prioritize whether to do EGFR ALK first or should go for a border gene panel. So I think there's a big need of surgeons, radiologists, oncologists, as well as pathologists to come on board to make a call in the sequencing of the test and the choice of test to be done for a patient. We have a number of molecular technologies available, which we all are using in clinical practice, that is FISH, IHC, real-time PCR, and the NGS. So if you see that they have some limitations, it's quite not easy to have all the information with all these techniques. And that is the reason why broader gene panel testing is recommended. Besides the cost for the sequencing of these tests, the important aspect is the time and the limitation of the tissue. So recommendations regarding the IHC, we are currently using the ALK IHC to screen the patients besides the FISH, but it can also be used for BRAF testing, as well as c-MET overexpression, as well as ROS fusion actually. So IHC can be used for screening. And if you find any IHC positive, a confirmatory FISH is recommended to be sure that is as per the guidelines. Parallel sequencing allows you to pick up all these alterations and all variants of alterations, including the point mutations, insertions, deletions, as well as copy number variations, and as well as fusions. So parallel sequencing is the key which I'm trying to emphasize today. We understand that the single testing approach involves multiple steps and it involves a lot of tissue. If you talk about the biopsy followed by histology, then classification to adeno and squamous, and then all these biomarkers based on PCR, and then IHC for ALK, and then IHC for PDL1. So it involves a lot of tissue, and which is a challenge. And most of the tissue gets exhausted by the time fourth test is performed. So the bottom line is to recommend a multiplex approach. We have multiplex approach based on the PCR, where they can pick up the multiple genes and multiple hotspots. And then we have a multiplexing or next generation sequencing where we can do parallel testing at the same time. So, but in India, as of now, NGS panel testing or broad panel testing is offered and is available. In terms of whether it is a feasible thing, so this is a study coming from the French National Cancer Institute. They have funded a nationwide program, and they have done a systematic routine analysis of the EGFR, ALK, KRAS, BRAF, HER2, and PIK3 alterations using the multiple gene testing border panel on NGS. And what they have found that this is a very feasible option, and this yields a better actionability as well as the sensitivity over the standard of care mutations and comparing with the standard practice of single gene testing. Again, multiple gene testing impacts clinical outcome in terms of the actionability and also in the overall survival. This data suggests that the patients who have undergone multiplex gene testing, the overall survival was 3.5 years as compared to patients who underwent the conventional way but were not given genotype-directed therapy. So again, it boils down to supporting the multiplex gene testing. And also the actionable driver detection is almost in 2/3 of the lung cancer adenocarcinoma. So the whole idea is to pick up the alterations. If this multiplex testing approach can pick up more alterations, I think the answer lies there. To summarize, optimal tissue sampling and management is the key to identify prognostically important genetic subtypes in lung cancer, and multidisciplinary tumor board is a must, where surgeon, medical oncologist, pathologist, as well as radiologist should be a part of the discussion before going ahead with the biopsy and the processing. And a range of molecular methods are available to test for genetic subtypes. Guidelines are pushing towards the broad mutation testing panel upfront, and they can help us to not only detect the common alterations, but also the rare alterations where we may have options, therapy options. And NGS is the key. Also, where the biopsy is not possible, liquid biopsies using the circulating tumor cells and cell-free DNA are other options for the patients to identify the actionable target. With that, I thank you all for your kind attention. Over to the organizers. So your voice is not audible.
Any questions from the audience, please?
Yeah, I can, Dr. Amit, I can ask one question. If many times it happens that the patient have limited tissue available and we cannot do a NGS study or a ISC marker, would you advise a liquid biopsy upfront for that patient, or you ask for a repeat biopsy?
So if the first biopsy has failed, and if the clinical diagnosis is suspicious of lung cancer, and then liquid biopsy is again an option, should be attempted first rather than going for repeat biopsy. If you hit your target or actionable target, then the job is done. You can straight away go ahead with your treatment option. If there is no yield in terms of actionable target in that case, a repeat biopsy is recommended to prove that yes, the patient had this lung cancer diagnosis, and then you can treat accordingly. So I would go with the liquid biopsy followed by a repeat biopsy.
And what are your recommendations for patients who have relapsed? Once they have progression, at that time, would you like to repeat the biomarkers?
And the secondary alterations, if the patient have received target therapy in the past, to understand the secondary alterations or resistance mechanism, repeat biopsy is recommended. And again, it's a challenge. If biopsy is not feasible, liquid biopsy can pick up all these alterations very easily. So now there are FDA approved tests in liquid biopsy, which can pick up all these alterations in an easy way actually.
Dr. Amit, I have one question. Like, if a patient don't have accessible tumor, and if we do one just histopathological confirmed tumor, but we don't have again tissue biopsy, and we do a liquid biopsy, one time it comes inactive, will you recommend again second time? Is there is false negative test occur in liquid biopsy, and we can go for second liquid biopsy and third time?
Yeah, so that's a very interesting question. Liquid shedding of the tumor DNA or the tumor cells is a dynamic process.
Yes.
You may not hit the liquid biopsy success in the first go. Depending upon the tumor burden, the success rate is going to change. If you strongly suspect that the patient is a non-smoker or a young patient, and you are expecting some alterations, I think it's worth repeating liquid biopsy if you do not have the access to the tissue and you want to make those decisions. So there is no harm repeating liquid biopsy at some point in time. And you can also give empirical chemotherapy. And then during the chemotherapy, if you do liquid biopsy, the probability will go up, because the liquid biopsy will do a lot of tumor lysis, and the leakage of tumor DNA will increase the probability or sensitivity of the liquid biopsy. So I think that can be another smart way to address the situation.
Can I ask a question? Amit, can I ask a question to you maybe?
Yes, yes, please.
There. What is the predictive value of ALK or EGFR in a chronic smoker squamous carcinoma? Because the guideline, and even you showed that, said light or never smokers. So, and we know that people even with heavy smoking or current smokers, sometimes with squamous, pure large tissue, end up getting, and very occasionally, in fact, they may be positive. So what is the predictive value that the anti-EGFR drug will work in this group of patients?
So the anti-EGFR drug, if you hit the alteration, definitely the probability of success will go up. You may talk about that, yes, the response rate will be higher. But if you want to ask categorically whether the patients who are chronic smoker and squamous cell carcinoma, what is the probability of these alterations? Again, the probability is less than 5%. So we are not talking about if you hit the target, the response rate will be higher, but the possibility of picking up the target is less than 5%. So you can try, there is no harm, and there's always a scenario of mixed histology which we can miss on a smaller biopsy. So there is no harm doing all these tests. It may be a big option.
Invite the next speaker, please, Dr. Bhavin.
Yeah. So thank you, Dr. Amit, for a nice presentation. And now we have next speaker, Dr. Senthil Rajappa. He doesn't require any introduction, and he will speak on how to choose the first-line immunotherapy or an IO combination. Over to Senthil.
Good morning, everybody, and thanks, Sandeep and Satya, for asking me to do this talk. My talk is titled Non-Small Cell Lung Cancer, How to Choose First-Line Immunotherapy or Combination. And the objective behind this talk is to make sure that you don't go through this experience that I'm showing you on the screen. And
sorry for the interruption, sir. Can you please reshare your slides? Your slides are not visible.
My slides are not visible. Is it visible now? No?
No.
Hang on.
No, sir.
Let me close this. Is it okay now?
Yes, sir.
Perfect.
Okay, thanks. Great. Thanks, Chirag. Good to see you. So the intention is to make sure that you don't go through this experience that I'm showing you on the screen. I thought I will start with some numbers. This is a very recent publication from the JAMA network. It's open access. This is to tell you the outcomes for patients who took immuno-oncology drugs in the United States. This is from the database, right? So what you see here is that the outcomes that you get with immunotherapy in terms of overall survival, this is from nearly 20,000 patients, is far below what you would see in the published clinical trials. Now, I have shown you the overall survival in some of these trials here. The Keynote 189 is just below 2 years. But look at what happens when you use a combination of chemo and pembro. That's about 13 months, which is nearly half of what you would get on a clinical trial. Of course, there's no time to go into why this is showing such poor outcome. But the point I'm trying to make is that in the clinic, when you're trying to employ these drugs, it's very, very important to make sure that you're choosing the right patients so that you end up as close as possible to what you see on a clinical trial. And that's why I like this ladder very much. You see that at the bottom is the efficacy as you would see in a clinical trial. The effectiveness of any therapy is usually a little lesser than what you see in a clinical trial, because clinical trial consists of patients who are very, very selected. And of course, then comes the cost effectiveness, which is a totally different ballgame altogether. So just getting started, we will look at biomarker testing. Amit has beautifully put that into perspective. We will go into patient and disease characteristics that you should be looking at before you choose your patients for immune checkpoint inhibitors. Now we start with biomarker testing. The most important test is looking for the PD-L1. The very interesting feature in PD-L1 testing in almost all cancers is that the drug determines the test. Usually what happens is that you do the test, you find out a predictive marker, and then choose the drug that you want to use. Here, if you want to use pembro, then you look at the 22C3. If you want to look at nivo, you look at SP263. If you want to look at atezo, you look at SP142. So it's a very interesting situation where you need to first decide on what is the drug that you want to use, and then you choose the antibody and the platform that is appropriate and the companion diagnostic for that particular drug. Second important question, lung cancer is another unique situation where you always look for tumor proportion score. It's not the combined positive score. In almost all the other sites in the body, you look for CPS. Lung is the only place where you look for TPS. Why should you do broad molecular profiling? It's because of two important reasons. The first reason is that if you have a driver or a target, then it's most appropriate to use that targeted therapy. Most of these driver mutated lung cancers have poor response to immune checkpoint inhibitor. The exception might be a smoker with a BRAF mutation or a smoker with a MET exon 14 skipping mutation, where the response seems to be slightly better. What is the least that we should be doing? The least will depend upon whether you want to do a single agent immune checkpoint inhibitor or combination therapy. If you're looking at doing chemo plus an immune checkpoint inhibitor, then I would suggest that the least that you should be doing is to look for EGFR and ALK. Why do I say that? Because all trials which enrolled these patients looked only at those two markers. It's always better to look for a wider panel, but that's the least. If you're looking at using single agent immune checkpoint inhibitor, then it's definitely better to look at a wider panel, because when you're using only the immune checkpoint inhibitor, remember that you're putting all your eggs in one basket, which is the immune checkpoint inhibitor basket. And if you don't test adequately, you are very likely to end up having an extremely suboptimal outcome in your patient. The second reason also is that some of these immune checkpoint inhibitors stay on in the circulation for a long period of time. And when you use a targeted therapy in the second line, there is a possibility that you will see a higher incidence of side effects secondary to your targeted therapy. So the least is EGFR ALK. If you're doing a combination, the best is to do a wider panel of those 7-8 markers if you're going to use single agent immune checkpoint inhibitor. What about other alterations? Let's say you send it to Foundation Medicine and you get a report with 360 mutation, that you can look for. Now, at this point in time, we are not very clear as to how to incorporate the presence of other alterations, which may or may not add to the predictive value, both the positive and the negative predictive value of an immune checkpoint inhibitor. For example, if you find an MDM2 amplification, we know that the likelihood of hyperprogression is higher. But should we incorporate that into practice? Off the hook, I would say yes. But really, is there a guideline to say that if you find that you should not be using an immune checkpoint inhibitor? Not as of yet. So that's the point I'm trying to make. So it's always good to look at a wider panel, look at all the other alterations and take a decision in a molecular tumor board. But I know that all of us don't have the luxury of doing that. So this is the more practical way of approaching this problem. Where do we stand as far as TMB is concerned? It's not recommended at this point in time. Again, if you have the wherewithal to do this, it might help in some situations, but routinely not recommended to use or choose your first line immune checkpoint inhibitor. What about patient characteristics? I think this is a very, very important point, as important probably as testing for the biomarker. What about autoimmune disease? Why are we considering this important issue here? It's because when you use immune checkpoint inhibitors in patients with autoimmune disease, you've got a higher incidence of a flare-up of these autoimmune diseases and also a higher incidence of immune-related adverse events. So does it mean that it's a contraindication? No, it's now a relative contraindication. So if you have someone who's got a well-controlled autoimmune disease, not much of immunosuppression that's being given at this point in time, it's okay to get on to an immune checkpoint inhibitor. But if somebody's got that uncontrolled rheumatoid arthritis or a systemic lupus erythematosus, then it's better to avoid. For beginners, stay away from these relative contraindications. What about organ transplant? Again, a contraindication because you've got lots of immunosuppressives going on there. Whatever retrospective data is available tells you that about 40% of all these patients have transplant rejections. So again, it's better to stay away from an organ transplant situation. What about active infections? Now, when there is an acute active infection, it's better to delay the institution of an immune checkpoint inhibitor. What about chronic infections like hepatitis C, HIV, AIDS, and so on? That is not a contraindication for use of an immune checkpoint inhibitor. Again, one important bone of contention, steroid intake. Should patients who are on steroid, they should go on an immune checkpoint inhibitor or not? Now, there's a lot of data on this available. There are meta-analyses which have been done showing that if you are on a steroid, your outcome is likely to be poorer. But again, as I said, this is very contentious. Is it because of the underlying condition that puts you necessary to take a steroid? Is that the one that gives you the poorer outcome? Or is it the steroid? For example, brain metastasis, uncontrolled chronic obstructive pulmonary disease, and so on and so forth. These are patients who have poor outcomes on treatment. Is it the steroid or this condition which ended up giving you those poor outcomes? We don't know. Again, we have data from pre-medication that is used as part of adding chemotherapy for immune checkpoint inhibitors. That does not cause any compromise to the outcome at all. You also have steroid that is being used when you want to control an immune-related adverse event. Again, you see no compromise in the outcome. So what do you take home? Please remember that as far as possible, as much as possible, avoid steroid. If you have to give your patient a steroid, make sure that the steroid is at the lowest dose that is feasible to keep that condition under check. Performance status, poorer the performance status, poorer the outcome. Smokers do much better than non-smokers. In fact, you will see consistent data that smoking gives you better outcomes. Non-smokers do poorly on immune checkpoint inhibitors. Women do poorly compared to men on immune checkpoint inhibitors. So all of these are very important patient characteristics. What about disease characteristics? Histology. Histology determines what chemotherapy you use, not necessarily what immune checkpoint inhibitor you use. More your disease burden, better to avoid single agent immune checkpoint inhibitor. What about disease sites? We earlier used to think that if you had liver metastasis, you needed to use the ABCP combination. But now we have data from many more retrospective analysis that it's not the case. All of these work well. Extensive involvement is a prognostic factor, not necessarily a predictive factor. One special mention is about patients who have brain disease or CNS metastasis. There is data from melanoma that if you use combination immune checkpoint inhibitors, when I say combination, I'm talking about PD-L1 and a CTLA-4 inhibitor, there seems to be good intracranial activity. Also, there isn't large volume data in lung cancer. So that might be one area where you may be tempted to use a combination there. Let's get on to specifics. What about patients who have a PD-L1 that's high? When I say PD-L1, it's more than 50% TPS, or if you're using SP142, it's IC3 or TC3. Busy slide, don't go through all these numbers. Just look at what I have highlighted. You've got a host of things that you can do for these patients. Single agent versus combination, there's absolutely no difference in the 2-year overall survival, which is in the lower row that I have highlighted. The 2-year overall survival is somewhere between 45 and 50%, irrespective of whether you're using a combination or a single agent. So when you can use single agent, when there's high PD-L1 expression, that's what you should be doing, not going in for the combination. Having said that, if you want to consider a combination, in spite of a high PD-L1 expression, who are those patients where you need to consider? When I say combination, I'm talking about chemo plus immunocheckpoint inhibitor, not dual immune checkpoint inhibitor. If you've got a female, if you've got a non-smoker, if you've got lots of tumor burden, then you certainly should be better off choosing a combination. The other thing that I would add here, as I said earlier, is if your molecular checking is not as good as what you want it to be, if you've not looked at a wider panel, then again, don't put your money on a single agent immune checkpoint inhibitor. There's some data that if you have a lower TMB, it might be better to go for combination rather than one. Why should you not use a combination? It's because it's more expensive. It comes with more side effects. When you get the same with one drug, why to go for two? But if you have these clinical situations, then it's absolutely important to make sure that you're going in for the combination. What about patients with 1 to 49 non-squamous? The green highlighted area here clearly tells you the studies which are positive. You've got Keynote 189, the quadruple combination in IM power 150, and the triple combination in IM power 130. Now, my full marks will go in for the Keynote 189 because the numbers clearly favor there, at least in terms of the median overall survival and the hazard ratio. But if you look at the column at the right extreme, which tells you the 1 year overall survival, they're almost the same. So the medians are better, the hazard ratio is better for Pembro plus chemo, but it's not wrong to use the others, except that if you're using the quadruple, again, unnecessary because you don't get anything extra, you pay more, you get more toxicity. Where is it that you would want to use the IM power 150? It is in a patient who has got a driver mutation, progressed on the first line therapy, let's say EGFR ALK, and you want to use this second line. Then if you're using an immune checkpoint inhibitor, ideally it should be the quadruple combination. There's no other established role for this quadruple combination in immune checkpoint inhibitor treatment. What about 1 to 49% squamous? The only positive study that we have for chemo plus immune checkpoint inhibitor combination is the Keynote 407. All the others are really not statistically significant. So you don't have a TISO there, you don't have the combinations there. So the clear winner here will be Keynote 407. What about patients who are PD-L1 negative? PD-L1 is clearly a good predictive marker, though not the best predictive marker. I've shown you a list of Kaplan-Meier projections here, showing you that Keynote 189 beneficial, Keynote 407 beneficial. IM power 150 and 130 don't seem to be beneficial. This is subset analysis from these studies. So you have to take it with a pinch of salt. But having said that, it's the Pembro studies that seem to be beneficial in this group of patients who are PD-L1 negative. Now, something that has raised a lot of dust is the 9LA. What's the 9LA? 9LA is where you're using a combination of EP and Nivo. But to begin with, you just do 2 cycles of chemotherapy to make sure that you're not losing some of these patients during the early phase of immune checkpoint inhibitor treatment. What's the expectation? At least the expectation is that the tail of the curve is likely to be higher. We don't know this at this point in time. We need to wait for longer follow-up. The other possible advantage of the 9LA might be that you're not using all your combinations or all your drugs upfront. You probably can reuse your pemetrexed carboplatin later because you're exposing your patient to only 2 drugs at this point in time. So there are some advantages that are potentially there, but we don't know. What is the one area that should be an area where you may want to use the 9LA even now? I think it's a patient with squamous carcinoma and a PD-L1 that is negative. That's one place where you see that the hazard ratio that you're getting with 9LA is superior compared to what you're getting with the squamous Pembro, which is the Keynote 407, or the Nivo EP for the squamous. So you clearly see that the combination seems to be better for a patient whose PD-L1 is 0 and has squamous histology. So that's one area where I think 9LA probably has an immediate implication. Can you avoid chemotherapy for the 1 to 49? No, we cannot avoid chemotherapy for the 1 to 49 at this point in time. This is right out from the standards of ASCO a couple of weeks ago. This is a FDA-driven meta-analysis, which clearly shows that the outcomes are inferior for patients with 1 to 49 who did not take chemotherapy along with an immune checkpoint inhibitor. So there may be an exceptional situation, but over the board, you cannot do that. My penultimate slide, what about chemotherapy considerations? Histology detects the chemotherapy choice, right? So it's pemetrexed and platinum if you have somebody with an adenocarcinoma. If it's a squamous carcinoma, it's paclitaxel carboplatin. You could use paclicarbo also for patients with adenocarcinoma though. Steroids can be used as appropriate as an antiemetic and for pre-medication. We did tell you that there is no compromise because of the use of steroids as pre-medication. What about nab-paclitaxel versus paclitaxel? I don't buy the argument that you can avoid steroids by using nab-paclitaxel. At least in lung cancer, there is no data to clearly support that. Is cisplatin better or carboplatin better? They did an analysis of the keynote 189 and clearly showed that there isn't any difference between cisplatin and carboplatin. So you're good to go to either of these drugs, depending upon what your patient is ready to take as adverse event. So summarizing, choosing the right patient is the most critical part of using immune checkpoint inhibitors. So what are the clinical pearls, should I say? Adequate molecular workup. Remember, when in doubt, always choose the doublet. Don't go in for the single agent. Some don't do well. Be careful when you're enrolling them on a trial or you're enrolling them onto your regular practice. For example, non-smokers, women, all of these don't do that very well on an immune checkpoint inhibitor. In patients who have infections, autoimmune diseases, be very choosy. We did tell you about who are those candidates who can go on it and not. And finally, the most important pearl, prepare your patient, prepare yourself for a long haul, because you are looking to cure your patient, not just make your patient live a little longer. Now, if you've learned that lesson, you will be able to choose your patient best when you're considering him or her for an immune checkpoint inhibitor. Thank you so much for that patient hearing. I am happy to take questions if there is any time. Thank you so much.
Dr. Senthil, may I ask a question?
Oh yes, more than one, Amit.
So if you do a molecular profiling and you come across MDM2, which is a sign of progression,
yes,
would you consider chemotherapy with IO or IO alone to avoid hyperprogression? What is your...
Okay, so I would certainly use chemo plus IO, Amit. I wouldn't do IO because in IO, as I call it as IAO, there are a lot of patients who have those early progressions. So if I'm worried of, hyperprogression, I will always use chemotherapy along with the immune checkpoint inhibitor.
Any choice of chemotherapy, taxanes will be better than platinums, is that so?
Of course, you would use a platinum-based combination. My preference would be to use pemetrexed and platinum. If it's an adeno, and of course, taxane plus platinum if it's a squamous.
Thank you.
Thanks, Amit.
Is there any other question?
Can I read a question that Nitesh has asked? Even I haven't read it.
I think he has a comment, not the...
But question is, with all these parameters, what's the first three we must look at? To me, PS, cost, and then biology. Of course, I agree with you, Nitesh. Thanks so much for that comment.
Thank you, Senthil, for an excellent presentation, as usual. And
thank you, sir.
If there is no further question, I can ask Dr. Duval to introduce the next speaker. Dr. Duval?
Yeah. Next speaker is Dr. Nitesh Rodgi. He'll be talking to us on building on long-term survival and providing and improving IO in metastatic non-small cell lung cancer. Dr. Nitesh, please.
Thank you very much, sir. It's going to be an impossible task to follow Senthil, and that one of the best things I've heard for a long time. Unfortunately, I'm going to be repeating a lot of what he said. I think I almost predicted that. Can I share my slides? I'm trying to. Okay.
Yes, sir.
You should allow me now. Okay. Are my slides visible?
Yes, sir.
Okay. So I think I'm going to repeat a lot of what Senthil said, and I guess that because building on long-term survival in IO is basically about, as Senthil said, choosing the right patient. Exemplified by a 68-year-old gentleman who basically developed metastatic carcinoma. For the sake of argument, let's not talk about his PD-L1 right now. But finally, as Senthil said, we sent for NGS. His TPS is 100, and there's not really any very useful marker. There's a BRAF, but that's not V600, and we don't really know how to tackle that. So coming back to this, as I said, Senthil has more or less spoken entirely and much better than anyone I've ever heard about choosing the right patient. In fact, choosing the right drug and the right biology. And I'll go through that maybe with a slightly different twist, and then we'll go on to how to avoid the wrong things, do the right things, mainly related to antibiotics and gut microbiome, and a little bit into what future looks like with immunosensitizers and maybe better biomarkers. So choosing the right patient, lots of studies. There's the 3 checkmates, 9LA, 227, 026. We can go through details of that in a minute. Then there is the keynotes, the 024, 042, 189. All these numbers often don't make sense, but they are very important because There were certain studies that segregated squam, non-squam, others segregated sex, others segregated liver versus non-liver, and there were crossover in some and not crossover in the other. So I would request all of you to actually spend some time going through these almost dozen studies, the empowers, the checkmates, and certainly the keynotes. But if we look at them in three categories, squam, non-squam, IO and second line, and smoker not, I didn't get a crux of really, in my mind, who are the right targets. Squam, non-squam, first, the non-squam studies essentially came back with more than 50 pembro alone, plus minus chemo, or 1 to 49 as Senthil just put, combination of chemo and immuno, and actually less than 1% pembro maybe plus minus, but chemo is more important. Note that in 189 it was a non-squam study and the crossover was allowed. This is an example of how we must start reading this. Extremely important. This was a 22C3 study. So if you're really going to transpose information from 263 or 142, there is a likelihood of getting wrong. So when you're choosing the right patient, choose the right test. Very interesting. The PFS was important. OS was showing even a bigger difference. Note the hazard ratio in fact fell. But interestingly, when you look at the more than 50, the hazard ratio is huge. When you drop to 1 to 49, hazard ratio drops, but not for OS. And when you go to less than 1%, the hazard ratio drops further. So this was a good study that showed that PD-L1 for lung cancer, especially on 22C3 for pembrolizumab, was somewhat predictive of response and should be used when you're choosing the right patient. Another example was the Empower. This was the other non-squam study. As I said, you're doing non-squam first. And while others segregated squam, non-squam, they were not the non-squamous studies. And here, very interesting was the maintenance arm, which was atezo versus pemetrexed. And yet it did show somewhat survival benefit, but you saw that the hazard ratio is slightly worse than the pembro arm, and the 12-month overall survival was even lesser. To me, that meant that if I really must choose for non-squam, I would choose a pembro combination of pembro alone, especially if I'm using 22C3, if I want to use pemetrexed and I'm looking at OS as my main goal. However, somewhat atezo can be cheaper at times, and if that is the reason, if you cannot use PEM for any reason and you want to use paclitaxel or nab-paclitaxel, and the patient has already had 142 tested and does not have more tissue to test on 22C3, I think I would use this. Plus a small group, and I've recently used there where I had a patient with a lot of pleural effusion. I wanted to use bevacizumab. So in fact, I chose a weekly regime where platinum and taxane is easier, and I chose atezolizumab for that reason. Coming down to squams, very interesting. This changes very quickly. The only two squam studies were 407, where they used crossovers allowed, PAC and NAB-PACLI. Again, good hazard ratios in both PFS and OS, but very interesting, and this is something which Senthil again highlighted, that in more than 50 TPS, the hazard ratio, although 0.64, the confidence interval crossed. Was this in isolation or did we see this effect again? We'll see that in a minute, but do note that in squamous carcinomas, in more than 50%, the confidence interval crossed. This was 131. This was the atezo study with squam, and again, the hazard ratio is good when we are looking at the PFS of these patients, and the OS also, the hazard ratio is good, but the confidence interval crossed. So if I really must use for squam, the only data on overall survival benefit we have in at least more than 50 and 1 to 49 is on 22C3 and is on OS and hazard ratio. What about the trials which were not studied in this group but did segregate or stratify patients on squam and non-squam? Well, we have a number of them, starting with 024, which looked at the more than 50% population, more than 50% PD-L1 population, good hazard ratios. But again, note, and as said, this will come back as a theme, that when we looked at the squam And when we looked at more than 50%, the confidence interval crossed. So is there something about squamous and more than 50% that you're not getting the level of effect which you are getting in more than 50% non-squam or squam with less than 50% and more than 1%? I think I leave that to debate or a panel discussion, but I find that interesting. And if we have to choose the right patient now that there's a plethora, I would use the clinical trial criteria and the efficacy to make a judgment there. 9LA, I think, is extremely interesting. Again, Central pointed it out, but I think it is changing the paradigm slightly, not only because Nivo has come back in the first line after failing its initial trial, not only because you are using chemotherapy, so it's giving you confidence that you can at least start even in a high volume disease, even in a patient who may fail single agent, but also because I think somewhere the combination is triggering some level of immune responses from the immunotherapy, especially when we're considering the Nivo-Ipi combination. So I am actually waiting to see the longer data that comes out of this. The 2 years was very interesting. Senthil has pointed this out also, that this was the only study to my mind where in squames, in fact, with a strong PD-L1, there is still a benefit. So if there's a squam, and if I want to use chemotherapy combination, I would certainly consider 9LA, special with dual agent. The 227 again had some very interesting insights. It was a study where they made the trial as complicated as they could. I don't think any other trial is as complicated, dividing into 2 parts based on PD-L1 and then taking a PFS on TMB or more than 10 and OS more than 1%. I think I would really love to sometimes sit with the PI. Dr. Ramalingam is fantastic. I'm sure there were lots of reasons for this, and get an insight onto what that really meant when they were designing, because the outcomes are equally interesting, where in more than 1% group, there's a significant, there's a good benefit in terms of OS, but in the Nivo alone, it's crossing 1%. It is only when you're using the combination IO. And the same when we're seeing in OS also. So I think I want to understand this better. But again, squam, IO, useful. So as things stand today in 2022, if I have a squamous carcinoma, other than the Pembro, I would consider 9LA and even the IO arm. So this is about really choosing the right patient. Some very small insights into IO in second line. Suppose this patient fails after 12 months. The immunotherapy usage in India, at least, is in fact a lot higher in second and third lines. And this is news to most of us. It was news to me till a couple of months ago, that although the data is strongest in first line, the usage is more in second line. And so to get second line wrong actually would be quite grievous. And in that respect, while there is lots of data out there, it is confusing because on one side, the Atezo shows the maximum in the number of months of OS, but the hazard ratio is almost similar when we look at the whole group together. I looked at it slightly differently and said, what if we pick up the more than 1%, where clearly there's a good hazard ratio and a great survival of 17.7 months with Nivo versus docetaxel. And similarly, if you look at the less than 1%, this is the less than 1% where the median OS is in fact highest with Atezo with a great hazard ratio. So I think there's a slight difference there as well. And that must be teed up and picked up and studied more, especially as I said, because this group is high in number. What are the lessons we've learned from IO? The fact that the PD-L1 enrichment matters even more. The separation of curve is even more. And this was seen across trials where the hazard ratio increased, was quite good, and in fact went up as PD-L1 went up. We also see that the OS, we also see that there's a plateauing effect. So there are patients, even in second line, who can continue to do well for many years. And I think this is one of the reasons why IO became so important. We also see that the side effect profile actually is, I have skipped the slide. The side effect profile continues to be better than chemotherapy alone, and with at least the tail end, it makes very important to consider these in second line, right, for the right patient. The patient-related outcomes and toxicity was better tolerated. So for the right patient, right drug, right timing, even in second line, managed well, I certainly feel that this is important. For not even a minute, I think we should ignore the smoker versus non-smoker combination, because to my mind, this is really turning out to be one of the most important biomarkers. Whether we look at the 0 to 4, whether we look at 0, 5, 7, there's a consistent separation of, at least on forest plot, of the former smokers and never smokers, or current and former smokers and never smokers. And it may be a surrogate for both immunotherapy response, for TMB, for PDL1, but in isolation also, it seems to be working out. This is again an IO segregation based on smoking and non-smoking, and we again see a difference. So to my mind, choosing the right patient, smokers should be picked up. Senthil again said non-smokers do consider chemotherapy. And I'm saying even if you're considering chemo-immuno combination, the crux of the matter may lie a lot more in the smoker than we thought before. This is the third and very important data set, both in Power 132 and 189, where we see a separation of or the segregation based on smoking and non-smoking. So I think with that, I close with choosing the right patient. This is a reiteration of what Senthil said, slightly differently, and certainly he did a much better job on this. But I'll very quickly go into avoiding the wrong things. And while steroids, we thought at one point was the wrong thing, but may not be. But there's a clear, and this is a great review article. So this, I haven't gone into many articles, but a review article, very well put, negative impact of antibiotics on our outcomes. And these are so empirically and rampantly used that almost hurts me on my daily round. I did a Sunday round today on the number of patients on chemotherapy who may not be needing it. There's only one study of all these, almost a dozen studies, this does not show a significant impact of antibiotics on the role and efficacy of immunotherapy. So we have a very strong now data set coming out of that. There's a guideline on when considering antibiotic, what should be done, and how narrow spectrum antibiotic may be better for a smaller course involving infectious disease. In fact, I think they should be a part of our now immuno-oncology tumor boards. There is also, again, the same article which spoke about fecal microbiota transplantation, but more than that, probiotic diets and prebiotics, I think we should be considered very carefully, and delaying ICI because it loses efficacy in the right patient. So don't ignore that. My last few slides, I'm going to close after that. I know I'm running a bit short of time. Really something exciting I'm looking forward to see, which is the immunosensitizers, the OX40, the TIGIT, a very important pathway, which may be critical to immune tolerance develop, and TIM3 again, LAG3. These are the approaches which I think will come in combination of immunotherapy and increase that curve, the flattening of curve to even longer as we add them right in front, or maybe as immunotherapies become resistant to. These are a couple of trials which are running in this category. You can see how many I've clicked 4 times and they still don't seem to be finishing. The other is integration of radiotherapy, a long-standing debate whether abscopal effect is real or it's actually just a fiction of imagination. I believe it's real for the right patient, especially for the high TMB group. And there are various trials going on that. Last 2 slides, predictors of response. Smoking status, we spoke about, TMB and TML. Certainly very important parameters. But look at this. This is very interesting. As I said, last 2 slides, SKT11 and KEEP. And we saw separation of curves in patients who were wild type versus who were mutation. So I think we will get better at predicting when you're doing broad molecular testing on these patients. This is smoking again. And with that, thank you. And I know you all are tired. I am too. And I hope I didn't put you to sleep. Any questions if there are any? Thank you.
Nitesh?
Yeah.
Important question. If a patient progresses on a monoimmunotherapy, would you consider
I think if I heard you right, you said if a patient progresses on single agent immunotherapy, would I consider adding chemotherapy?
No, adding the CTLA-4 ipilimumab.
So I would not. I would not. I think the patient choice is important. If a patient is really progressing on immunotherapy, is progressing on immunotherapy. I think we must follow data. These are expensive drugs. These are toxic drugs. They're difficult to understand. And while you could say what is the harm, there's a huge opportunity cost in lung cancer and pancreatic cancer, in triple negative breast cancer. Any wrong therapy means we may actually lose a patient by the time they become salvageable. So I would not go strictly, I would try to stick against a trial. Salvage therapy with the second line is still experimental and I would not consider that.
Okay. And re-challenging with the IO therapy if the patient have progressed on IO, received chemotherapy, and now the patient wants to approach the IO.
So, Amit, by the time we reach the fourth line or nth line therapy, almost everything and anything sometimes becomes acceptable. But I think for a forum at large, I would not recommend these things because these will not be considered standard of care.
All right, thank you.
So if there is no other question, we can go to a next presentation. And it is from Dr. Asim Shamar. He is a consultant at Bhagwan Mahavir Cancer Hospital, Jaipur, and he will speak on personalized therapy to further improve outcome in BRAF mutated metastatic non-small cell lung cancer. Over to Asim.
Yeah, good morning, everyone. And now I want to share my screen. Yeah, is it visible?
Yes, sir.
Okay, so let's start. So today's topic on which I will speak is personalized therapy to further improve outcomes in patients with the BRAF mutated metastatic NSCLC. So we all know this MAP kinase pathway, which regulates the transmembrane growth factor receptors and leading the cell proliferation in the malignant cells. And BRAF mutation results in persistent BRAF activation and uncontrolled signaling via the MAP kinase pathway. And we know BRAF is mutated in mostly the melanoma, 50 to 60% of the cases, colorectal cancer 10%, thyroid cancer 30 to 50% cases, and NSCLC it is 1 to 4% cases. So it is very contemporary to find a BRAF mutation nowadays. And again, the same statement, BRAF mutation occurs in 1 to 4% of the NSCLC adenocarcinomas. BRAF mutation typically do not overlap with the other common mutations in NSCLC, which we usually do, like EGFR, ALK1, ROS1, MET, RET, and RAS1. So it is the different mutation, and if it is present, the other mutation will be absent. In contrast to the other oncogenic driver mutation in NSCLC, patient characteristics for BRAF mutated NSCLC have not been very well characterized. So sometimes we can say, like in other driver mutation, patient is female and Asian and non-smoker, that may be positive for the ALK1 and sometimes the EGFR. But in the BRAF, there is no key characteristics on which we can identify the patient. BRAF mutation do not appear to correlate strongly with the age, sex, stage at the diagnosis, and smoking status of the patient. There are very little predilection, which suggests in some studies that patients with a BRAF mutation are more likely to be a female or have a smoking history. So BRAF V60E is the commonest mutation, and it occurs about 50 to 70% of the cases of the BRAF positive mutation. It caused by a point mutation in the BRAF kinase domain at position 600 by a valine, which is changed to the glutamic acid. So valine is converted into the glutamic acid, and this mutation happens. And this causes a persistent activation of the cell signaling pathway, MAP kinase pathway. So although V600E is the most common BRAF mutation in NSCLC, occurring in 70% of the cases, but other BRAF mutations are also present. They may be present. Diversity of the BRAF mutation has important implications because the response to the therapy depends on the which BRAF mutation we are dealing with. Different strategies may required for the targeted treatment of NSCLC being V60, non-V60. It is sometimes it is inactivating BRAF mutations also present. In retrospective study of 1046 patients of NSCLC tumor, BRAF mutations were present in the 4.9% of the adenocarcinomas. This is a retrospective study. And in the old BRAF mutation, 56.7% was V600E, and the other mutations, non-V600E mutations. So BRAF V600 mutation has a histological feature suggestive of an aggressive tumor. We all know, like, when this mutation is present, we generally till this date explain the patient like the survival is very short if you don't go by the treatment. Patient with advanced BRAF 600E NSCLC have worse outcome in platinum-based chemotherapy, including DFS or OS, than wild type patient and with the patient with non-V600E mutation. So these graphs are presented in Journal of Clinical Oncology 2011. Here you can see if patient is V600E BRAF mutation positive, then the survival is very less, and wild type it is still better with the platinum-based chemotherapy. And the same this is depicted in this graph also. Clinical outcome in patient with NSCLC on first-line platinum-based chemotherapy. If patient is wild type, you can see the overall response rate is 48%. And if it is a V600E, the response rate is only 29%. Median PFS, they mentioned like it is 6.7 month with the chemotherapy in the wild type, and with the V600E mutation, it is 4.1 month only. Overall survival is 15.9 month, and here it is 10.8 month, almost 25% decreased. So there are three statements which we carry forward. Approximately 1/3 of the patient remain untreated, and in Indian scenario, especially, we can see like it is almost 60 to 70% or 80% patient untreated because drug is very costly. 33 of the patient with BRAF V600E positive mutations have received best supportive care in first line because they present late and the extensive disease, and 57% patient best supportive care in the second line. We tried for some time platinum-based chemotherapy, and they progress in 3-4 months, and we just sent them for the palliative care. Doublet chemotherapy is the most common treatment option for BRAF positive NSCLC till date in the India and other countries also. In patient with the driver mutation, targeted therapy can help patient to live longer. If you can target the mutation, their survival will be increased. And we have seen in the various lung cancer studies, patient identified with the mutation, a mutation driver not receiving targeted therapy lived 1 year less than if we can target the particular mutation. And this is the historical approach in our PG and the DM course program time. We used to send the molecular studies one by one. Non-squamous NSCLC, we send the EGFR, then ALK, and then ROS. But nowadays scenario has changed, and at one go we send the patient for molecular studies. Advanced EGFR, ALK, ROS, BRAF, and HER2, RATE, MET, KRAS, and PDL1. So this is the same thing suggested by the ESMO guidelines and the NCCN guideline. They strongly recommend we should send the broader panel, which they include the BRAF and the other targetable mutation like EGFR, ALK, and ROS1. Broad molecular profiling can be achieved by companion diagnostic NGS technologies, and NGS is such a beautiful technology which you send the block, and in one go all the mutation can be tested with the multiplex NGS. So what is the clinical data for the Refinlar and Maxel? This is a combination drug. So dabrafenib, it is a reversible. This is a combination of two drugs. Dabrafenib is the reversible potent selective inhibitor of the RAF kinase pathway, which is mainly implicated in the BRAF V60E mutation and V600K mutation. Trametinib is the reversible, highly selective inhibitor of the MEK1 and MEK2 kinase activity. And remember, the MEK pathway is also a downstream pathway of the BRAF mutations and the RAF pathway. So DCJ approval in India, dabrafenib in combination with trametinib is indicated for the treatment of adult patient with advanced non-small cell lung cancer with a BRAF V600E mutation. And why we have combined these two drugs? Because this NSCLC and melanoma, compared with BRAF inhibition alone, BRAF and MEK inhibition has been shown to, if you inhibit both the pathways, they act synergistically and they delay the resistance of the particular drug and inhibit cancer growth more effectively than dabrafenib alone in clinical trials, leading to approval of the Refinlar and Mexel in combination in the treatment of the BRAF 600E mutation in advanced melanoma. So here in cartoon, you can say this is the growth factor which are attaching to the cell receptor, and they give the positive signals. Sorry, I'm going forward here. And here the BRAF pathway, this pathway gives the down signals to the MEK kinase pathway and this MEK ERK pathway, and it is causes the ultimately cell proliferation, unlimited proliferation and survival of the cancer cells. So if you inhibit by the dabrafenib here and this MEK cell here, the whole pathway get inhibited and the results are good and the cells are in under control. So the same thing tried in the phase 2 trial where the combination has tried. So it is a BRAF 11 39 28 study design, multi-cohort non-randomized open label phase 2 study. Here they have done the cohort A, B and C, divided the patient in the 3 cohort. They basically they tested monotherapy, combination and combination in the naive patient. So the inclusion criteria were patient with a stage 4 BRAF V600E mutation positive NSCLC, ECOG PS 0 to 2, no prior treatment with the BRAF or MEK inhibitor. Either alone they have excluded, and patient with the symptomatic brain mets were excluded. So the patient in the cohort A, patient who has received more than one line or more than one line platinum-based chemotherapy, they have given dabrafenib monotherapy as a 150 mg BID dose. The N number was 60 patients. Cohort B, prior treated patient, but the combination was tried, dabrafenib 150 mg BID plus tremetinib, and the 40 patients were involved in this cohort. And the cohort C, which we are interested is no prior treatment and you start upfront dabrafenib and tremetinib and the same dose intensity. So the primary endpoint of the particular phase 2 study was investigator assisted overall response rate, and secondary endpoints were PFS, duration of response, overall survival, safety of the drug and population pharmacokinetics. This is the same depiction in the language form. The majority of the patient enrolled had adenocarcinoma and were current or former smoker. This was very peculiar in this trial. So what happened to the cohort A? Cohort A is pre-treated patient where the dabrafenib tried alone. So the response rate, overall response rate means CR plus PR was 33%. Duration of the disease control rate was 58%. Duration of response was 9.6 months. PFS was 5.5 months. And overall median survival was 12.7 months. So in the cohort B, where the platinum-based chemotherapy were used and first and 1 to 3 line chemotherapy agents were used, and then the patient were exposed to the combination drug dabrafenib and tremetinib. So what happened to this particular population group? Overall response rate was 63% because it was combination. Duration of the disease control rate was 79%, and the duration of response was 9%. So basically, it became better to adding the tremetinib because it is a downstream pathway inhibitor. PFS with combination therapy was almost double what has reported with the dabrafenib monotherapy. Dabrafenib monotherapy in cohort A was this was 5.5 months, and here if you use a combination, it is 9.7 months. So clearly, it has been improved if you use the combination of the therapy. So what is the efficacy result in cohort C? Cohort C is the chemotherapy naive patient where the dabrafenib and tremetinib used in the combination. So this is the best subgroup. Overall response rate was 64%, disease control rate was 75%, and duration of response 10.4 months. And if you do the independent assessment, here the duration of response was 15.2 months. PFS with combination therapy was double what has been reported with the dabrafenib monotherapy. It's the same happened with the cohort B also and cohort C also. So 5.5 months just doubled the PFS to 10.9 months. It is a very encouraging and interesting. So this is the slide which is very important, and the most important slide of the presentation is the summary of the slide, summary of the whole presentation. Cohort A, where the dabrafenib monotherapy was used in the pre-treated patient, PFS was 5.5 months, overall response was 33%, disease control rate was 58%. Disease control rate is CR, PR and stable disease, and duration of response was 9.6 months. If the patient were pre-treated and the combination was tried, then the overall response was 63%, disease control rate was 79%, PFS was 9.7 months, and duration of response was 9 months. Cohort C, where the patient were not pre-treated, chemotherapy naive, and the combination was tried, then the overall response was 64%, disease control rate was 75%, PFS was 10.9 months, and the duration of response was 10.4 months. Remember, this is the subgroup which fares very worse if you don't give the targeted therapy. So we are convinced with the data, but what happens with if you try it with the combination therapy? The most common side effect was the pyrexia. Pyrexia was the most common AE and present in 64% of the patient. And fatigue, peripheral edema, decreased appetite, chills, sometimes chills lead to the fever also, headache, dizziness, and cough. These all are related to the quality of life issue with the patient, but pyrexia is the such side effect which may discontinue the drug also. Skin allergies, dry skin, digestive systems like nausea, vomiting, and diarrhea sometimes. So here all patient had at least one AE of the any grade, a grade 1, grade 2. SAE in more than 2 patient included ALT increase, pyrexia 11%, AST increase. They were very minor, but still they were there. And ejection fraction decreased in the 8% of patient, but it was not very significant. So one fatal AE was reported with the cardiorespiratory arrest, but it was found to be unrelated with the steady medication. So what we should do if the patient has a pyrexia? So interrupt the treatment of the Refinar, this dabrafenib, if the patient temperature is more than 38.5 degrees centigrade, but you should continue the Maxel at the same dose. Initiate antibiotics such as ibuprofen or acetaminophen, paracetamol. If the fever responds, you resume the therapy. If fever doesn't respond, then you should institute the oral corticosteroid in those instances in which antibiotics are insufficient. So there are some guidelines how you will reduce the dose of the dabrafenib. So clinical evaluation of infection hypersensitivity we should do, because sometimes patient may have concomitant pneumonia also. It is moving. Laboratory workup, we should do the DLC in routine lab work. Sometimes we should send the cultures also. Hydration is required because sometimes fever range is high and patient may be dehydrated. So first event, administer antibiotic treatment if clinically indicated. Interrupt dabrafenib. Dabrafenib causes fever, and tremelimumab may be continue once pyrexia resolve at baseline. With the treatment, restart dabrafenib at the same dose level. If fever was associated with the dehydration, hypotension, renal insufficiency, reduce the dabrafenib by 1 dose level. That is 50 mg we should reduce and start with the 100 mg instead of the 150 mg. If the second event happens, same as for the first event, use antipyretics and oral corticosteroid, maybe prednisolone for 5 days or as clinically indicated. And the subsequent interrupt the dabrafenib if the fever doesn't respond. Once pyrexia resolve to baseline, start dabrafenib. Consider 1 level further reduction, that is around 50 mg. Optimize oral corticosteroid dose as clinically indicated with the recalcitrant pyrexia. If corticosteroid have been tapered and pyrexia recurs, restart steroid. If corticosteroid cannot be tapered or escalating dose are required, consult medical monitor, and that we should permanently discontinue the dabrafenib. So this is the starting dose schedule of both the drugs in combination. Starting dose is 150 mg, that is 50 mg capsule in 3 times, twice daily. 50 mg BD, 150 mg BD, sorry. Just a minute. And Mechanist, this is a trade name for this, tremelimumab, 2 mg once daily. First dose reduction is required if pyrexia doesn't respond, 100 mg twice daily. Second dose reduction 50 mg twice daily. And if 50 mg is also causing pyrexia, then you permanently stop the dabrafenib. And here the dose reduction of the Mechanist. This is 2 mg once daily, 1.5 mg once daily, and 1 mg once daily. Mexes should be taken at the same time each day with either the morning dose or the evening dose, because it's the OD dosing schedule and here's a BD dosing schedule. If you are going with the morning dose, you should take the Mechanist at the morning dose. The safety profile of the this is the last slide and this is a summary. The safety profile of the dabrafenib and tremelimumab was manageable and similar to the previously reported melanoma studies. The most common AEs across all the cohort were pyrexia and GI-related toxicity and skin reaction. Pyrexia was the most frequently observed AE across all cohorts, and managing pyrexia we have learned, and we may manage this drug beautifully, and sometimes it will be in the clinical practice in the more robust phenomena. Right? Thank you very much. If you have any question, I will be happy to answer you. Thank you.
Thank you, Dr. Asim.
Yes, sir.
For the nice presentation. And is there any question to Asim? If there is no question, we can go forward. And Dr. Doval, can you please introduce the next speaker?
Yeah, next speaker is Dr. Kumar Pravash. He'll be speaking on making heads or tails out of checkpoint inhibitor combination therapy for first-line advanced non-small cell lung cancer. I don't know. I think it's going to be a lot of, but let's see what Kumar has to say.
Good afternoon, sir.
Good afternoon.
And thank you for the introduction. So I'll start my my slide is visible, sir.
Yeah, slides are visible.
And I'm audible.
Yeah.
So my topic for today's presentation is a checkpoint inhibitor combination in a first-line setting for non-small cell lung cancer. And primarily, there are two important studies and two important positive and two important negative study. I'll focus on both of them, on those four of them. Starting with the first study, that is nivolumab, that is PD-1 inhibitor, and ipilimumab, CTLA-4 inhibitor combination. That was a randomized trial with 4 arms, that is Checkmate 227. There has been data in other tumors, that is melanoma and RCC, that combination has merit. And that's the reason people have been trying to see the various combination if it improves outcome in our patients in lung cancer. And my apology, I said 4. No, there are 6 arms, initially 2, and then again division of 3 each in each arm. And this is a very complex study, but what they did this time was to analyze the patients with PD-L1 less than 1% or more than 1%, patients receiving this nivo plus EP combination and compared with chemotherapy. They also had the nivo alone was also included in the comparison. That was the analysis done. A beauty of this study was there are multiple analyses, but it was adequately powered, and that's because you can see the number here. You have almost 1200 plus 550. That is almost 1800 odd patients in the study. But not only it is powered because of number, they had put in the protocol that they will be analyzing in one of these ways in this study. This is the outcome data, and for me, the most important data was not the first one. This is pretty interesting that at 4 years, that is at 48 months, you have a survival improvement from 18% to 29%. And that is, in absolute term, around 11% improvement. Again, why it is striking, and this is we are seeing in lung cancer in many other situations. This is also, again, an important situation. It is not 11%. 11% itself is a huge increase. If you take, not metastatic, adjuvant trial, if we have 11% improvement in survival from 80 to 90, 60 to 70, that is also taken very significant for any treatment, any modality. Sure, in palliative setting, when you have around just 18% 4-year survival, and that improvement is around 29%, that is very significant, and that gets reflected into hazard ratio, that is 0.76. We do see that, yes, for nivolumab, that is alone arm, also there was some improvement in outcome, but was not statistically significant and doesn't look very promising. But what is reassuring, and we'll come to that later on also, that if we have a PD-L1 expression 1% or more than that, the nivolumab also, they don't do really badly. And for me, that is another additional information. That is not what they wanted to answer for this trial, that if your patient is not fit for chemotherapy, is there a viable option for these patients giving nivolumab? And we'll come to this again when I talk about other slides. Now, this is overall survival based on PD-L1 more than equal to 1% in squamous cell versus non-squamous cell. For overall survival, what we can see in non-squamous cell improved from 23% to 32%, again, at 4 years, around 9% improvement in survival. Squamous cell, it is striking because your 4-year survival is around 6%, which became around 20%. That is around 14% absolute improvement in survival with hazard ratio, which looks good, 0.81, 0.68, which is statistically and also clinically meaningful, suggesting that in both histopathology it works. We have always thought that looks like the proportional benefit in a squamous cell for immunotherapy may be a bit higher, but I'm adding maybe a bit higher, but looks like we have seen in many other situations. This is overall survival for less than 1% overall population of these patients. And what we see that in this less than 1%, but the catch for less than 1% is that they have not removed the more than 1% patient. So they have taken all together. But again, that becomes reassuring that once they add less than 1% population also, then the survival at 4 years improves from 10% to 24%. Remember what we had around 18% to 29%. The proportion benefit again remains similar, 0.64 here, suggesting that when we added that PDL1 less than 1%, again here remember what I'm trying to say, that if we adding the less than 1% PDL1, then overall outcome could have been diluted if there was no merit for this combination to working there. Yes, it would have been preferred that we had a separate data to it. That is dividing the PDL1 less than 1% separately from more than 1% and to get the data, but somehow most of the trial, they don't publish it, but hazard ratio looks good. Doesn't look it is getting diluted, 0.64 here, 0.76 here, suggesting that when you're adding that PDL1 less than 1%, this combination keeps working. Again here, highlighting for nivolumab, and that is again interesting for me. That's not, you have a label for it, but again, if you have PDL1 less than 1% patient also looks like at 48 months, if you're giving nivolumab in first line, there is a good number of patients who keeps surviving if that single agent was given in these patients. Coming to overall survival for PDL1 more than or equal to 1% versus PDL1 less than 1%, including the histology subtype. Non-squamous and squamous, it increased from 12 to 25%, here from 5% to 22%. Again, highlighting that your base is very low here when you're treating those patients with chemotherapy. And that is where the improvement is being seen. So that is where the 22% becomes important. Now, if I have to talk about this 22% or 25% in this setting, I will like to quote some of those data of curative setting so that people get a hang of it, why this 24% is important. Now, if the people look for data for CA esophagus or CA stomach, surgery arm alone, I always talk about to my student, when you see the data in a randomized trial, don't forget the standard arm outcome. In the surgery arm, the 4-year and 5-year survival is around 22-21%. If you take the CA stomach and CA esophagus. I'll give you another example, which because I deal with that on both of the tumors. If you take CA lung, CT-RT patients, if you have given CT-RT without durvalumab, the 5-year survival is similar or inferior to what we are seeing here. Again, highlighting the importance of this data. Here, if you take the duration of response in these patients, again, in the patients PDL1 equal to more than 1%, around 34% versus 7%, less than 1%, around 0%. And this we know by and large if you give only chemotherapy versus 31% if this combination is being given. Now, efficacy by PDL1 more than 50%. We are all want to know about this because we have seen this data separately in pembrolizumab alone randomized trial. For overall survival, looks like the proportion of benefit improves from 20% to 37%. Nivo again looking good, going strong here. Again, if you are not able to give combination, if you are not able to give chemotherapy, for me, again, this is additional information for me to work in my clinic. Duration of response improves from 6% to 44%. That goes without saying that this combination does something better than giving only chemotherapy. For the safety, with a minimum follow-up of 4 years, all patients had completed the maximum 2 years of the treatment or discontinued because of safety or disease progression. 17% patient in the Nivo-IP arm, they had to discontinue treatment because of toxicity. So that we do know that toxicity is an issue with this combination, and we need to be a bit careful and learn giving that. All of us have given very few of this combination. I have also given very few, but it goes without saying that if you have to give few to realize that it is a relatively toxic treatment, but the toxicities are different from what we see in the chemotherapy. Bit about if you have discontinued the patient with treatment related adverse event, should we be get concerned? And this was one of the analysis done in this trial, and one more trial I'll be showing. And that is interesting, that if you have discontinued the treatment because of side effect, don't get worried about it. Looks like their tumor has got something interesting. They do better than as compared to the patient who have not discontinued. I don't think so. That is the interpretation for me. What is reassuring that if you have discontinued the treatment because of treatment-related adverse event, one should not get concerned, and patient outcome doesn't get compromised. The next study, again interesting one. First line nivolumab plus ipilimumab plus 2 cycles of chemotherapy versus chemotherapy in this study. And in this arm, in this trial, nivolumab plus ipilimumab with chemotherapy, that is what we call some mini chemotherapy, was compared with 4 cycles of chemotherapy in these patients. Primary endpoint, overall survival, secondary endpoint being the routine, progression-free survival, response rate, efficacy by PD-L1 expression, and the safety analysis. This is the number of the patients, and what we see that in this, because the patients who were included in this analysis, they had all at least 2 years of follow-up after they were randomized. So only all patients, they have completed treatment in this arm, or they have progressed, or they stopped treatment because of side effect. In this chemotherapy arm, small number of patients continued maintenance, that is maintenance per metric state, because here the duration of treatment was to be around 2 years. Here is a detail of what the treatment they received looks like in both the arm. Similar treatment was there, except that immunotherapy was more in the patients who had received chemotherapy in first line, again highlighting that almost 40% of those patients received immunotherapy, suggesting that is not diluting the result of this. That is partly diluting, but it is not that standard arm is fairly weaker in this study. If you take 2-year update, at 2 years, the survival improves from 26% to 38%, again reassuring that there is absolute improvement in survival by 12% in this setting. If we take subgroup analysis, it looks like almost all subgroup there is a benefit in this study, except non-smoker, and that we have seen consistently that there is an issue regarding non-smoker and the immunotherapy. And another one is elderly population, that I am not sure why we have here this, but elderly population, they do have some more events. 2-year update for progression-free survival and duration of response. For progression-free survival improved from 8% to 20%. Again, significant. Base is too low, and that's the reason 20 looks good. But I gave you example in many curative setting where the 20 looks good. That's why this 20 should look good. Duration of response improved from 12% to 34%. Again, clinically very meaningful. Overall survival for less than 1% for efficacy outcome. Again, this becomes important. What is reassuring for progression-free survival, that it remains around 20% when you have taken these patients, more than 1%, and we take less than 1%, again, it remains similar, highlighting that when we are adding chemotherapy to it, again, it does something to obviate the diluting efficacy of immunotherapy in the patients where PD-L1 expression is low. That's the potential explanation for me. For overall survival, looks similar benefit, and duration of response also looks a bit striking, but for me, more often than not, this is a bit maybe fallacious. This is more than 1%, and comparing this less than 1% to more than 1%, what it appears that the both of them has got a similar outcome. And when I was saying that less than 1% looking brighter than more than 1%, maybe that is a bit fallacious, but again, reassuring. Important is that reassuring. We are always concerned about PD-L1 expression being low, and then what happens and how we want to use immunotherapy in this setting. More than 50% or equal to 50% PD-L1 expression and the efficacy outcome. Again, overall outcome looks good, and proportional benefit looks similar in this group also. This is a 2-year safety and data for these this study, and that we don't have any surprises. Looks like whatever we had earlier, similar continues in these patients. What is important here is treatment-related adverse event leading to discontinuation of any component is around 1/5 of the patient in this study. Efficacy in a patient who discontinued treatment. Another trial showing that the discontinuation of treatment because of treatment-related adverse event doesn't impact the outcome of these patients. So that is okay. So is it always true that combination is good? No, we do have more than one sobering outcome. This is a MYSTIC study where durvalumab was combined with tremelimumab and compared with chemotherapy. Whichever way you look, this trial was negative in spite of modifying it based on PD-L1 expression to hope that this trial was positive. Another study, pembrolizumab with ipilimumab in PD-L1 expression more than 50 or equal to 50, and this was a surprise. But yes, this is the way it looks like human medicine works. Absolutely negative. So what we are looking for in future, we will have various of these combinations. We are looking different type of immunotherapy which works at different places, different drugs working at different places. We will be having, slowly we are having the data. We have data for now LAG. We have data for multiple CTLA-4. We will be having data for many other in combination of other treatments. And let's hope that many of them, they work and improve the outcome of our patient. For me, the conclusion is immunotherapy combination has shown to improve outcome in multiple tumors, including lung cancer. And this is one of the options we should have in our hand. I do understand there are some simpler regimen and simpler way of deciding. But for me, these are one of those options we should have in our hand in different group of patients. They have potential to have a chemotherapy sparing effect, which we are, and many times patient wants. Patients are very keen that can we avoid chemotherapy in this setting. But we're also learning that all immunotherapy combinations are not effective. Slowly we'll learn that which one is effective. So it is not good to randomly combine immunotherapy in our clinic. We know that alone immunotherapy, and that was for me a checkpoint 227 study outcome which was reassuring. Is it alone immunotherapy, especially when the patients are very concerned about chemotherapy? Nivolumab as an option in that setting, when many times cost is the issue. They have the discussion about all the options being there, and it looks like, is it one of those options which we can exercise? Thank you so much.
Novel sir, we can't hear you. You're on mute.
Thank you, Kumar, for such judiciously telling us about the use of immunotherapy in non-small cell lung cancer. And if there are any questions, I think he'll be happy to take it.
Can I request Dr. Kumar to stay for my panel, and we can ask the questions to him at that time?
Sure.
One package.
Ulas, no one can say no to Ulas.
Ulas, you can begin your panel discussion.
Sure. Okay, so good morning or good afternoon on a Sunday. And Dr. Somani, hi, good morning. I hope you're happy now.
You are looking much handsome now.
So this is, I realized I had a talk today, so I told my wife to do it yesterday night. I hope you're happy now. This for you.
Thank you.
Okay, fantastic. And I hope I can show a better photograph of you in the next one. Okay. So thank you, organizers. I think Kumar has set the ball rolling. And I have been asked to moderate about the recent advances in lung cancer. And my first reactions when I read about the recent advances in lung cancer was, how do you define recent? Then the dictionary meaning of the word recent, according to the Webster dictionary, is basically having happened, begun, or been done not long ago, belonging to a past period comparatively close to the present. And my subsequent reactions was demonetization. Now, demonetization, my first question to you, Prabhat, since I'm seeing you for a long time, is it recent, not so recent, past? How old is it?
Not so recent.
Not so recent. So you have hit the nail on the head. And then I remembered a conversation which I had with Dr. Kumar Prabhash in WCLC, and where he told me, lung cancer field is changing by minute. It changes by every year and stuff. So again, to Prabhat, you first. How recent is recent in terms of lung cancer? 6 months, 12 months, 2 years, 5 years?
So, as you said, that the speed of advancement in lung cancer, which is we are seeing in the last couple of years, I mean, beyond 6 months becomes too late.
Because 6 months. Prabhat is always up to date on that. So that's what, I totally agree. And they said, this is what Kumar told me actually, the field of lung cancer is changing by the minute. 1 year is a huge term. It's an old term in lung cancer. So Dr. Shekhar Patil, sir, if I have to ask you to just enumerate about the advances in lung cancer in the recent past, this thing, what would you say? Shekhar Patil, sir.
Hello, can you hear me, sir?
Yes, sir, we can hear you, sir.
Yeah, I didn't understand, Douglas, your question. Just
so,
can you repeat?
Sir, I mean, and that's on Sunday, sir. My wife and my children also don't understand what I'm talking to them about, sir. So it's not your fault; it's all my fault, sir. So if we just have to enumerate the recent advances in the lung cancer which have happened in the last, so what I did was I divide them into two, in the diagnostics and the field of management of lung cancer. So can you enumerate, according to you, what are the recent advances, sir, in diagnostics and in management?
Basically, most of the advances are in the lung cancer is the biomarker-driven treatment, sir. Basically, we talk of all these days, we had some 2-3 biomarkers. Now we have got about 7 or 8 driver mutation lung cancers which have got drugs and the treatment for that. And even in the non-driver mutation group, based on the PDL1 tumor mutational burden, smoking, age, the comorbidities, and also based on the volume of the disease, so many decisions are made whether to go with immunotherapy alone or to combination of immunotherapy or combination of immunotherapy with chemotherapy for a short period. Like that, we have got so many things which have improved in terms of the outcome, one, and second in the quality of life, and more personalized. That is what I feel has happened in the last few years in the treatment of lung cancer.
Fantastic. Vamshi, are you there?
Yeah, I'm there, Dr. Ulas.
Yeah. So Vamshi, management of lung cancer, what do you think has been the recent advances as an organizing secretary of Best of ASCO? I hope you have read.
Yeah, at the risk of sounding repetitive, I think it's all been IO only for all of us. That has been the most important change in lung cancer last 2 years. Beyond that, marker-driven therapy. I think the important thing is the emergence of new markers. Sotorasib is something we are really looking forward to. Then we have, of course, had the new HER2 new marker. We have mobocertinib.
Okay, I think we lost Vamshi in this thing. So let me just, to discuss all these things in a span of 15 minutes, and that too after Kumar has spoken, is almost like what I say, bahut nainsafi hai. Can you hear me? Am I audible?
Yes, sir.
Okay, fantastic. So 1 year ago, I have picked up 3 trials that we will discuss. I don't think we'll have time for more than that. So 1 year ago, ADAURA was presented, which said adjuvant osimertinib after chemotherapy or without chemotherapy, and this was the DFS advantage with ADAURA. In this ASCO, Empower 010 study was presented, which had compared atezolizumab versus best supportive care. and this was the magnitude of benefit. So my question to my panelists basically is, I'll start with Prabhat. What are your thoughts on the adjuvant targeted therapy or immunotherapy in non-small cell lung cancer? So Prabhat.
So as far as adjuvant targeted therapy is concerned, for EGFR, it's seems potential. For rest, we don't have data. We need to wait for some more trials to come, particularly the LMS.
Prabhat, we have only 15 minutes, out of which I have taken 5 minutes. So you think adjuvant target therapy is lukewarm, adjuvant immunotherapy is cold. Is that what you're saying?
Hard to say. Like
no, Prabhat, you have to say you are the AIMS chief expert of lung. You have to say something. Tell me, hot, cold, lukewarm, osimertinib.
Osimertinib is hot.
Hot. Adjuvant osimertinib is hot. AstraZeneca is very happy. Atezolizumab, adjuvant.
Is kind of lukewarm.
Lukewarm. Fantastic. Dr. Shekhar Patil, sir. Adjuvant osimertinib, hot, cold, or lukewarm?
Osimertinib is definitely hot.
Fantastic.
I think atezolizumab also looks promising, sir.
So lukewarm towards hot. Fantastic. Vamshi.
Osimertinib, definitely, I think it's tending to hot. Atezolizumab, lukewarm right now.
Okay, fantastic. Now we will go to Dr. Kumar Prabhash. Kumar is there?
Hi, Ullas, I'm
yes,
here.
Sir. Hot, cold, lukewarm.
So osimertinib, I don't think so we can get away without talking to the patient. Immunotherapy today giving option is a bit challenging.
Okay, so why does everybody feel that? Sir, last year when the osimertinib data came and we did a panel discussion on this, osimertinib was towards lukewarm, DFS was not a surrogate marker, a PET MRI was not done. Today, suddenly, because we have seen the advantage as compared to immunotherapy, osimertinib has become better. Is that so, or what do you say?
So I never said that. In fact, that time, my response was that this is very unheard of, and for me, it was always very good. Okay. It is the proportion of benefit which makes you bet you want to wait for some more time. Okay. But immunotherapy data, the way it looks like, my feeling is that it should be there. But I agree with you. You have a valid point. Kumar, why we have a different approach towards it is the quantum of benefit. If the hazard ratio for immunotherapy was 0.3 or 0.4 in esophagus, I said the same thing. Esophagus, after CT-RT followed by surgery, and then that data is there for
nivolumab.
In nivolumab, I said, no, that quantum of benefit is huge. That is you don't have to wait for everything. To have the option. I'm not saying the option. The option never comes.
Okay.
That's the reason.
Prabhat, what is your opinion about osimertinib? I'm not discussing adjuvant atezolizumab.
Well, there is definitely a potential. Again, like what we saw with metastatic disease, probably there could be a subgroup which would benefit certainly more. But I agree. It's not only adjuvant, probably neoadjuvant and adjuvant both. They're going to be benefit with immune checkpoint inhibitor, and more so with at least driver mutation negative patients.
Okay. So just to summarize, adjuvant osimertinib is definitely adorable. Atezolizumab, hopefully by the next ASCO 2022 comes, it will become more hot than lukewarm actually. Okay. Let's go to what Kumar presented. Checkmate 9LA was the second study which I thought, and Checkmate 227. So this is what I call a chemo light regimen. You have only 2 cycles of chemotherapy along with Nivo and EP, and then you give it for till progression. And you do not see the early drop that we see with the Checkmate 227 or the immunotherapy alone arm. So this is what Kumar said, heads and tails of that. So this was the heads. That is, there's no sudden dip, and that's the tail. So your thoughts, Vamshi, your thoughts about Checkmate 9LA, one patient in which you will give Checkmate 9LA regimen or Checkmate 227.
At this point, it's really difficult to last because, you know, except those who refuse chemotherapy, where I can use IO-IO combination, I really can't see a place where I would give this 2 cycles of chemo. It doesn't make a very logical sense to me. It works, yes, you're avoiding the initial dip, all that is fine. But then to find that subset of patients where you would rather not give pembro chemo or you would give only this, I really don't know which is that right patient.
Give them marks Vamshi out of 0 down to 10 and BMS is listening.
No, so I would definitely say the combination is probably better than the IO-IO alone. IO-IO, I'll give 50 marks. IO 9LA probably 60. The pembro chemo as of now seems to be the best at around 70%.
Okay, 50, 60, 70. Dr. Shekhar Patel, sir. Vamshi is a very strict examiner.
Hello. Sir, basically, I think the data with the 9LA appears to be quite promising. With 2-year median survival looks very promising. And I feel in people at least who are PDL1 negative or less than 1%, such group of people, I feel this combination of 9LA should be good. But we can't compare with pembro with chemo because we have got a good 4-year survival data available for that one. But still, I would like to consider this short period of chemotherapy with nivolumab and ipilimumab for people who are PDL1 less than 1%, smokers, and where I don't want the chemotherapy to be used for a long period of time. That is what I would consider in this.
Mark, sir. Checkmate 9LA 227 and keynote 189.
I would 9LA will be my first preference.
Marks, sir, out of 10.
I would say 60% marks for 60. That one.
Checkmate 227, sir.
Checkmate maybe 40 to 50%.
Okay, and keynote 189?
Because of the mature data of more than 4 years, I'll give 70%.
Okay, Prabhat. And then Kumar is the final examiner after that.
So, obviously with 9LA, you cannot compare this combination versus pembro chemo.
I am changing your question, which is that one patient in which you will give checkmate 9LA and not chemo KN199.
So, if you say 227, it's easier to answer because patient who deny chemotherapy, one can certainly consider irrespective of PDL1. Here, anyway, you are giving chemotherapy, so that doesn't make sense. If you ask me, I mean, as far as the biological rationale is concerned, probably this way of combining chemotherapy to checkpoint inhibitor, maybe in the initial few cycles, does make sense. I mean, if you have a high disease burden and if you want to use everything in a single go.
Marks.
As of today, with the base of mature data is highest marks to keynote 189. Followed by this 9LA, followed by 227.
227. Dr. Kumar Prabhash, you spent 20 minutes and, I was really impressed by that 18%, 29%. I never looked at the data. And Dr. Sandeep commented that, the more we listen to you, the more we learn. So definitely. So your marks, sir. I mean, to me, it is 0, I know. To the keynote 189 and CM 227 and CM 9LA.
So I'll say it's these two trials for me primarily looks not so good. The reason behind them is you're combining drugs and you're combining costly drugs. I'll say tomorrow, if the cost of this combination comes down below the cost of pembro, and then you will start seeing the patients who are willing, and that we discussed about. Who are those patients? Patients not willing for chemotherapy, and second, patients, especially when you have PDL1 expression being low and they are skeptical about chemotherapy. These will be a smaller group, but I do agree with the previous comment. Today, we don't find those many patients. Sir, but for me, the primary reason is because of the cost is why I will choose this.
Sir, can I ask you? Let us say if the cost is similar for pembro and a nivo EP combination. Tomorrow, both of them are same. Then what would you choose, sir? PDL1 less than 0.
Less than 0. You can't.
Less than 0. I am not going to make life easy for you on a Sunday, sir.
So then there is a challenge, Ullas, because if it is pembro plus chemotherapy, then you have to choose it. We choose a known devil. So for me, the cost is like bring it down. and then you will start seeing patients willing for.
Okay. So basically, I think to me, it basically is, everybody is important. There will be space for everyone over here. You will have to dissect that subset. You can't really say that one is supportive to bigger than another one. I think we have discussed this. Just the last abstract Pacific trial, Vamshi. Your comments on this? 5-year survival, stage 3, 0 on 10 marks. Vamshi, how much will you give Pacific regimen?
Pacific 70%.
Maybe 70%. Oh God.
It seems to be a good enough thing. I'll be okay with it.
I mean, तुम तो क्या बच्चे की जान लोगे क्या? 70 on 10. I thought you'll get 10 on 10. Okay, Dr. Shekhar Patel. Pacific regimen. How many marks?
Maybe 60 to 70, sir. I also feel that it is a good in three-way disease.
Fantastic. Prabhat.
Yeah, I think beyond 80%.
Beyond 80%. Finally say someone. Dr. Kumar, final marks. 70, 80, 90, 50, 40. Pacific trial.
So if for chemoradiation, we want to give chemotherapy for 5% absolute improvement in survival. For durvalumab, I leave it to everyone's opinion. So if we are willing to give everybody, chemotherapy for chemoradiation in same group of patients,
I think, yeah, I mean, I also would give it around 8.5, 9 on 10. The only thing is there's always a room for improvement. So that is why I'm taking out 10-15% from there, and that's it. For me, thank you, all the panelists. Thank you, Kumar, for a wonderful discussion. Thank you, Prabhat. Thank you, Dr. Shekhar Patel, sir. Thank you, Vamshi. And stay safe. Thank you, and hand back to organizers. Thank you.
Thank you so much.
Thank you, Dr. Ulas. Thank you.
Thank you, sir.
I think we'll hand it over to the organizers for the next session.
Yeah.
Thank you so much, everybody. Thanks a lot. Sandeep, thank you so much.
Thank you, sir. Thank you, Dr. Dole, sir, and Dr. Bhavin, sir. And I'm really very much thankful to Dr. Satya for organizing such a wonderful meeting and choosing the eminent and leading speakers and our best of the India, not only India, I can say in the world, our best speakers like Kumar Prabhas, Ulas Batravos, and all.
Yeah, I think Sandeep, I'll just take 30 seconds to tell that Amit very clearly mentioned that NGS is the key. Sendil simplified the complex interplay between the biomarker, the patient, and the IO molecule. Nitesh exemplified his case-based approach and gave us an algorithm. More than that, he told us what we must avoid, what should not be done. Asim focused extensively on BRAF mutant NSCLC. Kumar elegantly clarified the meaningful impact of an IO-IO combination or an IO mini chemotherapy combination, right patient. Ulas and his allied team of panelists, as always, I can say excellent. Thank you so much, Sandeep, and over to you.
Thank you very much, sir. And now we will move on to one supportive session. And this is also going to be a very good lecture by Dr. Bharat Vaswani. It's his original research work. So I would like to invite Dr. Bharat, and he's not only my colleague, my friend, but also a senior consultant doing a Hyderabad, practicing at Hyderabad. Dr. Bharat.
Good afternoon, everyone. Thanks, Sandeep bhai. Sir, am I audible?
Yeah, very much audible.
Yeah.
Please go ahead.
Thanks to you, and a special thanks to Satya, who was along with me, one of the person who has presented this. So I should thank him. I should thank Sagar from Gynec, who helped in preparing this. Actually, we have two publications. One was published last month in BMC Cancer, and last year we had one publication in World Journal of Clinical Oncology. So we have two data now to present, and these are the first data from India. So it is a pleasure to present this data in this meeting. For the first time, we are presenting this data in any forum. So the topic that I am discussing in the next 15 to 17 minutes is NEPA. NEPA is netupitant and phelanocetron. The real life evidence. So we are presenting our data from the first time from India. Now, probably discussion about nausea, vomiting in a conference is like odd man out. I think so. Very few of our conferences we discuss this aspect, which according to me is one of the most important aspects that I'll be telling you. If you ask your patient, which is the most dreaded complication you think or you expect when you give a chemotherapy, and we have presented, it is second most common behind fatigue. So nausea and vomiting probably are the two most frequent and troubling side effects during chemotherapy, definitely interfering with quality of life. And in my patient, in some of the patients, they have even stopped the treatment. So probably this is an aspect that we need to discuss more. Yes, drugs are important, but how toxic and how much side effects are there are equally important. The second most important aspect is not a acute vomiting, and it is a delayed thing which is important. Most of us, one day chemo, they go home. Problem comes from day 2 to day 5 where they experience vomiting or nausea. Thankfully, with these new drugs, that calls to my assistant or me have started coming down, because as a protocol, if the patient can afford, in the best of center for all breast cancer patient and in high doses platinum, we give this single tablet Akenzio. And trust me, in the last 3 years, which we are using more than 1,000 patients now, the complications are least. So if you look into the recent data, around 38% developed acute CINV, that is chemo-induced nausea, vomiting, and 64% had a delayed CINV. I will be more stressing on delayed CINV because that is something that our normal 5-HT3 or even a aprepitant may not be able to control fully, as I'll be presenting in the data subsequently. One of the most important slides. These are the major trials of aprepitant, and our late Maru sir presented about phos-aprepitant. Now, when you look into the acute things, acutes are quite okay, but when you look into the delayed vomiting, it is the responses to these drugs, that is from day 2 to 5 is poor. In fact, the best data is 74%. And if you look the previous data, 50% to 70% only have a control of delayed nausea and vomiting. And overall also, the recent two study apart, it was only 60%. So here comes the crux of my presentation. How do you reduce it, or how do you delay it, or can you add on something, and what is our data? Is it really good enough? This is something. Now, that is what I told you. That was a patient perception of the most feared side effect. Now, the last study done showed that nausea is supposed to be more commoner, impairing side effect than even loss of hair that the female experience. But yes, so that is something that we need to be more prompt about. Now, a patient having vomiting in first cycle, more in female anxious lady, it is suggested that if you don't add on your drug, or if you don't change, or if you increase your prophylaxis, the chances of vomiting in the subsequent cycle is 6.5, and by cycle 3 it is 14 times. So it is always better to start with the most effective drug in the first line. That is the. Now, this is all we know. Vomiting leads to most important impaired quality, discontinuation, and more importantly, for a patient who are living far away, interfere with treatment compliance. So probably whenever a chance is given, give the best effective drug. So NEPA, the topic of today's discussion was a combination. This is a single tablet. So you give a tablet, chemo, and then leave her. No post-chemo medication required. So we give a single dose, give your AC chemo or a high dose cisplatin, send them home. And trust me, 9 of the 10 will never complain. This is same being reiterated in the guidelines. So if you see the Multinational Association of Support Care and Cancer, that is MASCC and ESMO guidelines, it is now recommended as level of evidence 1, recommendation A, level of confidence high, level of consensus high. The basis is acute vomiting is due to 5-HT3 or serotonin, which is mediated through 5-hydroxytryptamine, and that is inhibited through our 5-HT3. The best 5-HT3 antagonist is Pehlajani, I will be telling you. Now, for delayed vomiting, it is mediated to substance P, and that is through neurokinin 1. So here we are giving two drugs which have a similar and complementary pharmacokinetic profile, have a synergistic action, and that forms the rationale of giving a single dose tablet only. Now, if you look into Pehlajani as compared to the other antiemetics, a better half-life, more binding, more positive cooperative, more inhibition, long-lasting inhibition of target, more importantly, receptor internalization, so more efficacy. And the most important is it inhibits 5-HT3 NK1 receptor crosstalk. So the most effective. Again, when you compare netropitant with aprepitant, a drug with a broader T-half, that is why it is more effective in delayed vomiting, equivalent or better receptor occupation at Cmax, better receptor binding, and more importantly, at day 5, the receptor occupation is better than aprepitant. So you have two drugs which you are combining, the best two drugs, and here you have a response. So a single tablet improves your antiemetic potential, reduces the number of dose, only a single dose, no mistakes because you are not giving anything post at home, and gives a more flexibility for a drug for a high emetogenic as well as moderately emetogenic. Schedule is single dose of NEPA, send them home. No post chemo drug. Of course we give DEXA, but we have reduced our DEXA also, and we are seeing an equivalent response. And when you look into the moderately emetogenic drug, again, a single NEPA, single dose of DEXA, send them home, no problem. So that is something which is easier for us to maintain. Other advantages, around 35% of patients, whatever you advise at home, they may not take the drug. Again comes the problem that most of them, they don't take the proper tablet. So by giving a single dose, better compliance, improve control. And more importantly, if you look into your ondansetron group, there is some QTC prolongation, which is not there with this combination. So here comes our real life data. This was the data which was published last month in BMC Cancer. I thank Satya sir who was there, who contributed equal number of patients to me. It was a multi-centric retrospective study conducted at our Yashoda and Omega Hospital. These were all chemo-naive patients who were prescribed NEPA. What we assessed was not complete response. So means no vomiting in day 1 to and day 2 to 5, and complete protection means including nausea, which is something of an unthink or an undiscussed topic. Now, this drug was taken from Glenmark. This was a pro forma that we have given to our patient. So after chemo, this was a chart which we explained to my assistant, and our coordinator explained to fill this chart. Do you have a vomiting in the first 24 hours? If you had a vomiting, how many this we could have seen? If any rescue drug required, and nausea, if any. And at home, again, in the next 4 days, would you have any vomiting? If vomiting, yes or no, how many times? And more importantly, did you have a nausea or no? So this was a pro forma which was attached to all the files. Patient was given, and on them they were asked whether they are filling this form or not. Treatment was single dose of this tablet, dexamethasone. Since we were taking it in the trial, 12 mg on day 1, 8 mg on day 2-4, as per as highly emetogenic. For moderately, we did not give it. So the parameters that we assessed was overall response rate, so no vomiting, no rescue medication in first 24. Overall is 1 to 5, acute 1 to first day, chronic or delayed is 2 to 4. Overall complete protection means no nausea. These were the parameters that we assessed. The median age was 53 years, females were more. The chemo that we choose was either a AC or a cisplatin in head and neck cancer, and in a moderately emetogenic we chose FOLFOX or FOLFIRI. Breast was the most common diagnosis. Now comes most important. You remember your aprepitant data. Now compare our data. Acute phase 93%, delayed phase 85, as well as overall 85. So more than 80, a very good. When you look into highly emetogenic, yes, delayed was slightly more, but acute delayed, it was in all patients, out of 185 had a very good control. In moderately, it was very excellent, again in delayed somewhat. So what it suggested was the control of acute chronic was good, and in all the patients, it was more than 80 to 85%. In fact, in moderately, it was nearly 98%. Now, complete protection included nausea. So what we see is acute phase, again, a good thing. If you see moderately, it is very good. Delayed, yes, slightly lesser because we found some patient having nausea, but it was a very less grade. And they did not take rescue medication except for 5 to 10 patients. Overall, it was 80% we had, including nausea, vomiting. Highly emetogenic 79, moderately 84. So these data, if we compare also, was very good. And this is an effective drug. I need not have to tell it, but these responses are just re-emphasizing our fact. Nausea, yes, something that we have. These were stringent things that we tried to find out. Was there any grade of thing? So yes, in all enrolled patients, around 77, highly emetogenic 76, moderately 79. That was something which was there, but yes, most importantly, the patient did not require the rescue medication. Now, so this finding suggested that yes, even in highly emetogenic or moderately, there was no difference in the complete response in acute, delayed, and overall phase. Male, female, there was no difference in the response. Now, so we concluded that single dose NEPA targeting joint pathway shows effective control of nausea, vomiting in highly hematogenic and moderately, and it has a very good control over nausea, vomiting in all the phases, acute, delayed, as well as in the nausea also. The second publication came last year in World Journal of Clinical Oncology. Basically, this was not chemo, but all the patients, including first line, second line, so treated, coming in the second line and giving highly hematogenic drugs with a total size of 400 G. So, effectiveness of novel fixed dose combination of netipetant and phenylephrine in the prevention of chemo-induced nausea, a real life study. It was published in WCA, World Journal of Clinical Oncology. So retrospectively, again, the same chart were used, but we analyzed all our data. Eligible medical records were checked for dose and frequency. Corresponding diaries were checked and rechecked again. The main thing was primary clinic complete response. So nausea we did not discuss. And CR was as again acute 24, delayed from 2 to 5 days, and overall. Mean age 56, same, more in females. This was the distribution. Again, if you see, the overall complete response rate was 93.79. So again, it was more than 90. In highly hematogenic, in moderately, both it was very good, 93 and 95. Now, when you look in acute phase, probably, according to me, the best drug for acute phase, slightly lesser, but again, the responses as well in acute and chronic was more than 90. So 93.97%, a complete response, probably a better acute phase 98, chronic in the delayed phase 93%. Now, when I look into the cycles also, if you see the efficacy remains more or less irrespective of first, second, third cycle, that is more important. Anticipatory vomiting probably not there, and it continues to work well for the entire 6 cycles. So overall CR rate was 90 or more. CR in acute was around 95, and in delayed was as good as the overall CR. So what we concluded is NEPA effective in preventing this in 93.79 this was the first paper, and the last was the second paper. Response was maintained irrespective of the highly hematogenic or moderately hematogenic. More importantly, it was consistent across the number of the chemo cycles. Where are we as compared to the world literature? So if you see, there were 4 or 5 major publications before us. Our numbers were respectable. We are probably better or as good as in the world literature in terms of acute. If you see chronic, 85 to 90, and if you see other data, more or less the same. When you look into overall data, again, probably better or more or less. If you remember, there was a practice guide which said that every country may have a different response. More importantly, nausea also was respectable, close to 77 to 80%. $1 million question. I have to spend so much money. Am I justified in giving this? So these are the data from other drugs in a landmark studies, including apripitant, ondansetron. Now, if you look into the data as compared to the left of the data, 60 to 80%, delayed vomiting, somewhere the response, the complete response was 40 to 60 only, and overall, if you see 40 to 70. So what does it suggest? That if you have a chance that the patient may have vomiting, and if you have the resources, try to give the best effective drug. We have seen our data, and if you compare our data or the data with the first generation, that is apripitant group or the HT3, these are better, more effective, and more importantly, safe drugs also. So if I have to summarize our data, NEPA is a fixed dose combination of highly potent. In fact, you are including the 2 most potent drugs in their subgroup, the more higher acting drug. Thankfully, there is a complementary and the synergistic effect. Single dose tablet will help improving compliance. Single dose will help controlling the acute and delayed phase of CNV. And our main thing was Indian data has established the effectiveness of this novel drug in controlling nausea, vomiting among Indian patients to a greater extent, to the effective extent with the very least toxicity. In fact, NCCN has already approved it in a fixed dose single tablet combination in all category A, highly hematogenic, even in moderately hematogenic drugs also. I thank you all for listening to us for the first data of our presentation for in country. Thank you, sir. Thank you.
Thank you, Bharat, for presenting an excellent data in the context of Indian scenario, and really it will be a great help to us and for our budding oncologists and even for established oncologists to take a lesson from your original research and your work. Now, house is open for any question answer. But I have one question to you. In these patients, like in a patient who are having a 4 or 5 days chemotherapy, like in PEV regime and this one. So what is take on
Sir,
this?
no data, sir. You should not. In fact, we tried out, but that is not recommended, sir. That is what if it is 1 day chemo, it is the best drug. Probably for a 5 day I+E or cisplatin etoposide bleomycin, not the right drug to give, sir. Because invariably by 4th day, we have 10-20 patients that I have given, but day 4 you need to give an anti-emetic again. So the drug is for 1 day chemo, sir.
So,
highly limited, sir. So not for a 5 day chemo.
So I have one more question to you. If we gave a single day 1, and if we can we repeat on day 4 to in these patients?
Sir, the thing is, it looks good, but unfortunately, we don't have a data. So 5 days, it works very well. Ideally, it should work very well in 5 days, but unfortunately, sir, we can still give it out of the trial or out of things as a personal thing. But if you ask me personally, probably not the right way. But yes, sir, we have tried out actually, but sir, it is difficult to discuss in a meeting, but we have tried out. But sir, drug is very effective. And we have, in fact, for vomiting, I don't remember a person who came back for nausea is something which still is there. But yes, sir, you can use it, but out of the context, sir. But as per the guidelines, not recommended.
Any more question to Bharat? Anyone else? Thank you, Bharat. Thank you for your presentation. Now, I would like to invite our program director of progress in GI cancer, Dr. Chirag Desai, sir. He's again, I welcome Dr. Chirag Desai. He did a very hard work to design this program, and sir is consultant oncologist and director Hematology Clinic, HOC Clinic, Vedanta, Ahmedabad. Sir, over to you for your proceeding. Next proceeding.
Thank you. Thank you very much, Sandeep, for the nice introduction. And it was an excellent program since morning, and particularly the lung cancer session and the supportive care lecture by Bharat was too good. When Ullas and Kumar were there, we were expecting some fireworks to happen with a good debate, but that didn't happen. So we will have the opportunity of having the debate in this session, GI session, which is also an exciting session. And we have included the topics of nuances that have happened in last year or so in upper GI cancers mainly. So I request Dr. Aditi Mittal, who is the session coordinator, to invite the chairpersons and to begin the proceedings. Thank you.
Good afternoon, one and all. So, firstly, I would take pleasure in inviting Dr. G.S. Bhaji, sir, who is the senior professor at Mahatma Gandhi Hospital and SMS Hospital, at Jodhpur. And I would also like to invite Dr. Dilip Ramkran, sir, who is a senior professor in the Department of Histopathology at SMS Hospital, Jaipur. Welcome, sir.
Thank you, Dr. Aditi. And good afternoon to all of you. And thank you, Sandeep, for the invitation. And without wasting time, I will go for the first lecture by the Dr. Aditi Mittal, and she is medical oncologist and assistant professor in medical oncology in SMS Medical College, Jaipur. And she will speak on NCCN guidelines, updates in gastric as well as the esophageal cancers. Aditi, please go ahead. Aditi.
Yes. So just a second, I will just share the screen. So thank you all the organizers and professors and sir for giving me this opportunity to speak on this topic. So we would be having, we'll keep it very crisp. And as we know, the topic is about the updates in the gastric and the esophageal cancer. And nowadays, for every malignancy, we have more and more update of immunotherapies. So most of my presentation would be covering immunotherapies. And then there will be something talk about HER2 inhibitors and other drugs. So immunotherapy is everywhere, in first line metastatic setting, in adjuvant setting, in second line and more lines. So we'll be looking at trials which gives us evidence and how the NCCN endorses it and how the NCCN uses it. So first is immunotherapy in first line metastatic setting. What data do we have and how we it is? So in our NCCN 2021 for HER2 expression negative first line is fluoropyrimidine and oxaliplatin combination with nivolumab for adenocarcinoma. So what is the data? Data is the main checkmate 649 trial. We know that prognosis for patients with advanced and metastatic unresectable HER2 negative gastric cancer as well as gastric esophageal junction cancer adenocarcinoma is poor. So they used nivolumab with the chemotherapy backbone and they had some good results. So this was a trial design. It was a phase 3 trial. And in this, they used nivolumab with either Xelox or Folfox and versus Xelox or Folfox, which is generally used. So primary endpoint was overall survival and peripheral progression-free survival. These were the baseline characteristics, which was similar in almost both the groups. There were metastatic disease, liver mets were there, signal ring cells were there. So these were Asian patients were also there. So this is the graphs that we see. So we can see that with the nivolumab and chemotherapy backbone, there was 13.8 months overall survival for these patients and then 11.6 months for the patient receiving chemotherapy. And PFS was not very different, but yes, it was 7.7 versus 6.9 months, but the hazard ratio was 0.77. So if we see, the median duration of response was almost 8.5 months for adding nivolumab and 6.9 months for only chemotherapy. So these were the subgroup analysis, and the subgroup analysis showed that as the PDL1 increases, the responses, the median duration of month of overall survival as well as PFS increases. That's why with NCCN we have for PDL1 greater than CPS 5. So survival benefit with nivolumab plus chemotherapy was enriched at higher PDL1 CPS benefit cutoffs, and overall responses was or. So we can conclude that in the phase 3, this trial for adenocarcinomas, nivolumab when added to the chemotherapy backbone increases the overall survival and the PFS and the duration of response also for the patients. Treatment-related adverse effects were less than 5%. Then there was one more study, Keynote 590, which actually used the pembrolizumab with the chemotherapy backbone. So the chemotherapy that they used was bit, I would say, cumbersome because they used cisplatin for 5-FU for 5 days, which is generally less used nowadays, but of course very effective. So they used a chemotherapy of cisplatin and 5-FU versus placebo plus this chemotherapy. In this patient, again, we have all the patients, and but in this patient, we also have the squamous cell carcinomas patient. It was a first-line study. Again, the overall survival curve was made, which shows for the PDL1 CPS 10 score, the curves are separating very beautifully, and the median overall survival was 13.5 versus 9.4 months. And if we see for all patients, we are not doing so according to PDL1, then it is 12.4 versus 9.8 months. So as per Keynote 590 also, first line pembrolizumab plus chemotherapy versus chemotherapy has some overall survival benefit as well as PFS benefit. Hence, we concluded that the esophageal cancer, squamous cell carcinoma with a CPS of greater than 10 or only squamous cell carcinoma or any patient with CPS of greater than 10 can be advised for pembrolizumab plus chemotherapy backbone as their first line setting. So now we come to what are the changes or what are the new advances that we have in the second or the mode line of therapy. So is there any hope? So definitely, I am talking about a recent addition only. So yes, there is a pembrolizumab which is being approved for second line therapy for esophageal squamous cell carcinoma with PDL1 expression greater than 10. And also pembrolizumab is being advised for MSI high tumors. So for advising these, we have some basic studies. That is Keynote 181, which was again a phase 3 study. It was a big study. And in this, they used only pembrolizumab or investigator choice of paclitaxel or either docetaxel or irinotecan. And what they found was these were the forest plots, and in this, if the patient is stratified as per the CPS, almost all of the subgroup of the patients are deriving benefit, and the squamous cell carcinoma patients are also deriving benefit. Although in this study they didn't have an overall survival benefit, the PFS rate was almost doubled. So this is the progression-free survival curve. Yes. So in the if we have a as per PDL1, then the curves are still a bit separate. Of course, not very interesting data, or not very. But in second line, we don't expect very great results also, and the curves are not very far off for squamous and all patients also. So for overall analysis, I told that there was not actually significant benefit, but yes, they were far off. So as per this keynote 181 study, we are advising pembrolizumab for these patients. Then there is one more study, which is a phase 2 study, basic study, in which they again use pembrolizumab Q3 weekly. I will just skip through them fast. Yes. So baseline characteristics for this 59 was almost similar, and the response disease control rate was 27% in these patients who are receiving only pembrolizumab. So again, we can say the same thing, that as the PDL1 positive patient has 15.5%, and the this PDL negative has very less, that is around 6 to 7%. So there was not much difference. But they also did one more thing, that is MSI. So in MSI assessed, in MSI high patients, the disease control rate was high compared to the non-MSI high. So again, they said that overall response rates were 11.6%, higher the PDL1, more the response rates. And in MSI high patients also, we have better response rates. So this is a study which was used in third line, maybe. After 2 or 3 lines, patient exhausted, then patients were stratified among only chemotherapy, that is paclitaxel or pembrolizumab. And there was no significant difference in the overall survival. But, and in fact, it was actually a negative study. In fact, both fared good. In fact, in this, the chemotherapy has a better PFS. So this was a negative study. So according to them, in keynote 61, pembrolizumab did not increase overall response rates. Responses more durable with pembrolizumab, although they said one time, but their overall response were not very good. So I will just go in the timeline of the immunotherapies in the gastric and esophageal cancers. So we can see these are the negative studies which are down the line. And we see we have data for first line use of immunotherapy for pembrolizumab plus chemo, nivolumab plus chemo, and the nivolumab plus chemo, of course, there were previous trials also. But there are negative studies also. We don't have any data for the maintenance chemotherapy. As well as in second line also, there are some okay type results. And there are studies which shows that there is no benefit of adding the or only immunotherapy in the second line. We need to, of course, have more data to be easily answer all the questions and who are the patients would be. Now, the most interesting and I think very exciting era, that is in adjuvant setting. We know metastatic patients have very poor prognosis in this subset, but yes, in adjuvant setting, we need to add something to improve their DFS. So Checkmate 577 tries to answer our queries and what more we can do for these patients after CTRT and surgery. So this was a well-planned study, which was a phase 3 study. And in these patients, stage 2, 3 esophageal cancer and gastric esophageal junction cancers were taken. Both the histologies were included. And these patients had received neoadjuvant CRT and underwent surgical resection. There can be a pathology, a residual pathologic disease was there. They have taken these. And they were stratified as per histology, as per node, as plus PDL1 expression. So what they did give a maintenance treatment, nivolumab, for almost 1 year. So initially it was given 2 weeks and then 4 weeks. And then they, of course, checked the DFS. So we see in this these red boxes, that squamous for squamous cell carcinoma, the median DFS for nivolumab was 29.7 months versus 11 months for the placebo. Yes, with numbers only we can know the it is significant, found to be this. So there was a yes, histology made the difference. The squamous cell carcinoma patient had more benefit. Then for PDL1, they said that regardless of PDL1 in adjuvant setting, you do not the response is there and the benefit is there. So again, it was the graph showing the DFS, and we see the curves are quite separated and it's quite interesting. So it was for all patients. As per histology, also again we can see that nivolumab adenocarcinoma has 19.4 months, and nivolumab squamous cell carcinoma has 29.7 months. So squamous cell carcinoma as such has a better prognosis, and then both the blue curves are above the adenocarcinomas, but the nivolumab is still up. So currently the standard management after neoadjuvant and surgery we know is surveillance. Patient would be put on follow-up, but we know yes, these patients do lack. We needed to have some more. So what more can be offered to these patients? So this trial I hope answers this, and this says it was associated with significant improvement in disease-free survival with a 31% reduction in the risk of recurrence or death. Benefit of nivolumab was present regardless of PD-L1 expression. So this was about the immunotherapy landmark trials, which has come almost in the last 1.5 years. Now we come to HER2 positive disease. Of course, we all know that trastuzumab is being used for HER2 positive in first line. Now we have some new molecule, trastuzumab deruxtecan. So we all know that trastuzumab is being used for first line always, and for second line now we have SAM trastuzumab deruxtecan. So difficult word for HER2 overexpression in second line therapies. So this is a more potent antibody than Kadcyla, T for TDM, when the drug attached to it has a more diffusion capacity, and it has the bystander effects also. So it is supposed to be more effective chemotherapy drug. The linker bond is more effective as per the literature. So it was one destiny trial. It was a phase 2 trial in which they had gastric or gastroesophageal junction adenocarcinomas, and these patients have already received trastuzumab and they progressed on that. Then of course there was very less options, and then these patients were given either a trastuzumab deruxtecan or paclitaxel. So there were overall response rates for 51% versus 48%. And the duration of response was 11.3 months versus 3.9 months, which is quite impressive in these subgroup patients. Response was present across all the groups, and there was mild side effects, almost 10% to the tune of myelosuppression. That is, myelosuppression and ILD was also observed. So we know there is one drug, of course, HER2. So in this we see that our patients some patient had complete response as well as partial response and SD. If we see the total disease control rate was almost to the tune of 86%, which is quite impressive in these patients. So this is the graph showing the tumor reduction. So we can see most of the tumors had good reduction volume, and this is the physician's choice chemotherapy. So this is the overall survival. There was overall survival also difference. So 12.5 months versus 8.4 months, and in PFS we have 5.6 versus 3.5. So I think once we have this drug I think this is a very interesting option for these patients. Other second line drug options which we already using is like ramucirumab, which is already being used for ramucirumab with paclitaxel for adenocarcinoma. For this we have some more data that in a Ramirez trial, which is a phase 2 trial, in this, the basis of this trial was that most of our patients are treated with docetaxel in perioperative period. So hence, we should change the chemotherapy backbone and use ramucirumab with that. So FOLFIRI was used with ramucirumab And what they have observed is for patients who have been already treated with docetaxel, they had better response rate rather than using with paclitaxel. So we can offer our patient with FOLFIRI with ramucirumab. Then there is one TAX trial which has used trifluridine and tibiracil, and it was a phase 3 trial. This was a trial design, and there was a overall survival was the primary endpoint, which was okay types, not very impressive. So it showed a clinically and although statistically significant, but not for patients, it is not very important. Statistically significant improvement in the OS and PFS versus placebo in heavily pretreated, means they were in third, fourth line, with gastric or gastric esophageal cancer, 31% reduction in death in 2.1 month, improvement survival. So with that, I just hope that we have next year more and more data and more drugs to offer to these patients who can afford and of course have benefit.
Hello.
Yes, you can hear me.
Yes, we can hear you. Thank you. You're done.
Yes, sir.
Thank you, Aditi, for a nice presentation. Any question from the audience? My simple question, Aditi, to you.
Yes, sir.
This is the trials, and these are the network which few of the oncologists doesn't understand what is to be done. And our patient will ask you, madam, you are offering me the immunotherapy or the trastuzumab or other newer drugs. What is the survival benefit for me, and what is the cost? And how will you explain it in very simple words?
So, sir, immunotherapy is still very non-affordable, and for most of our patients. So, very few patients can afford it. Yes, benefit is much higher, like in CA lung, but the data will come for these patients also. So, I think if there is no option they can go with, there's no side effect, not much any side effects, that patient should not go for it. And if the PDL1 is high, we can be more sure and more confident for offering these patients at least a hope.
Okay, one group who is highly affording can go for that without thinking anything.
Yes,
and one is the poor who will never go. And in between, I can have some money from some friend or the relative, and I want to go. What you will advise them?
So personally, I don't advise them to lend money and get treatment for these diseases which have a very less than 1 year of survival. If they are, so that's my personal opinion. Of course, but scientifically, yes, we should offer them.
Thank you, Aditi, for nice presentation. And now I will.
I think we move on to the next part of the program, which is a debate. So may I invite now Dr. Sameer Batham from Ahmedabad and Dr. Viraj Lavangia from Ahmedabad. The debate is on neoadjuvant CT-RT versus perioperative FLOT chemotherapy for GE junction cancer. Dr. Sameer Batham from Ahmedabad will be speaking for neoadjuvant CT-RT, while Dr. Viraj Lavangia from Ahmedabad will be speaking for perioperative FLOT chemotherapy. Over to Dr. Sameer Batham first for neoadjuvant CT-RT, please.
Good afternoon, everyone, and I'm just sharing my screen.
Yeah, please.
Am I audible and my slides visible?
Yes, sir.
So thank you. So good afternoon once again. And before I begin, I would like to thank the organizers for giving me this opportunity. So the topic of our debate, neoadjuvant chemoradiation versus peri-op FLOT chemotherapy for GE junction cancers. A quick background. So as we know that the incidence of esophageal, junctional and the gastric carcinomas, they are increasing day by day. And while surgery remains the mainstay of therapy, we know that some kind of neoadjuvant therapy definitely adds to benefit. And why we need that neoadjuvant therapy? Because we need more R0 resections. We want good loco-regional as well as good distant disease control, because eventually we want to improve the outcomes, the survival outcomes. But whatever we choose, the therapy should be well tolerable to our patient. This is very important point. We can choose anything, but if your patients cannot tolerate it, it is of no use. So in the next 10-20 minutes, what I'll try to justify, what I'll do that I'll try to justify why chemoradiation is better, and while Viraj will try to justify why FLOT is better for G-junction tumors. So this is the area we are talking about. The G-junction divided into 3 parts, type 1, 2, and 3, according to the Sievert's category. And I'm not debating about type 3 or the gastric cancers. Type 3, they behave like gastric cancers only, and we have enough evidence which support peri-op chemotherapy in these patients. While type 1 and type 2 junctional tumors, they behave like esophageal cancers, both in terms of nodal pattern of spread and in terms of survival. And even the HSCC, they also recommend that a type 1 and type 2 should be treated like esophageal cancers, while type 3 should be treated like gastric cancers. So when we talk about data on chemoradiation, started with RTOG 8501. This study was published way back in 1999. And what they did, they used 50 gray radiation with cisplatin 5U, small number of adeno-CA patients, but they also had significant long-term survival benefit. And this set the stage for studies in integrating approach with radiation and surgery. There are a few studies where they compared neoadjuvant chemoradiation with surgery. Many of them had a good number of adenocarcinoma patients, the R0 rates and the PCRs. This was very important achievement with the neoadjuvant chemoradiation. R0 rates ranging from 60 to almost 90%, while PET CR rates ranging from 20 to 40%. Of course, there were survival advantage. There were some parallel studies who were comparing chemotherapy with surgery alone. While the survival was definitely better, the R0 and the PCR were not that great as we were achieving with radiation arms. And if you believe that pathological complete response is not that important factor, here's to this. This is a retrospective study in which they analyzed patients of locally advanced esophageal cancers who received neoadjuvant chemoradiation, and what they concluded that complete pathological response, it predicts significantly higher rates of overall as well as disease-free survival. When we talk about circumferential resection margin, this is a meta-analysis involving 15 studies, close to 2,500 patients. And what they found, and they concluded that the circumferential resection margin is also an important predictor of poor prognosis. The very well-known and famous CROSS trial, which compared neoadjuvant chemoradiation to surgery alone. Many of the patients were adenocarcinomas, and what the outcomes we know, in all the subset of patients, all the subgroup of patients, there was a clear-cut survival benefit, whether it was squamous or adeno. The interesting point to note here that it was not just loco-regional disease control, but the distant progression was also less in the chemoradiation arm. We are still waiting for large randomized trial who are comparing CROSS and FLOT head-to-head. Right now, what we are having is the data of CROSS and FLOT. And these were some of the important findings. I'm not comparing the survival outcomes. They were almost comparable, 2 or 3 digit more here and there. But these are the important findings where it is making difference. See the compliance in CROSS, where in CROSS, almost all the patients could complete their plant therapy. In FLOT, the number was less than half. More than half of your patients could not comply with the plant therapy. The toxicities, hematological or non-hematological, were almost comparable. If not more, they were not less in chemo arm also. When we talk about R0 resection rate, FLOT also showed very good number of R0 resection rates, but in CROSS it was better. When we talk about complete response, even in adeno, in CROSS study, 23% of the patients, they had complete pathological response, while in the chemotherapy studies, this data is not reported adequately. This was a small study, a randomized study, and this study was a propensity score matched study in which 137 patients, they were randomized, 97 received CROSS while 40 received FLOT, and after propensity score matching, 40 patients from each group were compared. And they also concluded that compared to FLOT chemotherapy, neoadjuvant chemoradiation with CROSS in locally advanced adenocarcinoma type 1 and 2 resulted in better response, though there was no survival benefit in either. A POET trial, which could have been a landmark trial. This was a phase 3 trial, but unfortunately this trial closed prematurely because of the poor accrual. And of the 119 patients which they evaluated, they found an excellent PET-CR rates, 16% in the chemoradiation arm versus 2% in the chemotherapy alone arm. And the lymph node negative status was 64% in chemoradiation arm, while in 37% in the chemotherapy alone arm. The survival trend was favoring chemoradiation, but the difference again was not statistically significant. There are a lot many meta-analysis, though again, in none of these meta-analysis, the standard therapy, which is FLOT nowadays, has been compared. But whatever data we have with chemo, the kind of chemotherapy they were using that time, they were all favoring chemoradiation. This was a randomized, this was a meta-analysis which was compared pre-op chemoradiation to surgery alone. And what they found that there was an absolute benefit of 13% in survival with chemoradiation, while some other meta-analysis where they found the benefit of chemotherapy, this was coming close to 7% at 2 years. This was another meta-analysis published in 2011, and where they clearly indicated that chemoradiation has superior and significantly better survival outcomes than chemotherapy alone. This was a more recent meta-analysis published in 2018, where again, they were saying that chemoradiation is superior to chemotherapy. And as I said, all these meta-analysis, I'm still saying that the results should be taken with a pinch of salt, because none of these trials or the studies, they had included the standard FLOT. But CROSS is a time-tested regime, and these were the 10 years results presented recently at the ESCO. And even at the 10 years, what they are saying that the findings are still consistent. In the ESCO this year, they also presented the preliminary results of a head-to-head trial, which is comparing FLOT versus CROSS, a Neo-Aegis trial. And these are the things we can see. We can clearly see the R0 rates, YPN0 rates, tumor regression rates, and the pathological complete responses rates. They are clearly more in the CROSS group versus FLOT group, while neutropenia, grade 3, 4, and the sepsis, they are almost 5 times more in MAGIC and FLOT. And this is a very interesting conclusion they have written, that this RCT reveals no evidence that peri-op chemo is unacceptably inferior to multimodal therapy. So what they are trying to say, or what I could understand, that this is inferior, but this is not unacceptably inferior. Coming back to India, we are talking about our patients. This might look an overstatement, but an average Indian patient of esophagus or G junction looks like this only. I'm not talking about what most of the patients we see in our corporate hospital, but an average patient is this. And when we can very well imagine that when in a trial setup of Western countries, when more than half of the patients could not comply with FLOT, it is not that easy in Indian context. This is an Indian data which was published recently. This was a study from TMC Kolkata, and they also concluded they observed that 15% of the patients, they could not complete FLOT due to toxicity. We do not have, as I said, that we are still waiting for the head-to-head trials. We'll soon be having the answers. There's a big number of trials which are comparing chemo, and many of them are using FLOT as a chemotherapy, and they are comparing chemoradiation with that. We'll be having answers soon. This one trial I'm more interested, I'm looking forward to, is the RACE trial, which is focusing only on the junctional tumors, and they are comparing neoadjuvant chemoradiation versus chemotherapy alone, and they are using FLOT. Hopefully this will clarify the situation. But as of now, what we are relying on are the evidences, the data, and the guidelines, and these are the ESMO guidelines, which suggest that peri-op chemo or neoadjuvant chemoradiation both are the options for these patients. Even the NCCN, they still say that when we are talking about junctional tumors, pre-op chemoradiation holds category 1 evidence. So to summarize, both neoadjuvant chemoradiation and peri-op chemotherapy, they have definite benefit when compared to surgery alone. Neoadjuvant chemoradiation scores over better resection rate, fewer locoregional recurrences, better compliance, and more pathological CR when we compare to peri-op chemo, but doesn't show survival benefit. There are several ongoing trials which may further elucidate a preferred approach. So meanwhile, me and Viraj will be deciding on case-to-case basis what is better for our patients. And our surgeons, they still wait that let the neoadjuvant therapy be over, and they are waiting to do their job. Thank you.
Thank you, Samir. You provided a very convincing evidence in favor of CROSS. And now let's invite Dr. Viraj Lavingia to, let's see what he says in favor of FLOT. Over to you, Dr. Viraj.
Sir, you are muted. Please unmute.
Thank you so much, Chairperson and organizers, for having me here. I'm a medical oncologist, but obviously I'm going to pitch for perioperative chemotherapy. I have a disclosure to make, and Sameer did a very good job not to include squamous cell malignancies into the picture, because I was thinking Sameer will bring squamous cell carcinomas. So this debate is for G-junction adenocarcinoma and not squamous cell carcinoma. And second disclosure, that me and Sameer work in the same team, so we know each other inside out, that what are the practices. So historically, G-junction cancers or G-junction adenocarcinomas have been treated with perioperative chemotherapy. You can see the French FFCD, you can see the MAGIC ECF. Both of them had fair number of G-junction adenocarcinoma. And in that, compared to surgery, chemotherapy either with doublet or triplet showed improvement in overall survival. So this was the standard practice worldwide. But then in 2012, CROSS came. This Dutch trial changed the system, wanted to change the system, and it showed clear advantage of chemoradiation compared to doing nothing, surgery alone. Now, this had 3/4 of patients with adenocarcinoma and 1/4 of patients with squamous cell carcinoma. So when they did a subgroup analysis, what they found was the whole benefit was mainly guided or propelled by the squamous cell variants and not the adenocarcinoma variants. And if you see the hazard ratio for only adenocarcinoma, it was not even statistically significant. Mind you, this was not comparing to any chemotherapy. This was just surgery alone. And for adenocarcinoma, there was no statistical improvement, although numerical improvement. Then came in 2017 ASCO, we had the German FLOT presentation, which had 56% of patients with G-junction cancer. And this time, FLOT was pitched against ECF and not surgery alone. So one chemo was compared to another chemo. And even in that setting, FLOT was a clear winner. So how do we judge? Do we use the German trial or do we use the Dutch trial? I think so the answer lies in ESOPEC. I think so by next year, we won't be having this debate at all, where the ESOPEC is heading FLOT versus CROSS head-to-head, 400 patients randomized controlled phase 3 trial. However, until then, until 1 year, we have to see cross-trial comparisons. And one of the trials Sameer showed was NeoAegis, which was presented just a few weeks ago, which compared CROSS versus ECF. It was not FLOT. By the time FLOT beaten ECF, they already recruited 85%. So there only 10% of patients had actually FLOT. It was all MAGIC trial. So if you compare FLOT, if you compare CROSS versus MAGIC, it was head-to-head equal. In fact, this was an equality trial, hazard ratio 1.00. So we can clearly say CROSS is equal to MAGIC, but we know MAGIC is inferior to FLOT, and hence probably FLOT is superior to CROSS. But let's see. I have arguments against radiation for G-junction adenocarcinoma because if you see the clinical trials, if patient has got chemotherapy, addition of radiation in this subgroup of patients does not add any efficacy endpoints. And rightly so, because adenocarcinoma of G-junction is a systemic disease and not a loco-regional disease, what a squamous cell esophageal cancers are. And I'm going to show you that this was a Scandinavian trial, a phase 2 trial, 180 patients, where they had 3 cycles of cis-FIFU, and they were randomized. Half of patients would get radiation at cycle 2 and 3, what you would do in lung cancer, versus half of them you do not. And rightly so, the loco-regional disease control was improved, the YPT zeros were improved, R zeros were improved, but radiation cannot give you distant protection. And like you see, 5-year overall survival and disease-free survival were absolutely same, whether you do radiation or you do not do radiation. And if you see the subgroup analysis, there was no particular subgroup which had improvement for radiation. The radiation saga for gastroesophageal cancer started with McDonald's back in 90s, and where comparing to surgery, doing 5FU radiation showed improvement. But when you correct them for the right surgery, means the D2 resections, the benefit was gone. And even in this patient, 20% patients were GE junction adenocarcinoma. And if you had a D2 resection, adding radiotherapy did not add any benefit. Similarly, in the Dutch critic study, which was gastroesophageal and gastric cancer, 17% were gastroesophageal cancer. And you could see if patient has got perioperative chemotherapy, adding radiotherapy to this subset of patients does not add even a bit. And I call this flawed poet trial, what Samir rightly said. There were 400 patients they wanted to recruit, but they only managed to recruit quarter of patients. Chemotherapy arm did not complete properly. There were many interruptions. And despite this flawed, there was no statistical advantage of chemoradiation versus chemotherapy. I believe this trial could have solved the debate, but unfortunately, because of poor recruitment, this study is just an academia. And rightly so. Why I want to show is that the pattern of failure in adenocarcinoma is not a loco-regional problem, is more of a distant problem. And this German study, where they did a real-world experience of FLOT chemotherapy, you could see only 7% of patients who recur isolated loco-regionally, suggesting all the recurrences, 93% of your recurrences will have a distant metastasis. So the point of adding radiotherapy to your chemotherapy does not make sense. You can potentiate your chemotherapy, but I don't think so adding radiotherapy is important for this group of patients. And one of the trials did try and work this out. We know in CROSS we use carbotaxol as a chemo backbone, but we know in adenocarcinoma we need a fluoropyrimidine backbone. So this trial, the Alliance group or the Memorial Sloan group, they pitched carbotaxol versus FOLFOX, and they included PET as a PET adapted treatment. So this was very interesting, one of a kind trial. If you started on FOLFOX, if your PET is showing response, you continue FOLFOX. If it is not showing response, you change to carbotaxol. And similarly, if you start carbotaxol, if there is a response, you continue carbotaxol. And if there is no response, you change to FOLFOX. And you could see that no matter what is the PET, if you start a fluoropyrimidine doublet, your PAT-CR rates are far better than compared to what you start with carbotaxol. And clearly that translates into overall survival advantage. When the OS was reported a couple of years ago, if you start on carbotaxol, your overall survival are in the range of 50s, while if you are on FOLFOX, they go to 60s, or even in PET response, 73%. So clearly suggesting a stronger chemotherapy backbone clearly gives an advantage for adenocarcinoma variant of G junction. So to conclude, Samir showed this group. This is an Antrai GI clinic. We are a GI oncology team in HCG. And in last 3 years, Samir, you would agree that for squamous cell esophageal cancers, we have done CROSS for 76 out of 78 patients. While for adenocarcinoma, we have just done 3 for 42 patients. Clearly tells what we believe internally, what we do is as a team. For adenocarcinoma, we do FLOT. For squamous cell, we do CROSS. With that, thank you.
Thank you, Dr. Dheeraj. Now I'll give at least 2 minutes to Dr. Samir for rebuttal. Dr. Samir, you have 2 minutes for rebuttal.
Okay, thank you, sir. So just a couple of points which I noticed in what Viraj said. Yes, I agree with most of what he said. But the problem with FLOT was that they are taking type 2 and type 3 together. And I'm not talking about type 3. CVERT 3 is gastric only. I truly believe peri-op chemo is the best option. Talking of critics or any trial, where I do not believe in adjuvant radiation as well. I'm not saying adjuvant radiation might add to anything. I'm talking about pre-op only. The third point, when we talk about the distant, yes, of course, but when we include gastric and type 3 CVERT, the biology changes. So we cannot completely say that all the G junctions, they will fail a distant side. All these types, they behave differently. And the most important point is compliance. I agree, FLOT may add some benefit, but at what cost? Yes, what all, even Viraj will agree, we have treated so many patients on CROSS. Both of us see and how they, I do not remember a single patient in 3 years who we have to, who could not complete his therapy. While Viraj know what actually happens with the FLOT, and I'm sure we'll be presenting our data of FLOT and CROSS in a few years. But I still remember a patient who started with FLOT and unfortunately for some reasons he had to be switched to cross. I still don't remember any patients on cross who had to be switched to FLOT. This is what I have to say. Thank you.
So, Dr. Viraj, now you have 2 minutes for rebuttal.
Thank you so much. I think so. Samir would agree. There's only a couple of patients we started on cross for adenocarcinoma. And I completely agree, cross is a far better tolerated regimen, but tolerance should not pitch over the biology of the disease. And in adenocarcinoma, going for tolerance compared to going for better survival, I don't think so that's a fair comparison. So in our own center, I think so there's nothing to debate. Samir agrees that if it's an adenocarcinoma, it goes my way. If it's a squamous cell, it goes his way.
Probably we are learning now. Let's see what happens.
Viraj, you are very clear, which patient should go to the plot and which should go for the CT plus RT. But if you discuss not only in a corporate and you include all Indian patients, then what the percentage of the patient can go for float safely, or otherwise they are either leaving the chemotherapy or having a so toxic effect.
Yeah.
So what percentage would you feel that they will be able to? They are not the German patients; they are the Indian poor patients.
So while I agree, Samir showed that 40%, 50% do not complete all planned treatment on FLOT. They are the post-operative part. So even in our experience, more than 80% of patients would complete all 4 first round of FLOT. The problem comes in the later part of the FLOT, after the surgery, when there is a big esophagectomy done. So I do not believe the FLOT upfront is an issue. Of course, we do modify dosages. That's what medical oncologists are for. We titrate the doses. The post-operative FLOT is an issue, where we have enough data, you could just do FOLFOX rather than FLOT in the adjuvant part.
But you as a medical oncologist should give a clear message to the other people, like some of the surgeons, they are insisting to give the FLOT. Whatever the patient's condition is, that you should always give.
Our surgical team is very clear. If it's
that is a different issue. Your hospital is a different, and you are talking about the masses of the country.
Okay. So we are running short of time. So I think to cut short, let's ask the panelists. So whom have the debaters have been able to convince the panelists or not? So which is better, cross or FLOT? Let's ask Dr. Sandeep Jasuja, Dr. Shyam Agrawal, Dr. Vineet Talwar. So are they convinced? Like, what would they favor? FLOT or a cross in the case of G cancer? The final comments from the panelists. Just one word, please.
So in my opinion, what we have discussed in this setup, that if a patient is fit and fine to take care of, to take chemotherapy and to avoid the radiation therapy, then the FLOT is also a very good and standard of treatment regimen. And if yes, patient have little bit advanced disease or nodal positivity, then CT-RT is also a very good option for this patient if patient tolerate this both options. And after discussing with the patient, we can choose the options. One question in the chat box for our debater is that from Fanindra Kumar Sen. Before coming to other panelists, just address this question. Is the choice of neoadjuvant CT-RT or CT based in the length of the tumor any other factor that also should be considered? To all both debaters, please answer this question.
Yeah, so all patients with more than 7 centimeters of length were excluded from cross. And like Samir said, in India, we do see quite a bit of long segment patients, and radiating them, we have burnt our fingers even in squamous cell malignancies. So I do agree, more than 7 centimeters is a tough thing to radiate.
Can I add something? In fact, Viraj, this is our common practice to see more than 7 centimeter segments, but still I am saying we haven't seen any dropout from our cross protocol. All the patients, eventually, most of them at least, they underwent surgery and their final treatment.
Thank you. I think now we should move.
Okay, thank you for such a nice debate. And now we move on to the panel discussion, which is on recent advances in the treatment of GI cancer. May I invite the moderator, Dr. Shyam Agrawal from Bhopal, to take over and invite the panelists for this debate.
Yeah, good afternoon.
Sorry for the interruption, sir. Sir, can you please reshare your slides because your slides are not visible, sir.
I'm sharing my screen. So, yeah, can you see my screen, no?
No, sir.
Then what to do then? Or you want me to? Because here...
Can you share the slide if you have slide at your end?
We haven't received
please.
slides, sir. Sir, please reshare your slides.
Okay. Is it now visible now?
Yes, sir. We can see the screen.
Okay.
Just open the slides.
I think it is fine now.
Yes, sir. We can see your slides now. Put it on a slideshow mode.
Okay. So, Sandeep, thank you very much. And can you call upon my panelists? Meanwhile, the slideshow is on.
So, okay, I would like to invite the panelists, Dr. Neeti Raizada from Bangalore, Dr. Devendra Pal from Mumbai, Dr. TVS VGK Tilak from Pune, and Dr. Prasad Narayan from Bangalore. These are the panelists for this panel discussion on recent advances on treatment of GI cancer. All of you, please join in, please.
All of them are there? Or?
Sir, we have received the message from Dr. Devendra Pal. He has some health issues, so he won't be able to join us. And Dr. TVS Tilak hasn't joined us.
Okay, okay.
Yeah.
But again, there is a problem of I'm unable to show my slides now. PowerPoint is not going up. Oh, why it is not installing?
Sir, can you please mail us the slide? We will play your slide, sir.
Okay, you want me to now immediately mail you? Okay. Mail it what?
We have sent you the yeah, I'm sending it.
Okay.
Also, please take the slides on WhatsApp group also from sir.
Okay.
Perhaps we can prepone Dr. Talwar's presentation while the slides are being organized.
Yeah, I think
you can.
Yeah, yes. I think should Dr. Talwar. Meanwhile, I am mailing my slides. Okay.
Dr. Bhatti, please invite Dr. Talwar for his presentation.
Yes, yes.
Okay, may I invite Dr. Vineet Talwar from Delhi for real-world evidence and pan-Asian adapted clinical practice guidelines to please kindly come and please deliver his talk.
Thank you very much, sir. Can you please share my slides, please? Yeah, so this is basically the real-world evidence on Sarenza in metastatic gastric cancer, that is ramucirumab. We all know about the trials which have taken place with ramucirumab in association with paclitaxel and alone, and also with other drugs like irinotecan. May I have the next slide, please? So these are my disclosures. Next slide, please. So real world data, what is the importance and relevance as compared to the conventional clinical trials? The strengths are that there is a clear demarcation from patients selected in randomized clinical trials. You have the real patient in front, you don't hyperfiltrate. Patients have different comorbidities. The subgroups of patients underrepresented in randomized clinical trials are given benefit of the doubt. They might have advanced age groups which are filtered out earlier. Various patients may have different ECOG performance status. There may be deranged organ function, or they may be pre-treated patients. The burden of disease again may vary around. The validation of safety and tolerability and efficacy of regimens in clinical practice may vary. and so would be the ethnic variation based on the country-wise data. But of course, when you have strengths, you have limitations. Most of these trials are usually retrospective, and rare drug-related toxicities are often missed. Next slide, please. So we have two real-world data. One is from the Caucasian data, and another one is from the Asian data. The Asian data is from the Korean group, which would test the efficacy and tolerability of ramucirumab monotherapy or in combination with paclitaxel in gastric cancer patients, and the EAP, that is the Expanded Access Program. Next slide, please. So here we had two groups in which one ramucirumab, that is Saranza, was given as monotherapy, and the other one in which it was given as combination therapy. 86% patients were the ones which were given in combination therapy, and the decision to provide combination therapy and monotherapy was determined by the treating physicians only. Next slide, please. So when we go to the real world data in the Asia, the efficacy and tolerability of ramucirumab monotherapy or in combination can be seen in the EAP Korean group. You find that the median progression-free survival, when you give ramucirumab alone, it is about 1.8 months versus 3.8 months when there is a combination with paclitaxel. And again, the overall survival is about 6.4 months versus 8.6 months when you use ramucirumab and paclitaxel. So when you give this, and mind you, this is the second line, and when you give in second line, even then you have an overall survival benefit of about 9 months. And the 6 months progression-free rate percentage is about 28.5 percent in ramucirumab arm versus 67% in the ramucirumab and paclitaxel arm. Next slide, please. All these drugs, they are not adverse event free. So when you give a combination of ramucirumab and paclitaxel, you have a more incidence of febrile neutropenias and neutropenias, which is much less when you give ramucirumab alone. And also there might be some instances of GI perforation which were seen in the combination arm. Otherwise, all the other side effects like anemia, thrombocytopenia, fatigue, neuropathy, and GI disturbances are equally matched in both of these groups. So safety profile of combination therapy was similar to the Rainbow trial result, which was the registration trial. And ramucirumab monotherapy did not develop severe neutropenia, which was seen in combination when it was given along with paclitaxel. Next slide, please. Now, switching gears, we told about the Korean data, which was the Asian data. Now we come to the European study. This was the Italian group, and this was the RAMOS study, in which ramucirumab was given as second-line therapy in metastatic gastric cancer. Again, a real-world data. It was a multi-institutional, observational, retrospective study in metastatic gastric cancer patients who received ramucirumab during the compassionate use, that is the expanded access use. The median follow-up of these patients was 11 months, and the primary endpoint was the safety profile, and the secondary endpoint was the progression-free survival and the overall survival. In this also, about 90% of the patients received the combination and 10% received the ramucirumab alone, which was similar to the one which was seen in the Korean study. Next slide, please. Next slide, please. Yeah, so here you can see when ramucirumab is given as a second-line therapy in metastatic gastric cancer, you find that the overall response rates are about 30%, and 2 patients had complete response, and about 28 patients had partial response. So the disease control rate overall, can you go back please? Yeah, the disease control rate overall is about 88%. Next slide, please. And so was the safety analysis. You find that grade 3 and 4 adverse events were neutropenia in about 5% of patients. Bleeding was 1.8% because ramucirumab is a VEGF blocker. Bleeding can be there. and grade 3-4 hypertension was reported in less than 1% of patients. No grade 3 or more adverse events were documented in patients who were treated with ramucirumab alone. That is, that those patients who had a combination, they had about 5% of grade 3 to 4 adverse events. But when it was given in isolation, there was no grade 3 or more adverse event. And fortunately, none of the treatment-related deaths were being tabulated. Next slide, please. So when you compare the real-world data from east to west, we have the Korean study, we have the Italian study, that is the KCSG and the RAMOS versus the Rainbow study. We find that the median progression-free survival is almost the same across. It is hovering between 4 to about 5 months, whether it was the registration trial or it was the real-world data. And so is the median overall survival, which is again between 8 to 9 months. And you have good overall response rates. Next slide, please. So the key takeaways are that from the randomized controlled trials, we know that Saranza is the first biological agent to achieve statistically significant survival advantages in the second-line treatment of gastric adeno and the gastroesophageal junction adenocarcinomas, whether given in as a single agent or in combination with paclitaxel. It has a safety profile and tolerability that makes it possible to treat cancer while maintaining the quality of life of patients. And that has been transposed effectively in the real world data, where we have seen that the treatment patterns and the Saranza effectiveness is consistent, whether it was the real world data or whether it was the randomized clinical trial, which I showed you in the last slide. There is not much difference between the PFS and OS, and that shows that the real life practice data allow us to consider ramucirumab plus paclitaxel as the new standard of care in the second line, which, as alluded earlier, has been tabulated in the NCCN guidelines also as the preferred combination when it comes to the second line treatment in G junction cancers and the gastric cancers. Next slide, please. And these are the ESMO guidelines which are there for the gastric cancer. It is a slightly busy slide. I think I'll move on to the NCCN guideline. Next slide, please. Can I have the next slide? Yeah. So this is the NCCN guidelines in which when you do systemic therapy for the unresectable, locoregionally advanced or metastatic gastric cancer, the first line therapy which is generally preferred is oxaliplatin, or this can be a combination of oxaliplatin based, that is Folpox regimen or a K-Pox regimen, with the trastuzumab if it is HER positive. If it is HER negative, then probably if the TPS score is more than 5, then nivolumab can be added. Otherwise, the other combinations can be with irinotecan or docetaxel, or a triplet like docetaxel, cisplatin, and 5-fluorouracil if the general condition of the patient is very fit. Next slide, please. When you go to the second line, you find that even in the NCCN guideline, the preferred regimen is a combination of ramucirumab and paclitaxel, which is category 1. Otherwise, if the general condition and the performance status of the patient is not good, then probably you can give a singlet, that is docetaxel, paclitaxel, irinotecan, or a combination of fluorouracil with irinotecan. Pembrolizumab is for the third line of the subsequent therapy in patients who are expressing PDL1 levels with CPS of more than equal to 1. And other recommended regimens are, if again the GC, general condition of the patient, is not good, probably you can give ramucirumab alone, or the other drugs which have not been given, like irinotecan or docetaxel, or sometimes if you have the NTRK gene fusion positive tumors, then entrectinib can be given. If you have MSI high, or if you have TMB high, in these two situations, as an agnostic marker, pembrolizumab can be given and it is known to be effective, but not otherwise. So first line, you give a doublet if the GC is average, and you can add nivolumab if the TPS is more than 5. If the GC is very good, then probably you can have a triplet combination. In the second line, the preferred regimen is ramucirumab plus paclitaxel. Otherwise, if the general condition is not good, you might give ramucirumab alone, or you might give singlets like docetaxel, paclitaxel, irinotecan if they have not been given. If the patient has MSI high, or the patient has TMB high, that is 10 mutagens or megabases or more, these patients can be given pembrolizumab as an agnostic drug, irrespective of whatever other situation is there. Otherwise, if the patient has PD-L1 expression by CPS of more than equal to 1, these patients can be given pembrolizumab as a third line, or nivolumab also can be given as a third line, irrespective. There is data to suggest that trifluridine and tipiracil can be given as a third line or a subsequent therapy, depending upon the general condition and performance status of the patient. And that has been given as the CAT-GUN recommendations. If you have an NTRK gene fusion positive tumor, then probably you can give entrectinib or larotrectinib. So I think I will stop here. I thank you for your patient hearing.
Thank you, sir, for a nice and yeah, please.
Yeah, thank you, Dr. Vineet Talwar. If there are no more questions from the audience, and since we are running short of time, maybe move on to the panel discussion from Dr. Prasad Narayan from Bengaluru, which is, and may I request Dr. Prasad Narayan to invite all the panelists, that is Dr. Ashish Singh from Vellore and Dr. Vineet Talwar from Delhi. Over to you, Dr. Prasad Narayan.
Sir, one before Dr. Shyam Agarwal, sir, will be ready after this, and I request all panelists of Dr. Shyam Agarwal to be please stay back in next sessions also. Please go, Dr. Prasad.
Okay, thanks for the opportunity. So, can I have the slides? I think the slides went away. They had come before. So, in continuation with Dr. Vineet Talwar's talk, I think we will discuss a case of metastatic gastric cancer. And this is a Eli Lilly sponsored session. That is a disclaimer. So, we will have a case. Next slide, please. Dr. Ashish, you are there, right? Yeah.
Yes, Dr. Prasad.
Yeah. Next slide, please. Next slide. So we have a 56-year-old gentleman, a chartered accountant by profession. He has a history of ischemic heart disease, but presently is fine. His ejection fraction is 60%. No great or any specific diagnosis, this thing in the physical examination. Next slide, please. And presenting with the usual symptoms, which could be early satiety, epigastric pain, fatigue, loss of appetite, and endoscopy showing a mass centrally depressed in the anterior wall of the gastric body, and biopsy showing a moderately differentiated adenocarcinoma, CT scan showing gastric wall mass and bilateral adrenal metastasis. Next slide, please. So, can I start with Dr. Ashish? What more tests should you ask? You have to answer me in two ways. One is this case is around 2-3 years back, and in the present situation, would we do something more?
Yes, so in general, I think you already said that there is a suspicion that these adrenal nodules, whether they are metastatic or not. So in this situation, to score over the CT scan, which is already done, I'm okay with doing a PET CT. But as a first investigation, we do not order a PET CT because knowing the mucosal and peritoneal spread is the sensitivity of PET is not very great. HER2/neu testing again for only advanced disease is what we have been asking so far because we don't know what to do with that information when patient is not having an advanced disease. And even otherwise, I mean, if it's only my imaging confirms an advanced disease, I would want to do a PDL1 and MSI. Today, I mean, after all the data which we have seen, but earlier it used to be just a histology of adenocarcinoma and then go ahead with planning treatment.
Super. So, Dr. Vineet Talwar, what is your suggestion? Do you, with the present data, is there any change? Are you doing an NGS in these patients, or you are doing a PDL1 score or MSI?
Prasad, I would like to ask prior, would you like to poke the adrenals, or would you take it that it is metastatic? What do you do generally in your practice?
Let me show you the next slide. Maybe that will answer actually. So this is the patient underwent a PET scan, and he had peritoneal metastasis, and there were bilateral adrenal metastasis as well. So this was a clear-cut case of metastatic gastric cancer. To answer your question, in another situation, if there was a doubtful adrenal nodule, I don't have a biopsy of adrenal nodule, but we will take it as with a response. If there is a response to the treatment, we consider that as a metastasis. Ashish, can you take that question about biopsying an adrenal nodule? Ashish?
Yeah, hi, I didn't get your question. What was about adrenal nodule?
So the question is, if there is an adrenal nodule which is doubtful, do you biopsy that? Or you just take it as a
no, I mean, biopsying an adrenal is very difficult. Even reaching there by CT guided is very difficult. So sometimes we use PET, sometimes we use phase contrast MRI. So that itself, the radiologist is able to tell us whether it's basically it's an incidentaloma versus metastasis. A good imaging is good enough. We don't biopsy.
Why I was asking you, Prasad, was because if you had shown me the CT and the PET, then I wouldn't have doubted it. You have florid peritoneal mets.
Right.
But if you show him isolated met, and to say that, it's a metastatic disease, I would be slightly skeptical.
Sure.
That was my point.
Sure. Yeah. Next slide, please. So this patient, very influential guy, as is recommended by his relative, he gets a test done. And we get this report, the next generation sequencing based test, which you can see the result. It has not given us any great information. So Ashish, when do you see such situations where you get an NGS result which you have not asked for, and then you've been asked to work on that?
Yes. Yeah, I think this is likely to increase in coming days with the cost coming down and everybody looking for that magic bullet for their cancer. Yeah, but I think what I would tell this patient is it's a good piece of information to have. Right now, we have better options than what this test is suggesting.
Sure.
Maybe in future we'll find a clinical trial for you, and at that time it may be helpful.
Sure.
So in a way, we just note it down and move forward.
Right. So we will move forward. Next slide, please. So the next slide. The MSI was stable here. The PDL1 score was 5 to 10%. So this was not now. Okay. So I have this report with me. And next slide, please. HER2 is negative. What is the first line therapy which you will start this patient on now, Ashish?
Yes, so he's an older gentleman. He's fit. He clearly has advanced disease. So we have to think about not only first line here, but also what are we going to do in second line and subsequent lines. And from the NGS report, you've showed us that we don't have any magic treatment for him. So at the moment, the main drug remains 5-FU, either infusional or capecitabine, and along with the platinum. And we know oxaliplatin is better tolerated than cisplatin. So my first line option will be FOLFOX or KFOX, depending on the logistics, and that will be the treatment option offered by me for him.
Sure. Next slide, please. So we have seen this slide. Dr. Vineet had explained to us about what is the first line preferred option. So HER2 positive patients will get a trastuzumab based combination, and now in HER2 negative, like our patient, there is a recommendation in patients who have a CPS score of more than 5 to add nivolumab based on the checkmate data which we just discussed before. Like what Dr. Ashish explained, there are other options also, but mostly we are we are good to give a Xelox or a Folfox-based protocol. Dr. Vineet, any comments on this?
Oh, sure. See, if you have the TPS, if it is more than 5, then according to the checkmate study, it not only improves the PFS, it improves the OS. So given a choice, if that is possible, then we might include that. Otherwise, as a standard regimen, Folfox always remains as a treatment of choice for me in averagely fit patients.
Sure. Next slide, please. So the important take home from that point which Ashish mentioned was we have to always think about what second line the patient will go to. So we should not maybe use a taxane in the first line for such patients. So this patient is
also I think in a metastatic disease, it's important to make the treatment as tolerable as you can, so that the patient can stay on the treatment. Starting with a triplet, you may very often in an older man you may end up with toxicity interruptions, and then also you're using up your later line options. So that's the point.
Agreed. So the patient got a partial response to the treatment. There was he had liver mets also. They were all reduced. Next slide, please. So what do you do after giving 4 months of Folfox? When you evaluate there was a good response, do you continue or you maintain with capecitabine or you observe? Ashish, can you answer this?
Yeah, I think oxaliplatin is not a very good drug to be used for a long time. We've had patients bad neuropathy, even hepatic injuries. You will see slowly the steatohepatitis alpha is going up. I've also seen even hepatic decompensation ascites. So oxaliplatin definitely after 3 to 4 months we would stop. Now, whether to continue capecitabine or 5-FU, I think I decide case by case basis, because the gain in overall survival is not that much. But then if you have a patient with a very large volume disease and where you feel a little bit of progression will actually be poorly tolerated, there I'm tempted to continue maintenance. But there are many patients with just few nodes here and there, few peritoneal disease here and there, where I give them a drug holiday. Because the later they tolerate again 5-FU again very well, and they respond as well.
Sure. Next slide, please. So he opted for observation. Okay, he took a drug holiday. He in between had an issue with pulmonary edema, cardiac failure. That was optimized. Conservative management was on follow-up. Next slide, please. So 3 months he was away from treatment and he again progressed. This is very typical of the history of gastric cancer which we see. Next slide, please. So at progression, still stable patient, no specific issue in terms of he has grade 1 sensory neuropathy. Otherwise, there is no major neuropathy as well. Ejection fraction is 56%, willing to ready for further treatment. So Dr. Vineet, what is your option of treatment at this point?
Well, at this point of time, if he is in good average general condition and performance status, because that is the most important rider whenever you go ahead with the treatment, and he has a adequately okay cardiac reserve, I might hazard him with a combination of ramucirumab and a weekly paclitaxel and see how he tolerates.
Sure. Next slide, please. So that's what, next slide. So patient, and this is a recommendation. We saw this before also. So ramucirumab paclitaxel is a category 1 recommendation due to the approved based on the trial results which and the real world data which Dr. Vineet showed us before. Next slide, please. So he got good response actually. 6 months he was on paclitaxel and ramucirumab. And in 3 months there was a partial response. And at 6 months, there was only active disease in the adrenals. So the adrenals, which we discussed from the beginning, are coming at the end of it also. So next slide, please. So this is kind of PET scan, which fairly good result of treatment. So Ashish, what do you do at this point? You are given 6 cycles of paclitaxel, 6 months
yes,
of fine.
So I must say your patient is really lucky to have such wonderful response in second line. Even when we read other trials, registration trials, we talk about an overall survival of even the attraction to the Nivo trial was only 5 months overall survival. This is a situation where I may think of maintenance and continuing treatment. And also, as you said, your patient had a break from 5FU. Sometimes, even though Dr. Talwar rightly pointed out that ramucirumab is approved with a taxane, but we have seen reports of ramucirumab even being used with drugs, regimens like folfiri, which gives you an advantage of rebringing 5FU and using irinotecan. But both regimens are equally good. And here in this situation, I know a lot of the times the patient sometimes will say, doctor, should I have surgery? You may have an aggressive surgeon who will say, I can remove the adrenal. But I think those trials are still ongoing. And as of now, as a medical oncologist, I will say you've responded well. It's like hitting a lottery. You please stay on the drug. And I would continue ramucirumab with maintenance, either paclitaxel or 5FU.
Sure. So, Dr. Vineet, any opinion on this? Ashish already answered my next question also, actually.
Yeah, I'll agree fully with Ashish. See, wherever you see these patients, the basic accent is to judge the performance status and the general condition of the patient and the labs. If they are fine, and then you have to balance it with the quality of life issues, because the basic accent is preservation of his quality of life. He has achieved a good palliation. He just has a disease in the adrenals. And as I think you had mentioned, he had peripheral neuropathy at the inception of second line.
Grade 1,
So paclitaxel would be a concern if he does not have significant peripheral neuropathy. I might give a couple of cycles of paclitaxel more along with ramucirumab, and probably after that continue with the single agent ramucirumab till progression.
Sure. Next slide, please. So I think this question is what we answered now. Next slide. So that's the last slide, actually. So we have come a reasonable way in the treatment of metastatic gastric cancer, adenocarcinoma, from best supportive care to first line therapy with doublet treatments, and then second line therapy. As Ashish said, some of the patients are lucky, and as Dr. Vineet said, it is important to maintain the patient's tolerability to treatment so that we can give subsequent lines of therapy, and that is how we help patients live longer in stage 4 disease. I think that's my last slide, and I thank the organizers for the time.
Thank you, Dr. Prasad Narayan, for this excellent panel discussion. Now, we as there is paucity of time and we are running behind schedule, may I request Dr. Shyam Agarwal as the moderator for his panel discussion. And may I request the panelists of Dr. Shyam Agarwal, Dr. Neeti Raizada, and Dr. Prasad Narayan to join Dr. Shyam Agarwal in this panel discussion.
See, Dr. Aditi Mittal will join the panel.
Instead, okay, fine.
Yeah.
And Dr. TVS is also there.
No, sir.
Acha. So we have Dr. Neeti, Dr. Prasad, and Dr. Aditi.
Sir, Dr. Neeti has logged out.
Okay, so we have to Prasad and Aditi, no?
Yes, sir.
Okay. So, go ahead. So first of all, I'm apologizing for my delay. That slides were not technically shown on the screen. We have already discussed a lot of esophagus and gastric updates. So as our topic is recent advances in GI cancer, so we'll not be discussing or touching gastric or esophageal malignancies. Straight away, I'm coming to the metastatic colorectal cancer. So here is a 62 years old woman with metastatic colorectal cancer, MSI high, and we have V600E mutation. She was diagnosed with cecal adenocarcinoma on colonoscopy. It was prompted by a screening stool DNA test. She was asymptomatic. When we did the staging CT scan, we found pericecal adenopathy, and there were 3 liver metastases measuring 1 to 3 centimeters, and that were adjoining nearby the right lobe. The genetic analysis, there was loss of MLH1 and PMS2 overexpression, which tells about the MSI high, and of course that the ERA mutation. We started with pembrolizumab, and after 3 months of that, patient tolerated this nicely. And there was almost complete resolution of the liver metastasis and pericecal adenopathy. We did a combined hemicolectomy and metastectomy. One of the metastases was also RFA done, and she was found to have an almost in pathological CR. and then Pembro was continued. Now the question is, now she had a great response and resection. There was no evidence of disease. Is there any optimal duration of therapy after surgery, Dr. Prasad?
To answer this question, I think we will have to continue the pembrolizumab until we get that is the recommendation, because there is no pseudo-adjuvant kind of treatment here, and this patient seems to have done extremely well with single agent pembrolizumab. So I will continue the treatment if there are no specific problems in terms of toxicity or there is a progression of disease.
How about you, Dr. Aditi?
Yes, sir, I would agree with sir that stopping it would be it's a risk taken. So that has to be, if patient can affordability, and then I would like to continue it.
Okay, then both of you, how often you see MSI high and BRAF mutation together?
Very rare.
Very rare. Dr. Prasad?
Not seen actually.
Not seen. Had it been like your case, would have you started Pembro on frontline, or you would have option with the combination of anti-BRAF or some kind of chemo or IO?
So the Pembro single agent data, if you take against chemotherapy in combination, either alone or in combination with targeted therapy, the Pembro single agent data stands out actually. So Pembro single agent is a recommended treatment if you have MSI high patient with metastatic colorectal cancer. I think I would have recommended or discussed pembrolizumab with the caveat that you have to take it lifelong, and this is the kind of expense which you are going to look for. And metastatic colorectal cancer patients live for long time.
Okay. So like you all belong to metro cities, so cost is not a problem. Would you like to do ctDNA or some other test for assessment whether she has some residual or MRD kind of thing in colorectal cancer, or you will continue for long? Because what we are trying to address is this is a Keynote 177 trial where they continued for 35 cycles.
Right.
Yeah. So would you like to do some assessment to find out there is some residue or somewhere, or how will you do the surveillance of this patient?
If we have started, I think, and there is a response, there is no other assessment which I would do rather than the periodic assessments with a scan.
Okay, okay. Suppose this patient fails on Pembro, what would be your second line of treatment?
I would give the patient chemotherapy.
Okay, nothing for this BRAF mutation?
At least one line of chemotherapy I would give. Chemotherapy naive patient, definitely I would give chemotherapy.
Dr. Aditi,
yes,
what is your call?
So we generally do not have like ctDNA as such. We generally do, our patients are not able to afford even Pembro. It's very difficult. So yes, scans would be sufficient for me. And because patient is chemotherapy naive, and if the performance status allows us, then definitely chemo would be my first choice to go if she progresses on Pembro. And then maybe if available, then BRAF mutation or maintenance kind of.
Okay, then if suppose third line patient fails, then you would like to start BRAF somewhere?
So
yeah.
Which one? And whether it's a triple combination of encorafenib, binimetinib, or cetuximab, or it will be doublet with the...
They have only one patient experience. That was a patient support program which we got enrollment. So it was a doublet combination. Not much of a response, but we could get the drug for the patient.
Okay, Dr. Aditi, any experience with BRAF?
No, sir, not yet.
No, not yet. So that's what the recent advances tells us, that we are having a lot of newer generation molecules, but still a lot of practice is required. Next slide, please. Next slide. So this is what we were discussing, this pembrolizumab, the MSI high patient in advanced colorectal. Next. This is the Keynote 177 trial, and which has shown the advantage with the Pembro alone. Next. And this is what the ESCO 2021, they have got this treatment is clinically relevant, and it is immediately practice changing. So I think the Monday clinic, I think we should start doing first line Pembro. Next, please. And these are the genetic markers. We have BRAF over 8%, and we still have MSI high in around 2% of the patients. Next, please. And this was, we was discussing the trial, Beacon trial, which has encorafenib and cetuximab as a new standard of care of previously treated BRAF V600E mutation in metastatic colorectal cancer. Next, please. And here is the overall survival benefits. The left one showing the triple combination, the encorafenib, binimetinib, cetuximab, and the second, the right-handed graphs are showing the doublet, that is encorafenib along with the cetuximab. Can I have the next set of case? Okay, so we come to the advancement in the hepatocellular carcinoma. Here is the case number 2, 65-year-old woman with unresectable advanced hepatocellular carcinoma. She was diagnosed with unresectable HCC after presenting with right upper quadrant pain, pleural effusion, and weight loss. The imaging reveals a 15-centimeter primary liver tumor and smaller satellite nodules here and there. It started with atezolizumab and bevacizumab with initial response and then stable disease for 9 months before experiencing symptomatic progression. Lenvatinib was started as second line, but discontinued due to issue with stomatitis, nausea, and skin ulcerations. Currently, she is receiving treatment with dose-reduced cabozantinib and tolerating treatment well. So the question is, with Ato-Beva approved in first line, what does that leave the other available therapies? Which treatment is the best for the second line? Because most of the time we were giving lenvatinib as first line as compared to the sorafenib. So both of the panelists, what were your call? You start with the Ato-Beva first or Lenva first?
Sir,
in such situation? Yeah.
Shyam sir, excuse me, one more panelist, Dr. Mukesh Rulania is also with us. He is also can participate with in this.
Okay, Dr. Mukesh. Okay. I will address the question to him. Dr. Mukesh, have you gone through the case now?
Yes, sir. Good afternoon, sir. Yes.
Yeah, good afternoon. So here is the case of 65-year-old advanced hepatocellular carcinoma, unresectable. What will be your first line treatment in today's era where we have a lot of trials showing atezolizumab beva approved in first line? What is your current practice? You practice with this, or what is your practice? You start with Lenva or other?
Usually, sir, due to financial constraint, we usually start with lenvatinib.
Okay, so like in the beginning of the discussion, I told that we are all from metros, no financial constraints.
Yes, sir.
So otherwise, what will be the patient is from the Japanese group?
If there is no financial constraint, then I definitely go for atezolizumab bevacizumab combination for first line.
Okay.
Yes, sir.
Any other second line IO like Ipi Nivo combination, or you are addressing like this is IMbrave 150 trial?
Yes, sir.
Okay. So is there any way to distinguish between atezolizumab and nivolumab in the first line therapy? Other option like or it is going to be standard of care in near future? Dr. Prasad?
So the data is definitely establishing this as a first line option. I would say that 90% of the patients will still go for starting with lenvatinib or other treatments which we were used to giving before.
Yeah, that's what Lenva would discontinue due to loss of stomatitis and nausea. What is your call? Like, what is your experience with the Lenva? You have.
I think among all the treatments which we have, all the TKIs given for HCC, lenvatinib is one of the best tolerated ones.
Okay. Then how you go with the Dr. Aditi? You go with the enhancement of the doses, or you reduce doses? What is your practice in Lenva dosing?
The patient is a very good performance status, I can start with the standard doses. But if I see the patient is not very good, PS is less, so I would start with the graded doses and would start in how the patient is tolerating, and then only.
Okay. So, like recently, we have listened to gastric malignancy. Dr. Prasad itself, the panel discussion moderator. Dr. Prasad, what was your call with the ramucirumab in hepatocellular carcinoma? There's a REACH2 trial which says if alpha fetoprotein is more than 400, then definitely REACH2 would be the trial where ramucirumab comes into the picture.
Very specific entry criteria there, and we
Okay.
never used to distinguish patients based on the level of alpha fetoprotein.
Alpha fetoprotein. Okay.
Yeah. So that trial, maybe if you want to use that combination, if it is in the mind, then that is approved. But I don't know. I have no experience to see whether a higher alpha fetoprotein was predictive of survival in any other trial actually.
Okay. Okay. Dr. Mukesh, like we have regorafenib also in the second line approval by resource trial. What is your experience like? Have you ever thought of giving regorafenib in a patient who has not tolerated lenvatinib or otherwise post lenva? Did you ever started with the regorafenib, or it is not in your practice? What was
Sir, I have limited experience of regorafenib in second line setting in HCC, but there is a poor tolerance to regorafenib in HCC patients. Maximum patients do not tolerate usual doses of regorafenib, and there is a after dose reduction to 80 mg, there is also no tolerance to regorafenib.
Okay, okay. Dr. Aditi, like we have celestial trial where cabozantinib was also proved in second and third line. Have you ever tried cabozantinib?
Sir, no practical experience.
Okay, okay. Yeah, because we have now second line resource with the regorafenib, celestial for cabozantinib, and REACH2 for ramucirumab. Okay, so because they are all recent developments, and I myself also have not tried many of the newer drugs. Can we have the second slide? Next slide. So this is what IMBRAVE 150, which we discussed. This is updated overall survival data for a global randomized open-label phase 3 study of etho and bevacizumab versus sorafenib in patients with unresectable hepatocellular carcinoma. Next, please. And they are the graphs showing outstanding advantage of combination of atezolizumab and bevacizumab. I would like to ask the panelists how long you continue with bevacizumab, and have you ever come across with any kind of side effect with the bevacizumab? Either in the like colon or hepatocellular or whatever.
No experience in HCC, but definitely metastatic colorectal cancer, and now in some patients of ovarian cancer, we definitely have experience of giving bevacizumab for longer periods of time. And the main issues which we face will be sometimes uncontrolled hypertension, then proteinuria. These are the, and in some patients, maybe a fistula or something, especially in cervical cancer patients.
Yeah. So of course, I also had severe proteinuria in one of the patient, and like I saw the patient was started bloating. I never knew what. And when we did the urine routine microscopic, it was a lot of protein 3+ albumin. So bevacizumab in the long term can cause proteinuria. Dr. Aditi, you want to say something?
Yes, sir. Yes, sir. I have witnessed somehow 2 life-threatening bleeding, lower GI bleeding with the use of bevacizumab. They were doing very well, but somehow then they have to be controlled and supported. But then they recovered. But they had beautiful response with bevacizumab, and after that.
Yeah, definitely, it's a good molecule. Next slide, please. So this is what we have now options for unresectable hepatocellular carcinoma. We have cabozantinib, lenvatinib, anti-PD-L1, a combination of nivo-EP, ramucirumab, regorafenib, and of course our old friend sorafenib. Next, please. So like sequencing also becomes very challenging, and really it needs a lot of acumen. This is what the celestial trial, where the conclusion was that among patients with previously treated with advanced hepatocellular carcinoma, treatment with cabozantinib resulted in longer overall survival and progression-free survival than placebo. the rate of high-grade adverse event in cabozantinib group was approximately twice than they observed. So it is not safe also. There's toxicity. Next, please. This is again the accelerated approval to Nivo-AP was given to HCC on March 10, 2020. Next, please. This is what the trial is, Checkmate 040. Next. And here are the graphs. We got the longest survival was combination with the EP. Next, please. Next setup, please. Case 3. And this is the last case. We have 65-year-old woman with localized pancreatic cancer. Next, please. So this lady previously was very healthy and nice, presented with jaundice, elevated LFTs, and there was weight loss of around 20 kg. Ultrasound showed a pancreatic head mass, biliary dilatation, distended gallbladder, and sludge. Hello?
Sorry.
Yeah. So the workup showed there was a 2.2 centimeter hypo-enhancing pancreatic head mass process lesion, and there no additional site of disease. Germline testing was also done, which was negative. And patient was started on nab-paclitaxel. First of my question to all the panelists, anyone can answer. Do you do the germline testing for all the patients of pancreatic malignancy? Or
not in early stage patients, sir. I don't do.
Dr.
Same,
Prasad,
sir.
your breaking.
We generally consider in metastatic settings. Sir.
Yeah. Okay, not all cases.
Yes, sir.
Okay, though here was the recommendation came from the new National Cancer Institute General. This is given that 20% of patients with exocrine pancreatic neoplasm have germline alterations, and there's universal testing for germline mutations is now recommended. So that is what we have to do in all cases to sort out those 20% of the cases. So what now the question is whether you will like to give NSCT followed by surgery, or you will go with the upfront surgery followed by adjuvant, and what with your sequence if the patient is a little older, let's say 80 plus. So first question, whether you will go for chemotherapy first or surgery first.
So can it answer, sir? So if it is a curative Indian treatment, I would like to operate first in all pancreatic cancer patients.
Okay.
And if you consider like an elderly patient who might not go ahead with a Whipple surgery or something, that will be a palliative Indian therapy. I will not give a neoadjuvant therapy with an intent to go ahead with surgery at a later date.
Any other panel for any different opinion?
No, sir. Surgery would be my first choice. If it's easily resectable, I would go with surgery.
This is the case. Like you have 2.2 centimeter hypoechoic mass, and the parameters are with you. The lady is around 55 or 60. So this is your case. Would you take the opinion of surgeon first and see whether he is able to operate it, or you yourself will start referring him?
No, sir. We will take the opinion of the surgeon first.
Okay.
Then sir, we are getting late. Please wind up as soon as possible because we are.
Okay, this is the last case, Sandeep. Last case. Okay. Only we have 4 minutes 44 seconds. So suppose you have operated. Patient is in pathological remission or the all R0 section. What will be your adjuvant chemotherapy? Anyone can take.
So,
would you give adjuvant or not? First of all.
Yeah, I give adjuvant chemotherapy in all patients of pancreatic cancer.
What chemotherapy?
So, FOLFIRINOX in select patients, and other patients get the gemcitabine-based chemotherapy.
Any difference of opinion with the other panelists?
No, sir. Same, sir.
Same. So that's true. Like Prodigy 24 trial has given clear recommendations that any R0 resection adjuvant chemotherapy with FOLFIRINOX in a good PS patient is better than capecitabine alone. So it is now standard of care. Now, this patient, suppose not willing for surgery, which protocol of chemotherapy you will use, whether FOLFIRINOX or gemcitabine nab-paclitaxel? Dr. Aditi? Hello, am I audible?
Yes, sir, you are audible. Sorry, sir.
Okay,
Sir, PS of the patient is fit?
Yes, fit.
So I would
But denying surgery.
I would go with FOLFIRINOX, sir.
FOLFIRINOX.
She's like 15 around.
50, 55. Yeah, no problem.
No comment. I would go with FOLFIRINOX.
Oh. So you feel that results of FOLFIRINOX are better than nab-paclitaxel?
Sir, yes, sir. If a patient can tolerate, then FOLFIRINOX does sometimes like very good results. But our intent, like in the meantime, I would like to convince the patient for the surgery.
No, that's what he denied.
He will never get, he or she will never get then.
Dr. Mukesh, what will you call?
Sir, if the patient denied surgery, then I go for gemcitabine based therapy.
Nab-paclitaxel.
Yes,
Dr. Prasad, which is your...
in a palliative Indian treatment, I go for gemcitabine based therapy because that is better tolerated.
Okay, had it been a BRCA positive, will your first line will differ, or you will still continue with whatever you feel?
I will give first line chemotherapy. And
no, chemotherapy needs to be given. The patient has got BRCA positive.
No, that will not affect my choice of chemotherapy.
Okay. But the recommendation is, Dr. Prasad, that if patient is positive, then this oxaliplatin followed by olaparib will do better. So whenever this positive, you find to give olaparib in the subsequent lines, then FOLFIRINOX or the oxaliplatin contained regimen is the better one. Okay. So now the last question. This is regarding the maintenance. Suppose this patient has completed chemotherapy and no residual disease. Would you like to give maintenance for the BRCA positive patient, mutated patients? If yes, in what setting?
No, sir. At present, there is no data for early stage maintenance.
No, you are missing POLO trial. The POLO trial says a patient with BRCA1 germline mutation who do not progress on oxaliplatin contained regimen should be considered for olaparib maintenance therapy. So with this, I thank my panelists because I've finished my time. Thank you very much, Dr. Sandeep. Thank you very much, the organizer team for Oncology Progress.
Thank you, Dr. Shrival, for such an excellent panel discussion. And thank you all the panelists and thank you all the faculty for Progress in GI Cancer. I'll also like to thank my co-chair, Dr. G.S. Bharti, and also like to thank Dr. Jasuja for giving me this opportunity for chairing this session on Progress in GI Cancer. Over to Dr. Aditi Mittal for the last session on Progress in Gynae Cancer.
So thank you, our chairpersons, for really conducting nicely this session. And still we are late we want to discuss 5 minutes, but still because of late, now we are moving to our next session. And for next session, our coordinator is Dr. Aditi Mittal again, and she is my senior consultant at SMS Jaipur. And over to you, Aditi, for next session.
Yes, sir. So I would like to invite Dr. Lalit Mohan Sharma, sir, for his talk, Optimal Molecular Diagnostic Algorithm in Ovarian Cancer. Dr. Lalit, sir?
Yeah, thank you so much, Aditi, and thank you.
Dr. Lalit is senior consultant and senior hematologist at MG Mahatma Gandhi Hospital, Jaipur, and is very good friend of mine. Please, sir, over to you.
Thank you so much, Sandeep, for your kind words. And let me start with the presentation. And I believe already we all are late and very few audience are left over. So I think we all should not feel like this is being seen in this picture, and we all are waiting for probably lunch early.
So my topic given is optimal molecular testing algorithm for epithelial ovarian cancer. And we will discuss briefly, these are the outline, and I'll try to cover up as fast as possible. We will be seeing that what to test for BRCA, MMR, HRD or HRR genes, why to test, whom to test, what to test, when to test, and what will be the sequence of the testing, germline or somatic, and what will be the implications on the therapeutic as well as the offspring of that particular patient. We all have learned that in ovarian cancer, the germline BRCA mutations are present in around 14% of total cases. And if we see non-BRCA HR deficient, that will be close to 33%. So this becomes almost 50% of these patients, they are having some sort of genetic defect if we pick them up early and if we pick them properly. I am thankful to Angelina Jolie, who has made most of us wise, and everybody is now tempted towards the BRCA gene and BRCA gene analysis and effect. And I think her contribution in this field is also great. So why to test? First foremost thing, why should we test for BRCA status? So the implications are, one is about the predictive factors. So the prediction will be that BRCA testing can identify women who are more sensitive to subsequent chemotherapy and especially the platinum sensitivity based on the treatment, or we can know that who will be suitable for the targeted therapy, the olaparib and rucaparib and other things, PARP inhibitors. Second important comes the prognostic factors. So BRCA mutation status is an important prognostic indicator along with the diagnosis at stage, and especially in histology, like we know about the endometrioid variant and the serous carcinoma, they have the highest chance of having BRCA, while clear cell and mucinous has got less chance. And this will help us in the extent of surgical debulking. Risk assessment, of course, we want to know about the BRCA testing, and we want to know the risk in the particular patient about if somebody is carrying BRCA, one may have breast and or ovarian cancer, and family members also, like many times we see that the sister and sister's daughters and others are having the same genetic defect. So chance of BRCA mutation patients are having more and more of other cancers also. So these are about the cancer risk that based on BRCA, the breast cancer risk is lifetime is 12.9%. And we can see that this is in the estimated lifetime risk in BRCA mutation. This is normal, and this is in BRCA1 mutation. This is BRCA2 mutation. And we see the ovarian also, the approximate lifetime risk in normal population is 1.2%, in BRCA1 40%, in BRCA2 15%. And we can see not only the breast and ovarian, but other cancers like prostate and pancreatic cancers are also common with the, are more common with the BRCA mutation positive patients. So the prevalence of germline BRCA1, BRCA2 mutation, this study has been done by Dr. Sudeep Gupta and a team. This is an Indian study, and they have tested the prevalence of this germline BRCA1, BRCA2 mutations and variants, because most commonly in our practice, now we have started, but few years back we were not doing the BRCA1, BRCA2 testing in patients, and we were feeling these are rare. But these are the Indian data. If you see the BRCA1, BRCA2 mutation, patients with pathogenic or likely pathogenic germline mutation, the incidence has been 21.3%. And patients with variant of uncertain significance is 4.2%. So almost 25% of patients are having mutations in the BRCA1, BRCA2. So probably we are not testing, so we are not wiser, and their implications also probably we are not able to understand. And various PARP inhibitors are now available with us for clinical use also. So if you see the comparison between other countries and the Indian circumstances, we can see that various labs from India have documented incidence of BRCA1, BRCA2 positivity between around 14 to 25%, 30% also. And we see that percent of family, the patients where mutation who have no family history has been in fact not known. And many times the lab is giving us an idea that what are the predictions of various other malignancies. BRCA1, BRCA2 mutation is not common only in the elderly person, but we can see in young female also. And in India, we see that breast and ovarian cancers are almost 1 decade earlier than the Western world. So in India also, we can see that almost 16.7% of patients with BRCA1 and 5.6 in BRCA2, almost 25% in less than 50 years, and around 20% in more than 50 years. So this is not uncommon mutation, and I believe that we all should test as and when chance arises. In the serous carcinoma, it is around 25%. In endometrioid, it is 10.5%. And clear cell mucinous, in fact, they rarely have any pathogenic mutation. So the implication is in serous and endometrioid, we should test this BRCA1, BRCA2. Then comes the association between family history of breast and or ovarian cancer and the BRCA1-2 mutation. So we know that if the family history is positive, the BRCA1, BRCA2 mutation positive status is more than 50%. In patients who are sporadic in nature, no family history positive, it is around 20 to 25% chance that person might be having a positivity. If you see the country specific guidelines, then these are different things that when should we test. The idea is most commonly it should be tested at time of diagnosis. Many times we do not test at time of diagnosis and we test at the time of progression of the disease. So the window period when we can start the PARP inhibitor is lost, in fact, if we do not test them upfront. So we should develop a habit that whenever a patient, high risk patient comes, we need to test them upfront rather than waiting for the relapse to happen and then to test. Ovarian cancer therapy treatment, we all know that these are various things available to us. Different type of chemotherapy, surgery, paclitaxel has been backbone, bevacizumab has been tried, HIPEC has been often on highlighted, and then next comes the PARP inhibitor. So these are various treatment modality. PARP inhibitors we usually forget in our armamentarium, and we should remember that this is also having good outcome. Next comes what to test, whether we should test the tumor or we should do a liquid biopsy or in the form of a blood. So germline or somatic. So because germline BRCA mutations are present in all the cells, which is present in also, it will be tested, it will be positive in the blood. Or if we see the somatic mutation, somatic will be present in the tumor tissue. So we need to test them accordingly. Then comes that whether the blood test will pick up less or if the tumor tissue can pick up more. These are various studies which suggest that frequency of somatic mutations are variable, and whenever possible we need to test blood as well as the tumor tissue also. So this is workflow analysis that non-mucinous, non-borderline, so maybe serous or endometrioid, we need to do a tumor BRCA testing. Tumor BRCA testing results are available. If it is negative, then we do genetic. If it is negative, then genetic counseling and the germline BRCA test should be done. If the tumor is positive, then we need to offer them PARP inhibitor therapy as well as we do genetic counseling. The advantage of picking up of BRCA1 and BRCA2 is not only for the patient but for their family members also. If some lady has got BRCA1 and 2 genetic mutation positive, her daughter, her sister's daughter needs to do cancer screening at earlier age, at least 10-15 years earlier than the normal population. So it will have an impact on the genetic counseling as well as the early picking up of breast and or ovarian cancer and other cancers. So it would be when do we see and what will be implication? We do a germline testing. If germline testing is negative, we can do testing in the tumor. If the tumor test is positive, then we do germline testing. So in fact, both are complementary. So one negative does not mean that the person may not have the other mutation. So maybe germline. So if we see the graph here, germline BRCA testing, if it is detected, then treatment decision changes and genetic counseling changes. If the germline BRCA testing in the blood is not detected, then we do it in the tumor. If the tumor is not detected, we forget this. If it is detected in the tumor, then we take the treatment decisions here. And I'm thankful to AstraZeneca for giving us coupons, and many times we are able to do BRCA1, BRCA2 testing free also for many of our patients. Then comes the value of deficient MMR or MSI high in epithelial ovarian cancers. And I think the incidence of deficiency MMR in serous cancer has been reported to be lower. This is the range 1 to 8%. And all these observation, it is it is said that routine testing for DMMR in clear cell endometrioid and mucinous ovarian fallopian, although testing may be advised. Then comes the StarCast and what is new in the therapy of epithelial ovarian cancers. These are various PARP inhibitors. Olaparib has been for many years, and these are the other drugs. And bevacizumab also is there with us. So if you see the clear evidence of benefit from PARP inhibitor, and not only like after relapse, but in maintenance also, and this leads to significant improvement in the outcome, and we can see with good hazard ratio. In the solo trial, we have seen the hazard ratio of 0.3. Olaparib it was 0.31, and other also it was 0.4, 0.44. So we can see that the olaparib definitely leads to improvement in the long-term outcome. This is about various other things. That HRD positive, we know that HRD testing is group of mutations being tested together. So if we see the HRD positive and if you use them olaparib, then we can see the progression and death. So we know that the median progression-free survival in the olaparib plus bevacizumab arm is 37.2, while placebo plus bevacizumab arm is 17.7. So it is more than double. In fact, we can see the progression-free survival at 2 years. And in HRD positive, excluding tumor BRCA positivity, that may be a germline tumor and the tumor may be negative. In that case also we can see the olaparib plus bevacizumab, the median PFS is 28 months, while in the placebo arm it is 16 months. So again in the HRD positive with the tumor negative for the BRCA, that also leads to improvement in the progression-free survival. And this denotes that HRD testing is important rather than only BRCA testing. Then comes the HRD negative. We see that in HRD negative, BRCA negative, the outcome is almost same. The progression-free survival is 16 months in both. So beyond BRCA mutation testing, mutated test is current HRD assay do not provide sufficient differentiation and response to PARP inhibitor. So statistics always plays a big role, and our statisticians are there, and we all doctors have got little weak in the statistics. So HRD is present in approximately 50% of high-grade epithelial ovarian cancer tumor, and these are the HRD. This is possibly HRD. So we can see that almost 50% of the high-grade epithelial carcinomas, they are having HRD mutation positive. And these are the BRCA1, these are the other mutations positive. So with the HRD group, we get various genetic mutation testing, and these are available with many of the labs currently to us. So to summarize, we should know what to test for. We need to test for BRCA1 and BRCA2, MMR, and HRD whenever possible, because HRD will give a broader spectrum of mutation positive BRCA1, BRCA2. Why to test? Because it has got prognostic significance. We can predict the behavior. We can know the risk assessment and screening of the remaining family members because they are at high risk to develop cancer. What test to be used? NGS is definitely better. Sanger sequencing is test better, but NGS platform is better. Whom to test? All high-grade epithelial ovarian cancer should be tested, irrespective of age, family history. We have seen that 25-30% patients are without family history. They are having the BRCA1, BRCA2. When should we test? We should test them at diagnosis rather than waiting for the relapse to happen. What sequence to test? We need to test in the tumor tissue first, so somatic testing can be done, and then it can be followed with the germline testing, which is done in the blood nowadays. What to treat if somebody has got a BRCA1, BRCA2 positive? PARP inhibitor maintenance is the treatment of choice, which is available to us, and we should treat them. So the optimal testing and sequencing and implications in the treatment is huge with BRCA1, BRCA2, and I think we are not routinely doing it, and with the increasing knowledge and more discussions, probably we will have more and more implication, and we will have more and more number of patients coming positive. So with this, I thank all the audience, and I thank Dr. Sandeep for giving me an opportunity, and any questions or comments. Over to you, Aditi.
Thanks, sir, for such a nice presentation. It was quite a very important topic, and you covered it very precisely and Great. Now I would like to invite Dr. Deepak Shukla, who is a consultant medical oncology at Manipal Hospital. So he would be telling us about one drug and many indication, olaparib CA ovary. Over to you, Dr. Deepak.
Thank you, Dr. Aditi, and thank you, Dr. Sandeep sir, for giving me this opportunity. I'll be sharing my slides now. Are my slides visible?
Yes, sir.
So I'll be speaking today on one drug, many indication, olaparib in CA ovary. So we know that ovarian cancer, the most common subtype is the epithelial ovarian cancer, which accounts for close to 90% of the disease burden that we see in the malignant type. Among the epithelial ovarian cancer, the most common type is the high-grade serous carcinoma. And typically, the epithelial ovarian cancer of this type is diagnosed at an advanced stage when the disease has present or spread to the peritoneal cavity, and usually present at an stage 3 at the time of presentation. And the current first-line treatment for these patients with high-grade epithelial ovarian cancer is a debulking surgery followed by a platinum-based doublet chemotherapy. And we know that though the disease is chemosensitive, most patients will eventually relapse and after achieving a initial remission. So like in other cancers, precision medicine had made its way in CA ovary, particularly in the high-grade type. And the BRCA and the HRD status represents the novel predictive biomarkers for response to chemotherapy and PARP inhibitors, as beautifully discussed by Dr. Lalit sir. And germline mutations in the genes BRCA1, 2 are related to increased cancer predisposition, and they account to close to 14% of epithelial ovarian cancer based on the Western data. And beyond BRCA1 and 2, additional genes are also involved in the homologous recombination DNA repair. And based on a recent study, close to 21% of the Indian patients have BRCA1, 2 mutation in newly diagnosed or relapsed epithelial ovarian cancer, and close to 50% did not have even family history to begin with. And the reason for the increased interest in these BRCA and HRD is due to the PARP inhibitor. So just to look into how the PARP pathway works. So usually in cells, DNA single-stranded breaks are occurring all the time, and PARP detects it and repairs it. During the replication process, the unrepaired double-stranded breaks in a normal cell in the presence of homologous recombination are repaired, and this leads to cell survival. In the presence of a PARP inhibitor, the PARP is able to bind at the single-stranded break but unable to perform its function of repairing the single-stranded breaks. So this leads to development of a double-stranded breaks, and in a cell which is HRD deficient, in the presence of this PARP inhibitor, this leads to a tumor-specific killing by the PARP inhibitor. And this is so no effective HR pathway is required for activity of PARP inhibitor as a basic mechanism. So I'll be discussing this topic under the use of olaparib under these headings. The first one is just how to assess or identify patients who can benefit. So this has been already been discussed by Lalit sir, but I'll like to highlight that HRD homologous recombination can be assessed at 3 levels. It can be at the input level, i.e. at the level of the genes. The most commonly that we study are the BRCA1 and 2. We can look into the output, i.e. the genomic scars that are present because of this defect in the homologous recombination. This can be measured by genomic instability scores or loss of heterozygosity. And now there are tests which can detect at a given time point what is the status of homologous recombination repair. This is a test, RAD51 foci test, is not freely available with us, and its exact clinical implication is not known. And what it requires is a fresh tissue, which is usually we are not keeping it right now. We assess the HRD from the blocks that are available with us. So possibly in future, we'll be hearing more about it. So as already discussed, we can assess the HRD at two levels, where at the level of the homologous recombination gene level, or looking at its effect, i.e. the genomic scores, the genomic instability scores of loss of heterozygosity. The most common testing at the gene level is usually, and that is very well validated, is the BRCA testing. And there are certain laboratory tests which have been very well validated and have been studied both in the first line and the relapse setting. One of the tests is the myriad my choice test. It assesses both tumor BRCA status as well as genomic instability scores, and it is important to keep in mind that it assesses loss of heterozygosity. It assesses telomeric allelic imbalance, large scale state transition, and based on these two, it comes up with a score. And in the first line trials, this test was done, and a genomic score of more than 42 or equal to 42 was selected as a criteria for HR deficiency. So as we can see, there is plenty of confusion as how to best determine which patients will be the best to benefit from these PARP inhibitor. And to clear some of this confusion, recently in the last year 2020, there is an ESMO recommendation regarding HRD testing. And what we can see from this table, that the most validated marker is the BRCA mutation in the germline tumor or somatic BRCA, and it is validated both in the first line maintenance as well as in the platinum sensitive relapse disease. If we look into the genomic scar assay, which looks into the effect of the homologous recombination deficiency, this can be measured in terms of genomic instability score or by the loss of heterozygosity. And it is important to note that the genomic instability score, the myriad my choice assay, which measures this, is both validated in the first line as well as in the relapse setting. However, the LOH, which in combination with BRCA is assessed by the foundation assay, has not been validated in the first line, but it has been validated in the relapse setting. And in India, we now have a number of laboratory developed tests which try to assess the homologous recombination genes other than BRCA mutations to assess the benefit of these PARP inhibitors. And it is important to keep in mind that the clinical validity of these assays is only marginal. There is no evidence in the first line that if these tests are telling us that the patient is having HRR gene mutation, then these patients are going to benefit from the PARP inhibitor, and possibly even in the relapse setting, the relevance in the clinical setting and the literature we have to offer PARP inhibitor is not great. It is marginal. So next, I'll be discussing how olaparib made its way into the maintenance setting of newly diagnosed high-grade serous cancer. So olaparib maintenance treatment has been investigated in newly diagnosed advanced ovarian cancers in two phase 3 study. The first one was a solo one trial. It enrolled patients who were newly diagnosed but required BRCA mutation, and other was the unselected group, the Paolo one. We'll look into the solo one trial. So this trial enrolled newly diagnosed FIGO stage 3-4 high-grade serous, ovarian, primary peritoneal, and fallopian tube cancers. They have to have a germline BRCA mutation in order to be enrolled, and they should have completed the standard treatment of cytoreductive surgery and followed by platinum-based chemotherapy, and they have to be in a clinical complete response or a partial response to be enrolled. And subsequently, these patients were randomized to olaparib 300 milligram twice daily or to placebo, and the olaparib was given for a period of 2 years. The primary endpoint was progression-free survival. If we look into the baseline characteristics of the solo one trial, these were well balanced between the treatment arms. As we can see, the trial mandated all patients to be BRCA mutated. The most common histologic subtype was the serous, and nearly 95% have their CA125 normalized prior to enrollment, and the primary tumor location was ovarian in close to 85% of the patient. And nearly 80% patients were in clinical complete response at the time of enrollment. So this Kaplan-Meier curve at a follow-up of 5 years is really impressive. And what this trial showed, that by giving maintenance in a BRCA mutated patients, there is a progression-free survival advantage of close to 36 months. And at a median follow-up of close to 5 years, close to 48% patients were progression-free in the olaparib arm as compared to the placebo arm. If we look into the common adverse effects of olaparib, these were predominantly GI disturbances, fatigue, and anemia. The second trial that looked into the role of olaparib in the newly diagnosed patient, this trial, and this was a Paulo 1 trial, it enrolled patients with stage 3-4 high-grade ovarian serous cancers. And these patients underwent surgery, and following that, they have to receive a platinum taxane-based chemotherapy. And this trial mandated patients to have received at least 3 cycles of bevacizumab. And this is the only trial among the other 3 upfront trials in which there was an active comparator. So once these patients were selected, if they were platinum sensitive, having complete response, no evidence of disease, or partial response at the time of enrollment, and they randomized patients to bevacizumab for a period of a year with placebo, or bevacizumab with olaparib for close to 2 years and with bevacizumab, and the primary endpoint was progression-free survival. If we look into the baseline patient characteristics, again, it was these were well balanced. And what is important difference between the other Solo 1 trial was that in this 30% patients were having tumor BRCA, while remaining 70% were non-BRCA mutated. And nearly 50% had an upfront surgery, while 42% had interval cytoreductive surgery, and 7% did not have any surgery. And majority of these patients were in near complete response, no evidence of disease, or CR at the time of enrollment, close to 75%. The main reason for discontinuation in this trial was disease progression. In the placebo arm, the discontinuation rate was close to 60%, and it was 34% in the olaparib bev arm. So this is the Kaplan-Meier curve of the whole population, and in the whole population as such, there was close to 6 months improvement in progression-free survival in the olaparib bevacizumab arm as compared to placebo bevacizumab arm, and it was significant. But if we look into the subgroup analysis, the majority of the benefit was derived by the tumor BRCA mutated and HRD positive patients, while the HRD negative and the BRCA negative patients did not derive any benefit, or the benefit was too small. And if we look into the forest plot, almost all patients benefited with the addition of olaparib to bevacizumab. If we look into the adverse effect profile of olaparib in Paulo 1, it was consistent with what has been previously reported. So these 2 trials led to the approval of olaparib in the first-line setting maintenance in BRCA mutated and select patients with BRCA or HRD positive in combination with bevacizumab. So one of the other areas where olaparib can be used is in the maintenance setting in relapsed platinum sensitive high-grade serous cancer. Let's look into the evidence. So the Solo 2 trial was the later of the 2 trials. In this trial enrolled or asked the question whether the addition of olaparib in maintenance will prolong progression-free survival in patients who have relapsed after 2 or more prior lines of platinum-based chemotherapy, and at the time of their last platinum chemotherapy, they were in CR or PR, and these patients received olaparib 300 milligram twice daily, the standard dose, till progressive disease, and the other arm received placebo. If we look at the baseline characteristics of this trial, the experimental arm and the control arm were well balanced, and as mandated by the trial, all patients were BRCA mutated. The most common histology was serous type, and the primary tumor location was ovarian. And nearly 60% of the patients have received 2 prior lines of platinum-based chemotherapy, and prior bevacizumab was used in close to 20% of the patient. And recently, last year, this trial has shown overall survival benefit of close to 12 months in the unselect, means in the overall population that was that just made significance, but it was deemed to be clinically meaningful. And if we adjust for the subsequent PARP inhibitor use, the benefit was close to 16 months. And again, the final safety analysis showed that the discontinuation of olaparib was close to 17%, and the rates of MDS and AML was close to 8% in the olaparib arm as compared to 4% in the placebo arm. And the treatment side effects were predominantly GI, fatigue, and the anemia that were seen. The second trial was a phase 2 trial, and this is the trial that is the basis of approval for olaparib in patients who are relapsed platinum sensitive, irrespective of the BRCA mutation status. This was a phase 2 trial, and again the patients who were enrolled were similar to what we have discussed previously, but they can be enrolled irrespective of the BRCA status. And this trial used the capsule formulation of olaparib of 400 milligram twice daily. And again, the drug was given till progression, and the primary endpoint was progression-free survival. And the study was positive with a progression-free survival benefit of close to 4 months. So these were the two trials that led to the approval of olaparib in maintenance in the relapsed platinum sensitive setting in the BRCA mutation and also in unselected platinum sensitive patient. In the third line and beyond, this is the phase 3 solo 3 trial that was done to confirm the benefit of olaparib as compared to chemotherapy in platinum sensitive relapsed ovarian cancer who are having germline BRCA mutation. So these patients again have to have received more than 2 prior lines of platinum based chemotherapy, and they have to be platinum sensitive at the time of enrollment, and they have to have a BRCA mutation. And the patient were randomized to olaparib 300 milligram twice daily and to a non-platinum chemotherapy. Based on the paper, they have mentioned that the reason for selecting the non-platinum chemotherapy as a standard arm was that after 2 lines of platinum chemotherapy, subsequent platinum chemotherapy has not shown survival advantage. So this was the reason for selecting the non-platinum chemotherapy arm as compared to olaparib. And the primary endpoint to begin with in this trial, this was a confirmatory trial that was required by the FDA for the approval. So initially, when the trial started, the trial endpoint was progression-free survival, but it was later revised to overall response rate. So if we see in the solo 3 trial, the overall response rate based on the blinded independent central review, the CR rates of 9% and a partial response of 63% with the overall response rate of close to 72% in the olaparib arm as compared to 51% in the chemotherapy arm. So just to summarize what I have discussed, that olaparib is the most extensively studied PARP inhibitor in advanced high-grade serous ovarian cancer. Combination of BRCA testing and HRD testing can identify approximately 50% of the patients who can benefit from PARP inhibitor maintenance in newly diagnosed high-grade serous ovarian cancer. And it is important to keep in mind HRD status is dynamic, and when we are ordering a test, we should know what we are ordering and how to interpret the result. And frontline maintenance olaparib in combination with bevacizumab prolongs PFS in HR deficient advanced high-grade serous ovarian cancer, and time will tell, are we curing more patients by giving maintenance? It will be clear over a period of time. However, olaparib maintenance irrespective of HRD or BRCA2 status shows improvement in overall survival by close to 16 months in a relapsed platinum sensitive CA ovary setting, and olaparib, as discussed, has a manageable toxicity profile. Thank you.
Thank you, Dr. Deepak, for such an exhaustive review of olaparib. It was very enlightening. Now I would like to invite Dr. T.P. Sahu, sir, who is a consultant medical oncologist at Chirayu Medical College and Hospital at Bhopal. And I would, sir, please invite your panelists.
Yeah, please let me share my screen. Allow me to share the screen. Okay, first things first,
I work in Silver Line Hospital. It's a small hospital. I'm no more a part of any medical college. So we come down to the panel. It's an exhaustive panel of 9 panelists. So request to all the panelists to be short, brief, so that we can finish in the next 25 minutes. Already we are 10 to 15 minutes beyond the scheduled time. Before we start, on behalf of the panelists and myself, I would like to thank the Zydus for giving us the opportunity, and hope the new drug does serve a purpose to a lot of the patients. So with that, I invite the panelists who the names are all there. Dr. Ashish, Dr. Chandrakant, Dr. Deepak, Dr. Krupashankar, Dr. Vindhya, Dr. Rakesh, Dr. Satya Srinivas, Dr. S.K. Verma, and Dr. Vaibhav Chaudhary. And I presume all of them are medical oncologists. I know most of them. So if anyone is not, they may speak out right now. Otherwise, this is a medical oncologist panel. Okay. So based on, now we start to the things. Now we have a arbitrary case. A 53-year-old female has come down to the OPD with surgery for cancer ovary done outside. It was high-grade serous, suboptimal cytoreduction done. No significant family history. So we will just skip this part and keep to the specific what we're the agent of choice. We'll leave it. Can I bring in Dr. Ashish Agrawal? What would be your investigations of choice? Let's leave that agent of choice. I'm not going to discuss that at this point.
So already is a high-grade carcinoma and suboptimal cytoreduction there. I will go for the BRCA1 and BRCA2 testing. And
so you want to go for a BRCA1 and BRCA2?
Yeah.
Okay. So Dr. Kripa, any specific subtypes on which in the ovarian cancer you will go for a BRCA, or you would like to do it for all comers in the ovarian cancer now, irrespective of histology?
So yeah, hi sir, first of all.
Hi.
And so yeah, I would definitely like to do it for all comers, sir, because we have the recently published data from India as well, like from Professor Sudeep sir as well, where even non-serous tumors and people without a family history have also around 20 to 25% have had BRCA1 and 2 positivity. So I would offer it to all comers, sir.
Okay, Rakesh, Kripa is telling he would offer it to all. If I play the devil's advocate, I tell no, I would not offer it to some. Am I right in selecting it? Because all of these tests come with a cost, come with the genetic counseling. What do you feel is the right thing?
So I think apart from the cost, the social factor also should be factored in. Not every patient is willing to do the BRCA testing.
Let's assume everyone can afford it. Do you think that it should be done for all, or it should be for a select subtype?
So I personally feel it should be done for all.
Okay.
And most of our patients who have a family history at least.
Okay. Anyone in the panel feels that I would not give it and offer it to anyone particular? Anyone who has not spoken till now? Yeah.
Mucinous variety, I would like to avoid, sir.
Okay, Vaibhav, you would not go for mucinous variety. Okay, I somehow concur with Vaibhav. I feel the data for mucinous variety, if you look into the data and look at every PARP trial, all of them usually have taken this high-grade serous and endometrioid variety, apart from the primary peritoneal carcinoma. But mucinous by per se, the data in the literature is around 0 to 2%. So you would nearly not find a BRCA mutation in this subset. And that is why you would not find trials who have included this, irrespective of, you take a rucaparib trial, you have a olaparib trial, you would have this subset of patients who are serous or endometrioid. And that's what it is. And all of them would be high grade. That's how we agree. I think there could be debate on this, but I think this is where it is that most of us believe that they would do for all comers. But people like me and probably Vaibhav and some of us believe that we will filter out someone who would be a mucinous variety, probably because the chances of getting a positive BRCA or a HRD would be much, much, much lower on that. Anyone wants to say something who has not spoken? Chandrakant, your final view on this. Then we move on.
Sir, what about stage 2B, stage 2C?
Okay, so now we stick myself to histology and then we come to stage at some point if the time allows us. Histology first. Histology. Do you feel you would also agree that you are also for all comers? So Vaibhav, you and me are in the minority, but we can stand our ground because science also always tells us that mucinous is a variety which would not have a lot more BRCAs. It is, many publications have told it's nearly zero. So we can argue it on a later point of time. But the point that is coming from all the panelists is all of them would be interested in BRCA, mostly in serous and enumerated, definitely all of them. Some are not ready for mucinous. We stop here and go to the next question, and I would like to have Deepak coming in. Dr. Deepak, you test for BRCA. Do you test it for germline or somatic, or how do you do it? Quick, very short answer.
If block is available, then usually we do it on block, somatic mutation.
So can you stop you here? You would prefer a somatic, that's what you are telling, because in the ovarian cancer, where surgery has been done in most of the cases, you would have blocks and sufficient blocks. So is it that in all cases it will be somatic for you?
Yeah.
Okay. So Deepak, it is for somatic. I'll come back to you on this later on. Let me get everyone in. Dr. Vindhya, somatic versus germline. Do you feel that somatic versus germline, there is a difficulty in the testing parameters? The parameters are different. The somatic is not that validated in our country. So I would go for germline. Can you speak something, or do you feel you would be comfortable doing somatic? Because most of us do germline at this point of time, and very few I don't think would be doing somatic. What is your take on that?
But on the contrary, of late we have been doing more of somatic, especially not only BRCA, we have been doing the HRD testing. So I would prefer
you are
somatic.
Doing from the Indian labs, the HRD testing. That's what I presume, or you send it to Foundation Medicine or the
No,
Marriott?
Indian labs. Indian labs.
Okay, so Kripa, now I bring you in.
Yes.
Now I have 2 points here. One is the HRD, which I wanted to take later on. We'll keep that for the later 1 or 2 minutes later. I want to bring in you for the somatic versus germline. With all of us, none of us are lab specialists here, but with the little knowledge we have, do you feel the technique is same and it can be done by every lab who's doing a germline, or somatic would require little more validation and expertise?
Definitely, sir. I'd agree with that, because the somatic mutations requires a different standardization, and the technique is definitely different as well. So definitely there are practical issues with actually applying the somatic mutation analysis. But having said that, I would say around 10 to 15% have germline, and around 8 to 10 will have somatic, and another 20 to 25 will have HRD. So probably from a therapeutic point of view, somatic mutations also would matter, because I would still be able to use my PARP inhibitors there.
Okay, Dr. Verma, I come to you. Can I presume that to tell that most of us would go for somatic, as Dr. Deepak and Dr. Vindhya told, but the technique is still not validated? To my best of my knowledge, I feel labs are still picking up on the somatic technique, as Krupa alluded very rightly.
Yeah.
So should we be giving testing to these labs without validation, because these are important tests? Everyone claims to do it. So what is your take on that? Because Krupa picked up a very important point, that another 8% of patients on somatic will pick up. So what do you have to say on that?
Absolutely correct. Just in case there be minority of patients where there is a strong family history, then we can go for germline also at the same time.
That you can.
Yeah.
So basically that point is, people, you have somatic anyway, you have to go to a germline testing and counsel the patient.
Right. Yeah.
So I will take this point that all of us agree that somatic picks up 8 to 10% more of mutations, so you can find out 8% more eligible patients. Point number 1. Point number 2, people are using somatic, but I feel we need to look at this validation much more carefully. There may be labs who may be doing it. I'm not aware. I'm not vouching for anyone. To best of my knowledge, I think that is still lacking in the country, and that should be looked up very, 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 very carefully. So with that 2 things, that somatic is required. The last important thing that I can take up of the somatic is one more thing. Once you have done a somatic test positive, the point that breaks out is then only those who are positive only can go to a genetic counselor. Dr. Satya Srinivas, do you feel that will be a helpful thing? Because genetic counselors qualified are very less in the country today. So that would lessen the burden. Only those who have a somatic mutation only will go for germline, and those patients only you will send it for a genetic counseling. Dr. Satya, what is your take on that? Because the genetic counseling part is very important if you're doing some tests like a BRCA.
Sir, definitely, sir.
Okay, so you concur with that. Okay, so now we go to the next part of it. The NGS or MLPA or what technique? Weber, which technique do you read into the technique? Do you ask the labs or you go with a free coupon that is just provided?
Most of the time with the free coupon, because obviously cost is an issue. But
Okay.
obviously, I would prefer NGS slightly here, because HRD again will be done by that. And I usually, to my patients, I counsel for both BACA as well as HRD. So I go for NGS.
You go for NGS. So now we have Weber going for NGS, and coupon and no coupon. I feel olaparib or any drug is such a costly drug. If you ask the patient who can afford that drug, can anyway go for the testing without the coupon also. It's just a matter of fact, we are getting the coupon, so we use it. So Dr. Chandrakant, your take on NGS alone, or do you feel that there is problems and we need to do the MLPA testing also along with that, and we want to make it sure your test report has both the techniques? Chandra, you're there? Chandrakant, you're there? Dr. Ashish.
Hello?
Dr. Ashish, can you take this? I think Chandra, we have lost him.
Yes, sir.
So till he comes in. Yeah, Chandra, please. NGS
Sir, I didn't
alone.
get you, sir.
Yeah, is it NGS alone or NGS plus MLPA?
Sir, NGS is sufficient. At least.
NGS is sufficient. That's a very strong statement to come out from Chandrakant. Let's see how good he is. Ashish, what is your take on that?
So in our setting, we do with the NGS.
Okay. Okay. So you do with NGS. Okay. That's fine. That's fine. Most of us do with that. Dr. Vindhya, do you see, and because you told you sent a lot of this stuff for testing, have you looked at the reports? It is only NGS or you ask for MLPA also?
It's only NGS.
Okay. Kripa, coming down to you. Yeah. Why do you think, because I am the devil's advocate here, why do you think I will ask for MLPA? I will ask for it. Why do you think I should? Am I wrong?
No, absolutely. I would concur with that, sir. I would also definitely ask for an MLPA, because the multiplex ligation dependent probe assay actually helps picking up those large insertions and deletions, which can be missed on an NGS as well. So for me, it really matters. I mean, like, I cannot afford to miss out on somebody having a BRCA mutation by not doing an MLPA. So if at all I'm going to do it, I would definitely do it on an NGS with an MLPA as well.
So Rakesh, you do in your Indo-American, what do? You do NGS alone or NGS MLPA? It's very important. We should know to read the test. That's why I'm spending so much time here.
So we do it both ways, sir, both NGS and MLPA.
So that's how you would not miss those large genetic rearrangements. That's what it is. That's what MLPA. So basically, why we should be doing at the MLPA is, both of the panelists have rightly told, in the NGS, you might miss this large genetic rearrangements, which are a large base pair deficit beyond 20, sometimes you miss. And those are not amplified, mainly, they are not sensitive to catch this. But a lot of the new NGS techniques have included that in their armamentarium. The MLPA, that's what is happening is that MLPA picks up, and there's a PC, and then for picking up those large things, you need a PCR technique. So MLPA, if you add to NGS, you would not be missing this large genetic rearrangements, which both the panelists rightly picked up. Because when you do this testing, you don't want to miss anyone. As you told, you do the somatic also. So it's perfectly okay. And I feel that is the way we should be pushing this lab to do both the tests for us, the NGS and MLPA. All said and done, the Sanger's technique is the best gold standard still to pick up these single nucleotide. The only point is it is time consuming, does not pick up the large genetic rearrangements. So now we stop here on the BRCA, go to HRD. Vindhya, I come to you first because you spoke of it. You send a lot of HRD. Now tell me, HRD, which technique, what is your cutoff, and how do you read HRD report? And why should I do HRD report? Practical. What do you do, because you do HRD? I have not done HRD till now. I did one. I send it to foundation actually.
I just use the coupons which the AstraZeneca people have given. So there is an HRD test in that. They basically look at all the genes, all the HRD related genes, the 14 or so genes. They don't give a score, the typical foundation one score kind of a thing.
So how would you interpret that then if you don't get a score?
They give the mutation status of all the relevant genes. So based on that, we take a decision.
Dr. Satya, now Srinivas, coming to you, HRD without a score, and Indian labs, do you know any lab which is validated for HRD testing? Anyone? Dr. S.K. Verma, you want to take this? If Satya is not there?
Yeah. The score around 16 and above is the...
Okay. Dr. Ashish and then Dr. Chandrakant on HRD. Dr. Ashish, then Dr. Rakesh. On HRD, then we move.
If a BRCA mutated, then I will not go for HRD. But if wild type BRCA, then I go for HRD. Obviously.
So you want to do the two tests. You want a BRCA first, then if it is negative, then you want to do for HRD. That's how your technique.
Yeah.
And do you do HRD in your practice as of now?
No, sir. No.
No. Rakesh, you are in a rich hospital. You must be doing it. Tell me.
No, sir. I'm only doing germline mutations for the BRCA.
Or not.
And if it is negative, if we don't find any BRCA mutations, we stop there. I'm not doing any HRD testing.
Okay. Can I ask Deepak? Dr. Deepak, do you do HRD?
Yeah.
And would you like to do HRD? And what is the cutoff?
No, we are not doing. I'm testing for BRCA only.
Okay. Kripa, last word to you on this.
Yes, sir. So I have done it for a couple of my patients, sir, but I don't send it to any of the Indian labs because, like you rightly said, none of them are standardized yet. So I do it only to my choice Myriad Diagnostic CDX test.
Okay.
So that's outsourced through Core Diagnostics. But anyway, I look at the genomic instability score, which actually looks at three components: the loss of heterozygosity, the telomeric allelic imbalance, and large-scale state transitions. So based on this, if I have a cutoff of more than 33, then I would say they are HRD.
So basically, you are believing that 42 can be put down to 33, and the score of 33 is fine because that has shown that you are not missing out anyone.
Correct,
and someone who is doing and looking at LOH, the trials with Rucapari were told beyond 14% is what they are looking at the LOH. Correct. Okay, so with the take home for HRD will be Indian labs need to do a lot of catch-ups. We would be much more convinced with a lot of data coming for them for validation. We need a score. Because HRD beyond a particular score makes sense, because if you're doing HRD positive, you really encompass the BRCA things also. So with that, I now skip to the main point of treatment. So in a patient who's BRCA positive, I'll skip this slide because this has been shared by Dr. Lalit, that tells you that the Indian data has been anywhere from 20 to 30%. It has been across South and North India. That's where the BRCA positive is. Australian reports have shown to be around 14%. The Indians, we are 20 to 30%. So now, the options, the patient took paclitaxel first line. The patient did not take bevacizumab, did not take any PARP inhibitor, the patient who was in question. After 1 year, there was CA125 rise. I'll make things better. There was radiological evidence. Don't go by the slide. There was radiological evidence of progression. So now we have a progression that has radiologically advanced. We have a BRCA mutation positive, a germline BRCA positive. So with that background, what is your protocol? Dr. Satya, then Dr. Deepak. Which one would you choose? Dr. Satya, you are there? Dr. Verma, which is your protocol?
So chemotherapy followed by PARP inhibitor.
So chemotherapy, a platinum based, and
platinum
followed by
based.
a PARP inhibitor. Dr. Deepak, you concur. You shook your head. So I think that's the answer. Okay.
Yes.
So I think all of you would go for that. I am not going to repeat with that. So now coming to Rakesh, which PARP are you going to do for this particular patient who has failed 2 lines of treatment? And what is your choice? Be practical. You have all the options today. Now.
So the response to chemotherapy is at least partial response.
Yes.
CA125 is normalized. I will go with Rucapari.
You need a normalization or decrease is enough, because that is again a strong statement you're making to the panel. Normalization versus decrease.
Sir, I think normalization is what I would prefer.
Okay, so if it is not normalized, you would not prefer a PARP in spite of having a response?
So in spite of having a response, if the normalization is not there, probably I'll go for something which is not Rucapari. I think the data with Rucapari is to have a normalization of CA125 at the time of enrollment.
Okay, so that's how it is. So Chandrakant, are you so rigid on this criteria, or you feel a minimum of no progression with a platinum is something which you tell it's a platinum sensitive, and then you will choose a PARP? Chandrakant, somehow we miss you always. Ashish, can you take this? Vaibhav, your take. Would you be looking at this data, or would you choose any of the PARPs even if the CA125 is not normalized? You can go for any one of them, or you would go with the criteria very strictly. Vaibhav?
The PAP actually.
Vaibhav. You will go with
any of the PAP actually, not a specific.
So you so basically you look at the platinum sensitivity and then go with any of the PAP. Okay, Dr. Vindhya, what is your take? Because there is a little bit dichotomy and that's building up here.
Yeah, I will go with PAP, maybe olaparib, because rucaparib, the trial specifically says that they have to have a normalized CA 125. So maybe olaparib.
Okay, so Dr. Krupa, what is your take on this?
So yes, sir, I would believe that if the patient has had a partial response, I wouldn't actually wait for normalization of CA125. Just a drop in CA125. If they start responding, then I would put them on a PAP inhibitor maintenance.
Okay, I also feel that way, that the basic concept that comes through the trials would have the small intricacies. The point take home should be that they should be platinum sensitive. That's what all of the trials are pointing out to, and that's what Vaibhav told, Krupa told. I also feel I would also do the same. A normalization or an upper normal decreasing trend with a response on radiology should be fair. So now, if you're there, Vaibhav, you told, can you tell me which part? Because there are now two PAPs.
So it depends upon the accessibility. There is hardly any difference in the data of all these things. Depends upon the accessibility. I will choose either olaparib or rucaparib.
Okay. So any differences how you choose the drug? Rakesh, let's assume for your presumption that this patient has achieved normality of C125. Would you choose any of these PAPs because you have data from all the three drugs? How would you choose that? And let's expect that even the niraparib is available in India. How would you choose? Because that is the problem area that is going to be there.
So if the patient has taken any bevacizumab during the initial platinum sensitive disease, I'd probably go with olaparib plus bevacizumab as maintenance.
Okay. Would you now extrapolate the first line data with the second
Yes,
line because you are so strict with the CA125 thing?
No, sir. It's trial design. That's how it is being designed, and I think the trial design definitely has some value on how.
So if there is a bevacizumab to it, because there is data, at least some line that first line olaparib plus bev data is there, you would go for that. That's your thing. If bev has not been used, which one?
If bev has not been used, I think the rucaparib and olaparib are equally good enough for a BRCA mutation patient, and for a non-BRCA mutated patient, even niraparib is also an option.
Okay. So, Dr. Ashish, would you mind? Ashish telling he is a network issue. If Ashish is not there, Chandrakant, you are there. You are there because you were not there some time back. Okay, Dr. Krupa, how do you choose a PrEP? This is the main thing of crux of my moderation. For next 2-3 minutes, we'll discuss this, then skip to the last slide. How do you choose a PAP? Because this is the important part.
Definitely, sir. I think we've all had, some amount of experience with using olaparib until now. So that's one major point for me. And also, it's also been one drug which has been studied for a longer duration as well. And also the first in its class, as far as in the platinum-sensitive relapsed ovarian setting, to actually show an improvement in overall survival as well. So, we had the data from the SOLO-2 study around 13 months improvement in overall survival. So, yes, sir. So I would probably tend to go with olaparib here.
So now, with experience, you would go for olaparib. Sure. Any other criteria, Dr. Verma or Dr. Vaibhav? Any other criteria which you want to look? Dr. Verma first.
We have very little experience of olaparib, so we would like to go with that.
Okay, that's fine. Vaibhav, any way how you choose these PAPs?
Yeah, sir. Actually, in the setting I work, actually olaparib is prohibitively expensive. So rucaparib offers similar state of success rate. So I will go with whatever is cheaper. Sometimes I do get olaparib very cheap.
So first is you would go. So experience is what counts. What you've used because you're very comfortable. Second thing that's coming out of the panel is the cost. If both the drugs are equally efficacious, nearly the same efficacy, the hazards nearly same. We all believe it's a class effect. We will go with the cost. Dr. Deepak, any other thing which you feel can modulate your things? How you should choose your drugs, Dr. Deepak?
Everyone agrees that we have more experience of olaparib till now, and rucaparib is new to us.
We spoke of experience.
We don't know about rucaparib experience-wise, but because as you said, it is a class effect. Then I think cost remains important in choosing the drug.
Two more things which come to my mind is toxicity. If someone had a very bad experience of thrombocytopenia prolonged in the chemotherapy, niraparib is not a drug which you would like to go for, because that is a drug where the thrombocytopenia is a major side effects. Both the olaparib and rucaparib has lots of hematotoxicity with anemia, especially. The OD dosing is a plus point for niraparib. So what I feel is we have to look at the dosing, we have to look at the cost, toxicity, patient profiling, and then we have to look at the experience. That's the combination of all the four probably is going to be the way how we can take it away, ahead. Dr. Vindhya, your question to you. Would you use for a BRCA negative any of the patient, any of the drugs, Nira, Ruca or Ola?
No,
BRCA HRD negative, because it is for all comers. The approval is for all comers for most of them. What do you feel?
I would not prefer to use.
Okay, for a hazards of, tell me now, if a breast cancer protocol gives you hazards of 0.58, which protocol will you not give? If you look at the hazards for a HRD negative and PFS or something which is negative, the hazard is 0.58 to 0.6. Tell me one protocol in the immunotherapy, you all give immunotherapy with the same hazards. What is not so convincing about these hazards that you are still telling no? Or is that the hazards are comparatively looking poorer when you look at the HRD positive or a BRCA positive? That could be also another way of looking at.
In one way, the all comers have not been separated into the specific BRCA wild type. They have just been included.
They have been. No, they have been. All the trials have included the forest plot looks at that. Kripa, can you take this question and we move forward?
Yes, sir. So I would definitely explain to the patient that the magnitude of benefit may not be as much as that you would expect to see in a germline BRCA mutated or in a HRD, but I would definitely offer it as an option. If cost is not a constraint, definitely yes, sir. I would look at offering it in anybody with a platinum sensitive relapsed ovarian cancer.
So point that is made is, if you look at it, the benefit of a BRCA negative and HRD negative is around 3 months on an absolute terms, 2 to 3 months across the drugs. If you look at the positive, the advantage is 9, 12 to 20 months. So that is the basic difference coming is the quantum of advantage. The hazards, if you look at it, is very impressive actually. With these hazards, we have started immunotherapy lesser hazards than this. It's probably the options that are there, and we feel that the drug is toxic because the drug has 30-35% dose reductions. 8% in all trials could not take the drug that you've taken out. It comes with a cost. So basically, you have to weigh all these things. Dr. Vaibhav, is that a fair comment to make? Vaibhav, you are muted. You are muted. Vaibhav.
Yeah, I'm perfectly fine with it, sir. Actually, but the only thing to consider here is, as per the trial, we need to be platinum sensitive. Because
that's true.
Yeah, that has to
all of them had to be platinum sensitive. Yeah. So one more thing I want you to comment, because you are there. Please don't unmute, don't mute yourself. One more thing which I feel is the advantage is the duration on which the patient does not progress. And all of us know platinum sensitivity matters in prognosis. If I have even a 3 to 4 months further delay in the progression, and that can make my patient further platinum sensitive for my next line of therapy, does it not matter to all of us?
Yeah, very important point, sir. You actually just nailed it there. That the further we move from the platinum therapy, more sensitive we get, and more options are open there. So we can actually use the platinum doublet again. So obviously, it will translate into overall survival whenever the data will come. We just need to wait.
So I think this is a very important point which I felt that this data is there for the for subsequent therapies that has come from RUCA. If you look at it for the platinum-based chemotherapies, first subsequent 46% versus 38%, 8 to 9% patients more could give platinum. And so if you look at the quality, Ashish, you are back because you had a network issue. Dr.
Yes,
Ashish?
Now I'm back.
Yeah, sorry. We missed you. So quality of life, do you think that because the toxicity is there, we spoke of 8% myelodysplastic syndrome. So mind you, PARPs do not come without this complication.
Yes.
Do you think the quality of life will be important? And do you think this PARP inhibitors increase the quality of life if given in the first or second line, whatever it is?
Obviously, quality of life matter in the oncology setup, because and the PARP inhibitor, obviously they give good quality of life compared to chemotherapy.
So exactly that's what Ashish is telling, and that is what the data is, that all PARPs do make the quality of life better because they're controlling the disease better. Last, beyond second to third line, anyone has experience of PARP inhibitors in subsequent line? Dr. Deepak, your experience. Dr. Chandrakant, if you're there, quickly. This is the last slide, actually.
No, I've not used.
Okay, so you have not used. Anyone in the panel has used PARP inhibitors in the third line, because when it was not there in the 2 to 3 years prior, all of us have used PARP inhibitors in third, fourth line. Anyone? Dr. Vaibhav or Dr. Krupa, what is your experience on that?
Sir, honestly speaking, I have not used, because most of the patient actually become very toxic after 3 lines, and financial toxicity is also there with this drug. So
Okay,
honestly,
so you have not. Yeah. Krupa, what is your experience on third line?
Sir, unfortunately, I haven't been able to use any until now in the third line, sir. I've used it beyond in the fourth line, but not in the third line.
That's okay. Beyond third line, let's say. So you have used it much further down the line. That's true. So how has been the experience?
So the patient that I had, the patient actually experienced a lot of anemia, requiring blood transfusions as well, sir. So I had to come down on the dosing. Started off with 300 BD, then had to come down to 300 milligram once daily, sir. So
and the patient did well with that?
Yes, sir. The patient went on for about 13 months.
Oh, that's terrific. That's terrific for a fourth line therapy. And the main point with olaparib, rucaparib, and PARPs with the anemia is you have this anemia in the initial part of it. After 2 to 3 months, the anemia starts settling down. That's also a very important part all of us need to remember. For rucaparib, there is a data Ariel 2, which is a part 1, which is platinum sensitive, part 2, which is platinum insensitive. Just to make it, they gave it in all comers who were platinum sensitive, but the best advantage was in the BRCA mutation or the LOH high. And if there was statistical significance, the hazard was 0.27 when compared to those who were not BRCA positive or did not have LOH. So to mind you that you may give it to all, but the advantage is predominantly in this subset, as all the panelists have pointed out. But at this point of time, we have to offer it to our patients. Let them decide, but tell them very clearly the quantum of benefit could be very low for those patients who do not have these mutations or the HRD, but you could make them platinum sensitive for the next cycle. That's what I feel it is. Last, very important, rucaparib panel, I want to ask you, they don't have data for first line. Rakesh, would you use rucaparib in the first line, as you told you would use the extrapolate the data of bevacizumab and olaparib to second line? Would you use rucaparib in the first line? Because now we have both the agents.
I think we should be using, so I think there's no reason why it should not be used. It is very difficult to have a data again. There will be never a data again. So I think olaparib has shown a good benefit as per solo trial, and I don't think so any reason the rucaparib should not have the same effect.
So because olaparib, veliparib with chemo, and veliparib after that, and niraparib all have shown a beneficial effect in the first line. So you feel because the class effect, we can continue doing that in this. Anyone in the panel who's a very purist form of things would not like to use it in the first line because the cost difference is going to be huge. The market is definitely going to change. That's my take. That's my feeling. Anyone? Vindhya, what is your take on this?
I would use it, sir, in the first line, though there is
You would use it. Okay. Deepak, would you use it in the first line, or would you preserve it? Yes.
No, I'm in for that.
Yeah. Yes, I advise for maintenance therapy.
Chandrakant, you are there, or we have lost you forever? For this panel, definitely. Not like in that sense.
So he's not can I just make one more comment?
Please, Rakesh.
I would use it in BRCA mutated patients. So that's what I want to say.
Yeah, you will use it in the BRCA or the HRD. That's we make it that in the eligible patient. Yeah.
Yes.
Fine. That's fine. That's fine. Satya Srinivas, when would you use this? Do you agree? First line rucaparib, you would give a try? He's not there. Kripa, last word. I think I've covered all that.
Yes, sir. Probably if the patient can't afford olaparib, then probably I would like to offer them rucaparib. But still, my first choice would be olaparib. Yes, sir.
So you would give niraparib or olaparib as a choice. If they cannot, because of financial reasons, you would not be uncomfortable using rucaparib. Is the framing of words right?
Yes, sir. That's
to the patient.
Yeah, Deepak, you want to say something? Yeah, please.
Yeah,
please.
I want to ask that. Okay, we are comfortable with the rucaparib in first line, but because there is no data and it is not included in guideline also, so what the legal aspect of that?
Okay, what is the legal aspect of that? Anyone wants to take it? I think what I would feel that I would document the class effect. I would document the patient that olaparib is the first choice. I'd leave it to the patient that patient has taken a choice, be informed that it is a second line approval. But because there's a class effect, I as a doctor would like to tell that I can offer it, but it's your choice at the end of the day. I think that cannot be more fair thing than this. I have the last thing. Maintenance is there always. BEV alone or BEV with PARP or PARP is the only thing we want to do. And with that, I really thank the organizers are bombarding me with time is over, time is over. And we already have the organizing secretary on the frame. So with that, I thank Zydus. This would have made them very happy. The panel feels very positively for them. And I thank the organizers. I thank the panelists on behalf of all. I thank everyone for giving us the opportunity.
Thank you, everyone.
Thank you.
Thank you.
Thank you, sir. Thank you very much for a nice and extensive debate and discussion. Really, I always enjoy your this type kind of moderation and your anytime any presentation. Really, it was very informative to us. So coming to now end of our this conference and session. Really, it was great, successful. I let me congratulate all our national faculty and our all participants for this grand successful conference. And in this 2 days conference, we had received around 935 registration in this conference, and more than 125 national faculty participated in our 2 days program, and they did a great job. And we all know, we are witness that what the kind of what the level they showed in this presence. And just we have seen the TP Saucer's presentation, and each and every moderation and each and every presenters were like this, and one to one, one above one. So I am very much thankful to all our delegates, faculty, and our associates who have participated in conference. And really it was great experience for me to organize this conference. But somehow it is not a one-man show. That's why we have a whole team with us. And I have 4 directors, Dr. Chirag Desai, program directors who nicely constructed and restructured this conference, and Dr. Chirag Desai, Dr. Ajay Bafna sir, Dr. Satya sir, and Dr. Bharat Vaswani. Really, they did a very great job, and day and night they worked very hard to construct and restructure this conference and frame this conference, this meeting, today's meeting. And I also very much thankful to our MICE idea, Dr. Mr. Rajesh, Mr. Nitesh, Rambabu, Pankti, and their team. And they did a very hard work, and they really am very much thankful for smooth conducting smooth this conference, today's conference, flawlessly and without any interruption. And as we know, no one can be conduct successfully this kind of conference without financial support. And really very much thankful to our all pharma companies, our all who have participated and bring the delegates and bring the speakers. And they also worked very hard for us. And with all these words, I conclude this conference, and I invite all of you in our coming conference in October. As you know, this is also well-known conference, Precision Oncology and IBCC. So I again thanks to all and welcome. I invite you and request you to participate in our next conference. Thank you very much. Thank you to all of you. Thanks.